Good morning, sir. Sibu ആണ്. I am Sibu.
Yes, good morning.
Good morning, sir. First two presentations, first one and two are not there. It is starting with Dr. Daya Vaswani.
Okay.
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 Because first presenter has not submitted the slide. Second person has withdrawn.
Okay.
Okay. Jayakumar will be joining immediately. I had called him.
Hello. Can we start? Dr. Jayakumar has not joined.
Sir, Dr. Jaykumar has just joined, sir.
Okay, fine.
Dr. Jaykumar, can you have your camera on, please?
Good morning, Dr. Jayakumar.
Okay, shall we start with the first presentation, sir?
Oh, please, please.
Right, sir. So we are starting the PPT now, which will run for 2 minutes.
Okay. Understood.
Sir, sorry to say, this speaker has not yet joined us, sir.
So we
He
won't be
said
able
he
to.
is joining us. So
Okay.
we'll see if he joins up. We'll take the discussion a little later, sir, for this case.
So we will call the next person.
Yes, sir. The next one is ready and joined, sir.
Who's the next person?
1 second, sir.
Okay.
This is Dr. Shustri Valad.
Okay.
Right. So we are running the presentation, sir, now.
Fine. Okay, Dr. Susti, it is a very good study with a very long follow-up up to 10 years. Congratulations. It's a very good study. I wanted to ask you why the outcome is not very good in juvenile mitral stenosis because you find restenosis is much higher compared to the adults, people who had PTMC done beyond the age of 20 years. This is something described even earlier also, even at the time of closed mitral valvotomy. Why do you think is the difference between juvenile and adult mitral stenosis?
Sir, I think that it is because of the recurrent rheumatic reactivation in the juvenile patients, which leads to restenosis earlier than compared to adults. When we have seen the first rate of restenosis in juvenile patients is within 5 to 6 years. 6 years was the mean restenosis rate, but in adults the restenosis rate, the time average time was 10 years.
But they are all on secondary prophylaxis. So do you think they are getting recurrent rheumatic reactivation and that is responsible for that?
So this was the one hypothesis we had proposed that probably this was the reason. The other reason could be that in juvenile mitral stenosis patients we use a smaller balloon size
Okay.
to the PTMC when compared to the adults. That may also be one of the reason. Even in our study also there was significant difference between the juveniles and adults, but
Okay.
it didn't predict the restenosis rate when on multivariate analysis.
Dr. Jayakumar, please.
Uh, in the juvenile group, uh, about 7 9% of patients had a previous BMV or a CMV, right? Not 10%, isn't it?
So
Hello.
I could.
See, in the
Sir, we are
juvenile
not
group.
able to hear you very well, sir.
Hello. Am I audible now? Hello.
It's not clear, sir.
Okay. Question, I can go ahead. I will change my microphone and log in back.
Okay, say in the juvenile group, do you have a group, below, say, 50, then 15 to 20 or something like that, so that you can tell that people who are younger, the outcome is still worse because the definition of juvenile myelostenosis is a little arbitrary.
Yes, sir.
Some people take 18 years, some people take 20 years, some people take even younger age. So if we think that group itself, can you tell that the younger the patient, worse the outcome? Or
No.
do you have a
Meaning I had to
Sir,
log in back again
in our
to.
study, the youngest
Can you
patient
hear
was
me?
8 years,
When
but
yeah.
we have not
Just once again.
particularly analyzed that this one,
I'll
sir.
change my device. Yeah.
But the age also was one of the predictor for restenosis.
Just give.
I
Tell
think it's
me.
worth looking at that point.
Yeah. Yeah.
You have now below 20, 20 to 50.
Okay.
Above 50, you have mixed.
Okay.
But even that, up to 20,
So you're not, your voice is not audible, sir.
you,
Okay. No. 940.
am I
Your,
audible? Dr. Sudhi, am I audible?
yes, sir, yes, sir, you're audible.
466
Okay, say I will just suggest
06.
that you can look at a study
ABCD1.
within
Okay. Okay.
like
Sir, again,
15, 15 to 20, something like that. Okay, anyway, it's a very good study with a good follow-up, and I think probably this is one study with the longest follow-up available. So
yes,
well
sir.
done.
Up to 2 years
Congratulations.
follow.
Okay, good.
Sir, Dr. Daya Vaswani, the first speaker, has joined us. Sir, shall we finish the discussion for her?
Oh, sure.
Right, sir. Thank you. Dr. Daya, can you unmute yourself, please?
Yes, sir. Good morning, sir.
Good morning. See, Dr. Daya, you have demonstrated that to look at the velocity in the left atrial appendage is important. We all agree that something known. But follow up these people and then try to find out whether people who did not have improvement had a worse outcome. Agree, I
Yes,
agree.
sir.
You have only 25 patients. But still, could you look at that?
Actually, the study period, the inclusion period was only for 1 year for this, and we have kept 6 years, 6 months follow up only, sir. And the data is analyzed till 6 months at present, but the patients are still under follow up, sir. So,
Uh,
second outcome right now, sir, we have computed only 6 months follow up at present, sir. So, but these patients are under regular follow up, sir. We are planning at least 5 years follow up for these patients to
so
look
you,
for further outcomes of thromboembolic events in these patients.
okay. You took people who are in sinus rhythm. You have not included anyone in atrial fibrillation.
Yes, sir.
All your 25 patients were in sinus rhythm.
They were in sinus rhythm, sir. Yes, sir.
Any reason why you have excluded people with atrial fibrillation? Because the four
Yes,
studies
sir.
have shown, two of the studies have included people with AF also.
Yes, sir.
Not done. Any reason?
Yes, sir.
Can you hear me?
Yes, sir. Now I can hear you, sir. The voice broke in between.
No. See, the studies which you showed, the four studies which you showed, some of the
Yes,
studies
sir.
included people with atrial fibrillation,
Yes, sir.
but you have not included them.
Yes,
It-
sir. So your voice broke again, sir.
Okay.
Madam, we are able to hear sir very well. Can you, probably it's your internet, can you just check? Sir, anyway, time is over, sir. Shall we go on to the next one, sir?
Thank you, Daya. Thank you for your presentation.
And, sir, the next one is Dr. Rohit
Okay.
Hassanov. So now we are going for the presentation.
Okay.
Hello, am I audible? Coach
Yes,
sir, am I audible?
you are very well audible. Please go ahead.
Okay. Yeah. Rohit, a good study. So I just want to ask you, what is the reason for this unsuccessful procedure? Is it because of an unyielding valve, or was there any difficulty in entering the LV? So
Sir,
what? Yes.
we're in Indian subset of population where because of the poor socioeconomic status and because of the delayed presentation, the patient present to us in a very late state, in which the walls are very either they are having calcium or
No. I'm
not
asking
the.
about your study. In your study, what was the reason
In
for the
my study, sir,
unsuccessful?
The mean Wilkins score in both the group was more than 9, sir.
Okay. And how do you think this increased LA size or LA volume has contributed to the unsuccessful procedure?
Sir, one thing is the LA volume tells us the chronic. It is a chronic process which is going on.
Okay.
And the second thing is while doing a septal puncture, we will face difficulty in going to the LA side. And if the septal puncture is not good, or it is low puncture, we will have
Difficulty in
increased rate
entering
of
the LV. Okay.
complications.
Good. And you also mentioned that there was 6.7% incidence of pericardial effusion with tamponade, not just effusion, tamponade. So what was the reason for that? Was it an LA perforation, means atrial perforation, or was it an LV perforation?
So it was LA, sir. While it was where the IVC RA, SVC RA connection.
So it
Uh,
was the atrial stitch, is it?
yes, sir. Yes, sir.
So in that way, probably an increased LA volume would increase the chance of operations also.
Yes, sir. Yes.
Okay. Coach sir, any other questions?
See, you had some patients with LAVI between 18 and 34. I mean,
Yes.
what are the such people?
Sir, sir, your question is voice is breaking, sir.
So you had some patients with LAVI between 18 and 34. I mean, right?
Yes, sir. Yes, sir.
18 and 34. LAVI. What are the degree of what are the mitral valve area in such people?
Sir, it was sir, we did not find any correlation between the mitral valve area and the LAVI, but all the patients which we have taken, the valve area was less than 1.5, sir, and our patient usually we take less than 1, sir. They are mostly majority of the patients had a valve area less than 1, sir.
Okay, and, so you think that incorporating this LAVI along with the Wilkins score will be beneficial in predicting succeed?
Yes, sir. Because in the receiver operator curve, which I have shown in one of my result slide, it is showing that if we include LAVI with Wilkins score, the area under the curve increased. So, because to see pliability of wall, we need to see Wilkins score, and plus if we do LAVI, the our sensitivity and specificity will go up. For
Question, what is the main limitation of the Wilkins score in PTMC?
So the major limitation it is a semi-quantitative test. So it involves a large amount of inter-observer variability can be there. Second limitation is it does not involve the commissural involvement, does not take into consideration the commissural calcification or nodules. It does not take into consideration the commissural area ratio, which is taken in a revisited echo score, which tells us the asymmetrical involvement. And
Okay,
other parameters like LA size, LA volume is not taken into consideration
thank
in
you very much. Thank you very much.
Thank you. Go to the next.
See, you were telling that one of your patients had transient neurological dysfunction. What did he really have?
Please unmute yourself. Please unmute yourself.
I mean, no, I think you should unmute. You are not audible. Dr. Sunil, you are not audible. Not
No,
yet.
no, we cannot hear you at all.
Now, some problem with your audio.
No, you're still muted, Dr. Sunil.
Please unmute. Please unmute.
No, he says he's not able to. We are talking to him on the phone, sir.
Okay.
But he's not able to, he says.
Then I think we will have to. It's the mobile. No? I don't think we'll be
We'll
able to.
see for the next 10 seconds, sir, whether he's able to.
Can you ask him to connect over the phone,
Yes, sir, he's come on the phone only.
but still not audible?
Not audible.
I think we'll have to skip discussion.
I think we will go to the next one.
Okay.
The time is almost over.
Sir, we are now going with Dr. Suresh Paidi
Okay.
because the next person is not yet joined. So we are going for Suresh Paidi.
Hello, Dr. Suresh.
Yes, sir.
See, Suresh, why is the mortality so high in your study? It is about 26%, right?
Yes, sir.
But in the most
Because
of the series, the mortality is usually within 10% or 8%. So this, despite being having about 66% of them having mild or moderate PE, isn't it? So what is the
sir,
reason for this high mortality?
most of the patients who are of a high risk group, sir, based on pulmonary severity index, pulmonary embolism severity index. Like out of the 29 patients who expired, 20 were of class 5 pulmonary embolism severity index score.
But massive pulmonary embolism was there in only about 30%, isn't it?
Yes, sir. In the 29 patients who expired, massive was there in only around 9 patients.
Oh, that
But
means
remaining that
20% of the rest 20% were actually submassive pulmonary embolism who expired, is it?
yes, sir. But the it is total mortality, sir, not only related to pulmonary embolism. Maybe regarding that malignancy.
Okay, okay, okay. And why is it that only about 19% of massive pulmonary embolism underwent thrombolysis? The rest were not thrombolized. Why is it so?
Sir, it is because of the contraindication for thrombolysis. Some patients were immediate post-op patients, and some patients were having high risk of bleeding.
And was the surgery done in the acute phase or was it in the chronic phase? For
Surgery done
10%,
in failed thrombolysis patients, sir.
I see. Okay.
Dr. Sunil, how many of your patients developed chronic thromboembolic condition?
Sir, actually, we have not seen the follow-up data. This is only the presentation
Okay.
and in hospital.
Okay. Another point I wanted to ask, your study period extends over 20 years, 110.
Yes, sir.
So very, very,
Yes, sir.
you know, you took whatever patients you mentioned. Yeah, it's a,
Sir, voice is breaking.
was it, the patients, it's a retrospective analysis. Can you hear me?
Sir, voice is not clearly audible, sir.
Okay, then. Okay. Okay.
See, one more question. You mentioned that about 52% of patients had PND or orthopnea. So how do you
Ah,
explain PND in this patient?
sir,
Yes. So PND is a very specific symptom with its
yes, sir.
own characteristic pattern. So how do you explain that?
PND specifically, no, sir. Most of them were orthopnea mainly.
Maybe okay. And one more question, last question. You said the evidence of thrombus in the main pulmonary artery is a risk factor for mortality, isn't it?
Yes, sir.
So was it a saddle thrombus or just some thrombus in the main pulmonary artery? Because the studies have shown that only either a saddle thrombus or a clot in transit. These are the only two types of clots which are actually correlated with mortality. So can you
No,
say
sir.
that any
Like
evidence
in
of
our
thrombus in the
not partial filling defect in the main pulmonary artery, sir. Like
their
complete
total
filling
cutoffs?
defect. Yes, sir.
Okay, okay, okay.
Sir,
Was there any other questions?
right, sir. Sir, we have taken Dr. Sunil on the phone, and I'm just connecting him for just a discussion, sir.
Okay, okay.
Okay. Am I audible? Sunil?
Yes, Dr. Sunil, please go ahead. Sir, you have Dr. Sunil online, sir.
Okay, Dr. Sunil, am I audible now? Dr. Sunil, am I audible?
Sunil, can you hear us?
Am I audible?
Anand, he is still not connected, I think.
Still some problem, Anand. Dr. Sunil, am I audible?
Yes, yes, Dr. Sunil, can you hear us?
Okay, he is audible now,
Hello,
sir.
sir.
Sorry. Yes.
Okay. See, you were telling about
Hello.
the. Can you hear me?
Hello, sir. So you are audible, sir.
Okay, you are telling about the transient neurological dysfunction. What exactly did the patient have?
So can you repeat the question, please?
So you are telling about transient neurological dysfunction for one patient. Explain what exactly
Yes,
he had.
actually, for that patient, the transient neurological dysfunction was like he had the episode of deviation of mouth for about half an hour. After that, it was like after half an hour, automatically he has like come to a normal this thing, and we have done the CT scan also, CT brain, after 1 hour of that, but it was showing like no neurological dysfunction in that.
Why
So it was
I
a
asked,
clinical diagnosis basically.
why I asked that question? Overall, you find your thromboembolic episodes are very, very small. Out of the 34 patients, only one patient had a thromboembolic episode.
Yes, sir.
That is, if you did a TEE, not take people who have huge thrombus. So what are the mean size of your thrombus? In,
The mean size of the thrombus was very, actually we have the thrombus which were attached to the wall and which were not mobile. Only those we have taken into the study.
no, no, what was the mean size of your thrombus?
The mean size of thrombus was 4 into 4,
4 millimeter.
4 millimeters. Sir.
Okay. And
Did you
what
do
is
a TE for this all patients? How did you assess the size of the thrombus?
So by ecography.
No, means transthoracic or transesophageal?
No, actually, transthoracic we have observed, and also we have done TE to rule out if there is any major big thrombus in the right appendigeal area.
and we understand that you took people only with bileaflet mitral valve.
Yes, exactly. Which were attached to the wall and which were not mobile and which were small enough.
Okay, what about the tilting disc valve, single disc valve, like the Sitra valve and the other valve?
Sorry, I cannot hear you.
So you took only people with bileaflet valve. What
Yes,
did
sir,
you do?
exactly.
What did you do with the other patients?
So for other patients, like we have excluded taken in, and the other people we have like asked the CVT's opinion, and most of the people whichever have come in last 6 months, they were bileaflet only.
And you said fluoroscopy was the mainstay of diagnosis, right?
Yes, sir.
But most of our patients actually get a chitra valve, which is not, you can't see the disc. So how do you go
Yes, sir.
about?
Actually, in our resource limited area or in our area, like in our hospital, we are preferably having only fluoroscopy, which will diagnose whether it is moving or not.
No, what I'm saying is that the chitra valve wall poppet is not visible on floor. That is not radio plane.
Yeah, yeah. So that is the limitation, sir.
No, he used only bileaflet valve. He
Oh, bileaflet valves only. I see. Okay, okay.
Yes, sir.
I see.
issued and
Okay. Okay.
Can we go on to the next one, sir? It's Dr. Subramania Murthy. Thank you, Dr. Sunil.
Thank you.
Hello, Dr. Subramaniam, can you hear us? Dr. Murthy, can you hear us?
Yes, sir. Very good morning. Can you hear me?
Okay, just one question. Do you think there is a real value for this finer echocardiographic criteria in patients with a massive pulmonary embolism?
Sir, the main value I see here is many a times we have very unstable patients who cannot be shifted for a CT very immediately. So in such a subset, this is very important. Particularly, we have seen like our institute is COVID designated right now. So there is a massive burden of PE in such patients, and many of them are too sick to be shifted for a CT scan.
No, but this is very specific, but sensitivity is quite low, isn't it? So if you
Agreed,
have
sir.
all,
Definitely.
yeah, so if
Definitely.
you have all the clinical features of pulmonary embolism, and if there is an RV dilatation, that and if the
Yes, sir.
patient is unstable, then that is a good enough reason for starting a thrombolysis without a CT, isn't it? So does this finding add any value
Absolutely.
over the classical RV dilatation?
No, sir. I agree with that.
Okay.
I also think like that. You have the sign. Other parameters will be clearly evident. So what exactly is the
Absolutely.
incremental value of this? Can you
Pardon,
conclude
sir. I cannot hear you.
what is the incremental value of this sign?
Sir, the
Beyond
incremental value is Sir, the incremental value is many a times that we see the 60 by 60 sign without apparent RV dilatation, signifying an acute RV strain.
but
So
can you
that may aid to the diagnosis of a particular.
no,
how
can
many
you
people
base it?
observe the 60-60 sign without evident right ventricular dilatation?
Yes, sir. We had three patients in this subset where there is no evident RV dilatation, but there is change in the RV outflow parameters.
Okay.
But our question is, can you take a decision based on this finding alone? For example, as far as there is no RV dilatation, but this 60-60 sign is positive. Can you take a decision on
Yes, sir.
thrombolysis based on this?
The decision for thrombolysis.
Is it possible? Is it possible?
Hello.
Sir, yes, sir. Sir,
Yeah.
this sign alone cannot be used as a guide for thrombolysis. It's only an adjunctive tool.
Yeah.
That is what
Correct.
I have
Okay.
specified.
Okay.
Now you are telling that McConnell sign is a little subjective. That I agree. But don't you think that the right ventricular free wall hypokinesia is a reasonably reliable thing?
Sir, the McConnell sign is observer dependent. Many a times, if
No, I agree with that.
yes, sir, but it is reasonably specific, sir.
Okay.
Now, regarding the specificity, it is specific only in the massive pulmonary embolism group. If you look at the submassive pulmonary embolism, only about four had a positive sign out of nine patients, right?
Sir, I am not able to hear you.
See,
Yes,
this
sir. Specific,
this
more
is
in massive.
specific. Yeah, it is more in this massive pulmonary embolism group, isn't it? In the
Yes, sir.
submassive group in your series,
In submassive, there is
only
no
four patients
no
had a
as
positive
such.
sign,
Yes, sir.
and two patients without the pulmonary embolism also had a positive sign, right?
Yes, sir. Yes, sir.
So it
Yes,
can be used only in massive pulmonary embolism,
Yes, sir.
isn't it?
Subrahmanyam,
Okay.
people who had pulmonary embolism earlier, who had symptoms of embolic pulmonary, they are considered the second episode. The sign.
Sir, I am not able to hear you.
Okay.
Okay. Sir, shall we go to the next case?
Awesome.
Hello, Dr. Sambhavi, can you hear us?
Good morning, sir.
Hello, can you hear us?
Yes, sir. I can hear you, sir.
So, in your exclusion criteria,
Yes, sir.
you have mentioned in the asymptomatic patients, only patients with a gradient more than 40 and who underwent a previous intervention were excluded, is it?
Yes, sir. Because we know that echo overestimates.
Not the exclusion, sorry, the inclusion criteria.
Yes. Sir, in inclusion criteria, the symptomatic patients with those who have not undergone any intervention, we took a cutoff of 20, sir. For those who had already had an intervention and if they were not symptomatic, we took a gradient of 40
No,
because.
but that is not mentioned in your slide. This more than 20 is not there in your
Sir,
slide.
I put it in the left. Those who have undergone procedure.
Okay, okay, okay.
Gradient of
What are
40
the
because
okay? What are the incidents of aneurysm formation on follow-up?
Sir, aneurysm formation we saw around 3 to 4% of the patients. Whoever underwent a procedure only in them we saw, but many didn't undergo a repeat procedure. So we don't know within
3 to 4%, is it?
Yes, sir.
And what was the percentage you said? 3 to 4%.
Yes, sir.
Okay. One more question. In the balloon only group, you mentioned that about 80% of patients had event-free survival at 55 months, correct?
Yes, sir.
But taking into consideration that your initial gradient was very high, all of them had a gradient more than 60 or say 70 millimeters of mercury,
Yes.
indicating that all of them had a severe coarctation. So isn't it a little high? An event-free survival of 80% for severe coarctation with balloon alone at 55 months? Or is it affected by your loss of follow-up? About 30% loss of follow-up was also there.
5% of almost 30% of the patients lost follow-up at a mean of 55 months. So that might have not given us the complete data.
Okay. Okay. Question, any questions?
How many of the patients had birth age? How many of them had bicuspid or
51% of the patients had bicuspid aortic valves.
how many of the patients underwent a surgical procedure for coagulation? Because the numbers are huge. 344 patients plus 141. How many had surgical?
Sir, procedure-related complications were not there at all, sir. None of the post-procedure, we did not do. None of the patients were sent for surgery, but we excluded. It was in the exclusion criteria. We only took into consideration only who underwent an intervention.
Okay, other groups were not in. Okay, a very good study with a very good.
Thank you, sir.
See, out of this 40, 140 odd obese patients, only about 25% of them had any metabolic abnormalities, right?
Yes, sir.
So that is a little unusual, isn't it?
Yes, sir. In our study, it's like that only, sir.
So according to you, obesity per se is not a risk factor. Metabolic abnormality per se is not a significant risk factor. Only when these two are
No,
combined.
no, so both, sir. Yes, sir.
But I think previous studies have very well shown that a low HDL and a high triglyceride, they are definitely correlated with CAD. So how do you explain this discordance?
So there we can't tell like not at all risk factor with that decreased LDL and increased triglycerides. But when I'm what I'm trying to say like when including that BMI and with that metabolic obesity, that center score is high in this study, sir.
See,
I
many
think only,
people,
sir, go ahead.
many of these people could have been receiving statins already, no? At the time of
Yes, sir.
your study.
Yes, sir. Yes, sir.
How much of importance can you give to these lipid parameters? It's someone who is already on treatment.
Yes, sir. But most of the time we used to give statins. I think that won't give much improvement in the triglycerides. But anyway, we didn't include that. We didn't see how much patients are in statin and how many patients are not on statin in this
I
study.
think that is very important. If you are taking
Yes,
statin
sir.
naive patients, okay, or people who are naive to any treatment. But otherwise, these cutoff levels can be altered. Statins,
Yes, sir.
okay. See, statins predominantly have effect on LDL, but TG reduction of 15 to 20, 25% can sometimes occur, especially in people who are comparatively high TG. So that,
Yes, sir.
and regarding the measurement, what measurement did you?
Sir, for BMI height and weight, and for then for metabolic obese, we used TGL, and the patient are diabetes or not, and um, HDL and less than 40 for a man and less than 50 for an woman.
What important contact of the treatment modality
Sir, sir, I couldn't hear you, sir.
Coach, sir, you are not audible, sir.
Okay.
Okay, one more question. See, the problem with your study is that you have basically looked at the severity of coronary disease, right?
Yes, sir.
But all the other epidemiological studies have actually looked at the prevalence, because severity is something which is affected by so many other things like smoking, age of the patient, so many things are involved. So all the
Yes, sir.
metabolic studies have actually looked at the prevalence of CAD, whether it is 50% or 70%, that doesn't matter. So did you choose the wrong outcome?
Sir, so studies are showing that prevalence is more high in that metabolic obese but normal weight people.
No, but
But
you
I
are
want
trying to
to know
correlate with the
that
severity using syntax.
complexity and severity. Yes, sir. In that, I found that the metabolic obese and with abnormal weight people are higher in that group.
Okay. Any other question, coach, sir? Okay,
Thank you, sir.
thank you.
Thank you.
Okay, Dr. Bhatnagar, can you hear us?
Yes, sir. Very good morning, sir.
See, in the exclusion criteria you have mentioned that
Yes, sir.
pulmonary regurgitation is excluded. Why is it so?
Okay.
You have
Yes.
written supravalvular PS, peripheral PS, or presence of PR. Why PR was excluded?
Sir, it may be because of the presence of the non-coapting valves or associated with the other supravalvular pathologies. So we only included the exclusively the valvular pathologies only, causing the PS.
Okay, okay. So if the ASD is associated with the PR, then that is not an exclusion, right?
Yeah. For ASD, it was not. It was only for the PS, sir, if PR is
Only for
present.
PS. Okay. And one of your conclusion is that in both ASD and BDA there was a significant growth catch-up.
Yes, sir. Yes, sir.
But at the same
So
time, we
mostly
also
in the PTA because only 22 patients were less than 5 year of age group, and in ASD we have only one patient which was of 4 year old. So we could make it in PDA that there is significant catch-up growth after the device closure.
but the problem here is that the shunt is only what was the shunt in the PDA 1.7 or 1.8.
It 1.8, sir.
So do shunts less than 2:1 really lead to growth retardation, or correcting them lead to any improvement in growth?
Yes, sir. Maybe because of the associated other nutritional education, lack of nutritional education, poor.
No, that is
Uh,
different. You can't attribute that to the PDA intervention,
in
right?
our case, sir, we treated the disease as well as we give the counseling to the patients regarding the nutrition aspect also.
Okay.
And
Okay. Sir,
You have done interventions in a very nice manner. Lot of children you have helped. Apart from that, it is very difficult to conclude that that contributed the catch-up growth and all possible. That must be because of the associated nutritional support. That you can.
your voice is not clear, sir.
Okay, leave it. I think some problem.
okay. And see, what was actually the purpose of comparing these entirely different congenital heart disease with the different
There
natural
was
histories?
a study which focused only on one particular lesion. We included all the lesions which are coming to our OPD and attending the cardiology
No, but
department.
their natural histories are entirely different. No, they are not comparable. For example, you cannot compare the fluoro time of an ASD versus a PDA
No,
or a
sir.
VSD.
Yeah, that is correct, sir. It is our purpose was not to compare them, but only to give the average time which is taken for the procedure and fluoroscopic time, and there is no major complication to increase the these intervention in the centers like ours, so that the pediatric intervention can be carried out at these adult centers too.
Okay, okay, okay. That's all. Sir, yeah, sir. Okay, okay. Thank you.
Thank you. Thank you.
Okay. Dibanjan, you can hear us?
Yes, sir.
See, out of the about 30 patients who survived, there is no PR prolongation in any of them, isn't it? The
No, sir.
average PR interval is 190, is it?
Yes, sir.
So isn't it little odd because one of the classical signs of root abscess is PR prolongation, or is it because the location was different? Like patient who died had the abscess on the septal side, and these patients had more posterior without involving the septum. Is it so? How do
So
you
that
explain this?
actually we had not like assessed because it was a retrospective study. The data we had to take out from the EMR. So it's difficult to say. I think I have to like reassess my data, but we did not find a significant PR prolongation in any of our patients.
Patients who survived.
Yes, sir.
And do you also have any correlation with the size of the abscess versus mortality?
No, sir. We had
Sometimes,
tried like correlating it, but we could not get a proper. The p value was not significant.
no, but you could get the sizes. The old images were available to you.
Yes, sir. The old images were available, sir. We tried to have a correlation, but there was no significant like correlation.
What was the commonest barrier associated with diabetic? Not audible.
Sir?
Can you hear me?
No, sir was asking what was which was the valve which is commonly involved?
No, no, no. What was the lesion? What was the lesion responsible?
Lesion A, sir. Okay.
Sir, like most of them had a native AS or a prosthetic valve that is post AVR.
What was the commonest in your experience?
Commonest, sir, was the like prosthetic valves, sir. Around 16 like patients had prosthetic valves,
The commonest
out of
was
which 13 were like mechanical, sir.
none of them have any conduction of pneumatic.
No, sir.
That looks amazing.
Sir?
That looks very odd.
Yes, sir.
What was the most common organism you isolated?
Most common, sir, it was this like staff, sir.
Staph aureus.
Yes, sir.
Okay. And this organism was the same in the prosthetic valve versus the native valve endocarditis. Was it different?
No, sir. The prosthetic valve most oftenly had they had cons or coagulus negative staphylococcus aureus or fungal, and this fungal and endocarditis were associated with a higher mortality.
Did any of the fungal endocarditis patients survive?
No, sir. It was actually
Okay.
sir. I think only one patient survived. Otherwise, all of them had expired, sir. So that is what I wanted to highlight. That was not established in the previous studies.
Why there was only 9% surgical intervention in the patients who were deceased?
Sir, actually,
The,
there were like multiple issues that the patients who expired they were sicker prior, and the surgeons wanted us to stabilize the like patients. So either they were not it was not possible to like stabilize them, or there were some like financial issues also, or I think in 2 3 cases the patients did not want further treatment.
so do you think the early surgical intervention would have saved some of these patients?
Yes, sir. Maybe because if we because we did not have any Indian studies. That was the I think first large Indians like study. The data from the Western world they say that surgery is associated with a much better outcome.
What was surgical mortality in this series?
Surgical, sir. Actually, we did not do a like long-term outcome because many of the patients were like
The acute mortality, the patients who underwent surgery, what was acute mortality?
acute,
In-hospital
sir,
mortality?
was only two, sir. It was around like 10%.
Okay. Sir, any other questions? Okay, then, thank you, Dimajan. It's a very nice study.
Okay,
I
sir.
think there are not many studies around on adequate root abscess. Thank you very much.
Yes, sir. Thank you, sir.
Boy, sir, you are not audible. Hello, Coach sir, you are not audible, sir.
Okay, have you finished
Ah,
the
yeah.
Yes, sir, we have finished. Sibu here, we have finished.
10 people have presented, 2 people did not join. Am I right?
Two did not present. First two did not present.
Okay, fine.
Thank you,
Okay,
sir. Thank you,
thank you.
Dr. Jayakumar.
Thank you very much.
Thank
Thank
you,
you.
coach,
Okay,
sir.
thank you.
Thank you, sir. Thank you, Coach sir. Thank you, Sibu.
Okay, thank you, Dr. Jayakumar. Thank you very much. So we will leave the platform.
Yeah.
Thank you.
Sir, good morning. minutes to go, 2 minutes to go. Platform loop ஆயிடுச்சான்னு பார்த்துக்கோங்க. Platform loop ஆயிடுச்சான்னு பாருங்க. வாக்கி டாக்கில் ரிப்ளை பண்ணுங்கப்பா. வாக்கி டாக்கில் ரிப்ளை பண்ணுங்க. இவனை கூப்பிடு. ராஜு ஃபோன் கூப்பிடுங்க. வாக்கி டாக்கி ஆன் வச்சிருக்காங்கன்னு கேளு. யாராவது வாக்கி டாக்கில் ரிப்ளை பண்ணுங்க. ஃபோன் பண்ணி தினேஷோ தினேஷ் நான் கூப்பிட்டேன். அந்த சிஎஸ்ஐ கட்டாக வாக்கியில் கொடுத்துருக்காரு. ஒழுங்கு வரீங்களாங்க சிஎஸ்ஐ. What I would suggest is ஷஃபி வாக்கி டாக்கி வந்து பொம்மைக்காக கொடுக்கல, பேசுறதுக்கு வச்சிருக்கோம். தினேஷங்க tell me immediately. We have another 1 minute to go. Change பண்ணி பார்த்துக்கோங்க. Check in all 3 halls. Can I have the 3 halls on the LED? But I know that they are really doing it. Oh, you won't get it. It's only from the platform. Okay. Okay, then go for it. என்ன பண்ணலாம் சார்? இன்னும் கொஞ்சம் சென்டர் வாங்க ப்ளீஸ். ஓகே. யா. That's better, sir. That's better. இல்லை ஹைட் பண்ணாமல் இன்னும் மறைச்சிக்கூடாது. Right, good. Okay. Dinesh, last 30 seconds. Audio. Mic எங்க ஆனா?
Dear friends, another fantastic morning from the city of Ahmedabad, and we are on the 7th day of CSI 2020. Hope you are enjoying the scientific proceedings of all these days. As I was mentioning earlier, we have more than 23,000 registration, and I'm sure that a sizable number of them are logging in and watching our program. Today we have again important sessions coming up. Everything begins in all the 3 halls at exactly 10 a.m. The important events of the day are one is the B.C. Roy Award, B.C. Roy oration by Professor Venkatram, and then we have the National Interventional Council data being presented. As you are aware, we had postponed the 2020 NIC meeting, and but it's customary that we should be knowing about what's really happening in the interventional scenario in our country. So we have Dr. Diman Kahali, our chairman of the Interventional Council, telling us about now what exactly, how is the way that we perform in the scenario of interventional cardiology. And then, of course, the most prestigious presidential oration comes after that, followed by the customary annual general meeting. We have a large number of renowned international faculty coming up also. Faculty like Professor Robert Bono, Salim Youssef, Danai Lloyd Jones, Pinaro, to name a few, the European faculty. So we are going to have a scientific feast today also. So welcome to CSI 2020 again. Please do log in and enjoy the scientific fun. Thank you. Okay.
So, Dr. Panja, you can start your presentation
Yes,
on
thank you very
early
much.
detection and treatment of
Okay,
multiple plaque.
thank you, Pancholia, and all the chairman, Dr. Munshi, and the Datta, and Ramachandra, all the expert panel. And I'm very thankful to Dr. Mahan for inviting me in the speaker in the morning session, early detection and treatment of vulnerable plaque. Can we prevent acute coronary syndrome? And vulnerable plaque is a term that represents the plaque that's susceptible of plaque rupture. It is coined by the Muller. And plaque morphology was a rupture thin plaque fibroadenoma with superimposed
It's a lot of
thrombosis.
echo.
Ultimate goal to identify the vulnerable plaque and ultimate goal to preventing the plaque rupture, thereby averting the acute myocardial infarction and sudden cardiac death. So vulnerable plaque is non-obstructive, silent coronary lesion that suddenly becomes obstructive and symptomatic. And this is the vulnerable plaque. Unstable plaque means vulnerable plaque. Again, vulnerable plaque means the future culprit plaque. Therefore, representative the diametric representation of vulnerable plaque, the lumen is the brown color, and the thin plaque here, and the less than 100, that is the only less than 65 micromillimeters, and thin plaque contain the spotty calcification and infiltration of macrophages. And another important that there is some expensive outer remodeling of the intima and large necrotic core occupying a 25% total plaque area and neoangenesis, budding of the new vessel from the vasa vasoram, and therefore sometimes the rupture may cause the bleeding. And here is a criteria defining the vascular plaque once again. That means major active inflammation and thin cap with large lipid core, endothelial denudation with platelet aggregation and fissure, stenosis. Minor criteria: superficial calcified nodule, glistening yellow color, and interplaque hemorrhage, endothelial dysfunction, outer positive remodeling. Now, how will detect? First, non-invasive way, so biomarker of the vulnerable plaque. That is very important. Common things you have HCFP, lipoprotein associated that is the lipase, and WBC, interleukin 18, and T1 necrosis factors, myeloperoxidase. Apart from so many other biomarker inflammation, plaque inflammation is there, interleukin 1, interleukin 6, and ICAM, BCAM, cis-lectin, and oxidized LDL, an important factor, fibrinogen and CRP is very important. First, invasive investigation is that detection, that is angioscopy, permit direct visualization of plaque surface. The plaque color is graded. White color is the thick, light color in between, and yellow color also thin, and glistening yellow color, thinnest cap, 10 to 20 microgram. Glistening yellow plaque is a strong predictor of the thin cap hyperatherma acute coronary syndrome in 68% of cases. There is an endoscopy finding the glistening yellow cap, that means thin cap, arrow on the C point is very thin compared to the white plaque, that is the C on the white the pictures, that is thick plaque. So therefore, yellow glistening plaque, important finding of the endoscopy. Now I summarize the investigation, commonest investigation done by at present for the whole world. First thing is the virtual histopathological IVAS, OCT, and needs spectrogram. And here in the IVAS is the ultrasound, you know the OCT infrared, and near infrared is the needs. And depth OCT is very particularly 0.1 to 2, and depth of the determination case and the ultrasound guided 7 to 10, and special resolution needed. Manual plaque. First, I talking the remodeling. Remodeling can be recorded by the identified by the virtual IVAS only. Only remodeling can be recorded by the virtual IVAS. And second thing, the lipid core was detected by IVAS, and the plaque ruptures can be detected rupture, and spotty calcification also detected by virtual IVAS. OCT cannot recommend detect the remodeling. It is easy to recommend the identify the lipid core, and the thin fibers properly detected by OCT. This is important finding. And macrophage infiltration properly detected by OCT, and neovasculars are detected by OCT, and spotty calcification by the OCT. Near infrared spectroscopy only they detect the high rich lipid cores. A better way, better than the IVAS and OCT. An angiogram is a luminography only. It is poorly detect the wall of the plaque information. Now here is a patient angio, shows the thrombus containing plaque, irregular margin, and therefore IVAS histology is very important. And the necrotic core red color, calcium white color, fibrolipidic yellow color, fibrous green color, and this is important the virtual histology of the IVAS. And now here is my own patient. You see, the A1 is the thick pulp, the thick caps, and here is the white color is the calcium, red color is the lipid core, green color is the green color is the fibrous tissue, and B1 indicating the arrow into the spotty calcium. This is an important finding. Here, calcium direct contact and the red color direct contact with lumen that indicating is most likely thin plaque. Here is I was also detect the plaque rupture and identify the cap also, and also detect the calcification also. Intravascular thermography is very simple in theory but gives information about the inflammation. And here thermal heterography within the human atherosclerotic coronary artery detect in vivo a new method of detection application of special thermographic catheter. And here record the temperature up to 2.6. So temperature increase because of macrophages. Statin associated reduced thermal human, that is the heterogeneity human atherosclerotic plaque temperature only can that is the reduced temperature only up to 1.2 centigrade. And OCT, I already spoken the thin cap detected, necrotic core detected, plaque inflammation, microphage detected, and therefore one of the OCT finding here, the A1 is the thick plaque that is 170 microgram outside that is the green dotted area lipid core, and then the B1 that is the thin cap that is only 30 micromillimeter outside the core plaque, and the C indicate the neovascularization microchannel within the intima, and D1 indicates that the arrow indicates the rupture, and again the final OCT, the three arrow indicate the bright light that indicate the macrophages indication infiltration. Needs spectroscopy very important, and the chemogram that detect the lipid group burden within plaque a better way than the IVAS and OCT. Here I summarize the non-invasive imaging. Non-invasive imaging, that is OCT, then that is the coronary cap detection, coronary angiography, particularly coronary CT angio, and the FDA, FDG PETs and needs, and very important. And among the non-invasive imaging, that the CT angio can detect particularly better way that the remodeling and lipid core as well as the spotty calcification. Again, FDG only detect the inflammation macrophages. And the sodium fluoride detect all the microcalcification, and MRI can detect the only lipid core and some intraplaque hemorrhage. That is CT angio on our patient, that there is the white color and circled by the red dash. It is the that is there is a calcified spotty calcification, and red circle, red dash circle, and white color high attenuation indicate the fibrosis, while the low attenuation the dashed by the green dash, and there is a black color at the lipid core, and some lipid cores C1 also multiple lipid cores around the lumen, and D1 that is the green color, the outer expansion, they indicating the positive remodeling. electron beam tomography is very image of the calcium, quick and easy information regarding the plaque calcification. And so nowadays, the potential target nuclear imaging is an ongoing process going on. Therefore, ladies and gentlemen, using combination of morphological and functional imaging is very important. Now, regarding the treatment of vulnerable plaque, I summarize one chart. That is, one is the statin, second is ezetimibe, third is elolicumab, boscimab, and evolocumab. And all these things, the imaging done in cases of OCT derived fibers cap is increased, then the thickness of plaque increased, stabilize the plaque. And IVAS derived high risk plaque also drastically reduced. And IVAS derived plaque burden reduced. And positive, that negative remodeling effect is increased. And OCT derived fibers cap thickness is increased by this statin, ezetimibe, and this PCSK9. And inflammatory drugs, that is darapladip, persipladip, that also reduce the IVAS derived necrotic plaque. Methotrexate, colchicine, canakinumab also important for evaluation. So ladies and gentlemen, systemic therapy is very important. The NTK and ideal and the PRUVIT trial, they signify the reduction of the plaque. And ASTRO trial also shows the absolute reduction atheroma by rosuvastatin. Fibrate also demonstrate the plaque stabilization. And mechanism action, that improve statin, improve dependent vasodilation, stabilize the plaque inflammation, and slows the progression of the plaque. And therefore, 22% cases within 2 years, there's acute coronary syndrome can prevent it compared to the medical therapy. And newer drug is coming up, control the BCAM, ICAM, reverse cholesterol transport system. And local therapy, intravascular plaque, and pharmacological agent, physicochemical therapy is coming up, photodynamic therapy, endoluminal therapy, cryosurgery is coming up. Angioplasty is very important. Summarize this.
Please complete.
Yes. This is the final study, ongoing clinical trial of the prospective trial, BBS, not good result.
Sir, time is over.
And preventive trial. This is
Excuse
gentlemen,
me,
Sominen trial, Unimen, Paradigm, Easy trial, and Script trial, colchicine, methotrexate, Cantox, all trials shows the reduce the MACE. So finally, conclusion, ladies and gentlemen, invasive, non-invasive mortality, early detection, accurate diagnosis, prognostic value of the vulnerable plaque, IVAS, OCT needs, evaluation of the therapeutic agent, non-invasive mortality, particularly CT angio is very helpful. Therefore, local treatment, vulnerable plaque with the PCI prospect is not negative result. PECTAS and prevent trial is very useful. Finally, statin reduce the stabilize the plaque, anti-inflammatory agents very, very useful to reduce the acute coronary syndrome. Therefore, ladies and gentlemen, personalized treatment, coronary disease, particularly, it is inevitable and indispensable to prevent the acute coronary syndrome. Thank you very much for patient hearing.
Next speaker, please.
Thank you, Dr. Panja.
Yes, please.
Sir, can I screen share my slides?
Yes.
Sir, is it visible, sir?
Yeah, it's visible.
Yes. You can go ahead, Dr. Christopher.
Perfect, go ahead.
Okay, sir, I'm starting.
Yes.
Yeah.
Good morning, everybody. Thank you again for this opportunity, and I'll be talking about the coronary calcium score do's and don'ts. Everything has the good, bad, and ugly part, and calcium score is very, very similar. Now, the do's of calcium scoring is that we should understand what it means. It is a very specific marker of atherosclerosis. It does not occur in normal arteries, and it does not occur in any other pathological condition, and it does not involve the ingestion of calcium. Now, there are only two places where you need to use the calcium score in cardiac practice. One is the asymptomatic people, those with the intermediate risk with traditional methods, and the second group is symptomatic stable coronary artery disease patients who have a 10 to 60% pretest probability as an adjunct with any other anatomical like a CTA or a functional study like a stress maybe to assess the cardiovascular risk assessment. Now, the most important thing in calcium score is that you must do a prospective gating with a specific RR interval in diastole to limit the radiation. That is very important, and there is no contrast or heart rate reduction required. Now, in the asymptomatic population, males more than 40 and females more than 50, do your assessment by the Framingham and JBS3 risk assessment score, and only if they are in the intermediate risk of 10 to 20% should you proceed for calcium scoring. If it is absent, it's lifestyle modification and primary prevention. If it's more than 100, and in some societies more than 300, secondary prevention with the add-on of any other test such as a full coronary CT or a stress maybe can be done. We do understand that the relative risk in asymptomatic patients goes up as the calcium scoring increases and reaches a peak when you cross 1,000. The 2007 guidelines, American College, the 2013 guidelines, and later finally put the calcium score as a test that has to be done if you're not clear based on a treatment decision, and you can use either of the following: a strong family history, HSCRP, a calcium score, or an ABI, but it has only got a 2B recommendation, and that was because of the radiation. Now, the risk assessment based on the traditional risk factors, as we're all aware, using any of the society scores, can predict only 60% of the cardiac risk, and that is also in populations. For specific individuals, we need to do a direct plaque imaging. And we know that the Framingham risk score and the calcium score is well embedded in that every quartile of Framingham risk can be differentiated based on the calcium score of 0 being the lowest risk and the black bar being the highest risks. So every Framingham rose can be differentiated by the calcium score. And I will give you an example now of a 60-year-old male. He's hypertensive and has hyperlipidemia. His pre-test risk score based on the traditional risk criteria is 29%. However, after this, we did the calcium score. So based on this assessment, traditional risk, he is a high-risk patient. When we did the calcium score for the same patient, he has a 0 calcium score. So once you go to a 0 score, you get a post-test risk score of only 14%, which is what we call an intermediate risk. So you have converted a high-risk individual to an intermediate risk, and you have de-risked this patient based on the calcium score. We went ahead and did the CTA, and we found pristine, clear coronary arteries in all the three. So de-risking of the scores is important. Now, what is the benefit of a calcium score of 0? 80% will have no CAD, and a large proportion of the majority will have non-obstructive CAD. And you can clearly see with multiple studies that when you have a calcium score of 0, anywhere between 37 to 50% of the population in that group, the incidence of obstructive disease is extremely low, 1 to 3% only. And when you're doing a calcium score, a 0 score gives you a hazard ratio of only 1, whereas when you cross 300, it is 7.0 hazard ratio, signifying significant risk. A calcium scoring is very beneficial for the assessment of cardiovascular disease, but not so for stroke. A CIMT has not much benefit for cardiovascular disease, but it has a lot of benefit in assessing for future stroke. The second group is the stable CAD, and here you can see only in the low to intermediate risk you should use the calcium scoring in conjunction with any of the following functional tests. And the roadmap is like this. You do a calcium score. If it is 0, the patient can be managed with primary prevention. If it is more than 400, an invasive pathway can be used. If it is 1 to 400, you can do a coronary CT with contrast, or you can do a stress maybe. And as I said before, irrespective of the coronary CT report, if it is non-obstructive less than 50, the calcium score decides the prognosis. In that more than 300, there's a very high risk. The compliance is very good when you use calcium score for statins. Resource utilization based on the Eisner trial shows that the cost went up a little bit in the calcium scoring group because the drug dosages started increasing because they started taking better blood pressure and cholesterol medication. The cost effectiveness of a scan is almost 36% of saving compared to doing for an invasive test. So in conclusion, the advantages of a calcium score is it is simple and quick, less than 5 minutes, no need heart control, no need IV contrast, no complications, faster to interpret, and the non-cardiac findings can be seen, and it is easier to integrate with the PACS and offer the same day reporting. Now, there are a few don'ts I want to stress on, that calcium scoring is only the extent of atherosclerosis, not the severity. The relation between calcium score and stenosis is non-linear, and calcium scoring comes much later in the pathway when you're looking at risk compared to CIMT, flow-mediated vasodilatation, and coronary CT, which are much more sensitive techniques. In terms of prognosis, calcium score is a little behind CT because you can look at soft plaques and obviously invasive tests like IBIS, which are much more sensitive. There is radiation, so please be careful when you use it in asymptomatic patients. It's indicated only in very specific circumstances. The plaques contain lipids, they contain fibrotic and calcium. So calcium scoring won't give you the entire extent. There is also significant interscan calcium score variability. That is, if you do a scan now and if you do it after 1 year, there's a 14 to 43% variability. So keep that in mind. The second thing that has been looked at is, can you treat a patient with statins based on the calcium score? The answer is no evidence to treat patients only on the basis of calcium score. And I will end with this example of a 41-year-old male hyperlipidemic who has a score of 13% based on traditional risk factors. But when we did the calcium, it was 1609. And that means he has moved to the high risk category because more than 400 is 36%. So we have converted an intermediate risk to a high risk. And yes, when we did the CT, we found multiple tight lesions here in all the 3 vessels, and this patient had to go for bypass surgery. Do not use calcium score independently in the ER. It is of no value. Do not use calcium score in smokers because they have a lot of non-calcified plaques. And the beauty of calcium score in asymptomatic patients of a 0 score does not hold good with symptomatic, and a calcium score more than 0 has a high risk in patients who are symptomatic. That is the reason the guidelines stop short of recommending the use of calcium scoring because of cost and also radiation risk. We must also remember that the initiator of the Agatston calcium score, Dr. Arthur Agatston, left calcium scoring for good and is currently working on his South Beach diet, the gluten solution. So please be aware of that. In summary, ladies and gentlemen, calcium scoring is a well-established marker of atherosclerosis. It provides an independent and incremental risk for future coronary events, and the absence of calcium or calcium of 0 can be used to exclude CAD in patients with stable symptoms. I will end with this very nice quote by my mentor, Dr. Dan Berman, that major professional organizations should measure coronary calcium because it has as great an impact on saving lives as the recommendation that cholesterol be measured and controlled, says Dr. Daniel Berman, Chief of SEDAS Imaging and Nuclear Cardiology. Thank you very much, ladies and gentlemen, for this opportunity.
Thank you, sir. Next speaker, please.
Is my slide visible?
Yes, sir.
Good morning. Myocardial infarction with non-obstructive coronary arteries called MINOCA. So myocardial infarction in the absence of obstructive CAD is found in about 5 to 6% of all patients with acute infarction referred for coronary angiography. The term MINCA, myocardial infarction with normal coronary arteries, was initially coined to describe these patients and later evolved to MINOCA to encompass patients with evidence of atherosclerosis that's not considered sufficiently severe to compromise myocardial blood flow. MINOCA is initially considered at the time of angiography as a working diagnosis until further assessment excludes other possible causes for troponin elevation. How do you make the diagnosis of MINOCA? You have to have 3 criteria. 1, acute myocardial infarction as evidenced by elevation of troponin, and corroborative clinical evidence of infarction as evidenced by at least one of the following: symptoms of myocardial ischemia, new ischemic ECG changes, development of pathological Q waves, imaging evidence of new loss of viable myocardium, or new wall motion abnormalities, which is consistent with an ischemic cause. or identification of a coronary thrombus by angiography or at autopsy. And second is a non-obstructive coronary arteries on angiography, defined as absence of obstructive disease. There is no coronary artery stenosis more than 50% in any major vessel. This includes three types of patients: one with completely normal coronaries; second, mild luminal irregularities amounting to stenosis less than 30%; and moderate coronary atherosclerotic lesions with stenosis about 30 to 50%. In fact, 1/4 of these patients, if you do FFR, may have a value less than 0.8. And third is no specific alternate diagnosis for the clinical presentation, like sepsis, pulmonary embolism, or myocarditis. So this is how you diagnose MINOCA. There are the different terminologies: MINOCA, MI with non-obstructive disease; troponin positive non-obstructive coronary disease called a TPNOCA; then myocardial infarction with normal coronaries, MINCA; ischemia with non-obstructive coronary disease, INOCA; and XNOCA, acute coronary syndrome in normal or near normal coronary arteries. Then what is the clinical presentation? Compared to patients with the typical atherosclerosis mediated MI, patients with MINOCA tend to be younger and more often females with relatively fewer coronary risk factors, except history of cigarette smoking, which is not different. 1/3 of patients with MINOCA present with STMI. Usually they have no history of angina before infarction. They do not generally have a prodrome, but the clinical lab and ECG features of STMI otherwise resemble those present in majority of patients with STMI who have classic obstructive CAD. And about half of the patients with MINOCA have smooth vessels on angiography, whereas the other half has some non-obstructive irregularities, which may predispose them to vasospasm or plaque erosions. So this is a clinical algorithm for the diagnosis of MINOCA. If you look here, you have elevated troponin T with features of non-obstructive CAD. Then the working diagnosis is MINOCA. Then we have to exclude missed obstruction. Sometimes you may miss a vessel which is completely occluded, a branch which is completely occluded, or sometimes spontaneous coronary dissection may be missed, or an embolus or thrombus in the coronary may be missed. So you have to review the angiography. Then you have to look at non-ischemic mechanisms of myocardial injury, like Takotsubo syndrome, other cardiomyopathies, or myocarditis, which you can assess by the echocardiography. And the myocarditis can be ruled out by contrast MR imaging. And if these two are excluded, then we can come to diagnosis of MINOCA, which is called unclassified MINOCA. And if you want to have specific etiology, then you may have to resort to other investigations like IVUS or OCT, which can find out whether there is a plaque disruption, coronary emboli or thrombus, spontaneous coronary dissection, or MRI. So these are the specific causes: a plaque rupture, plaque erosion, in situ thrombosis, spontaneous coronary dissection, and sometimes it can be epicardial coronary spasm or microvascular dysfunction, and sometimes it can be supply-demand mismatch in a patient with, say, thyrotoxicosis. Additional causes for MI in the setting of normally appearing coronary arteries include coronary emboli, perhaps from small mural thrombus or myxomatous mitral valve, or LA myxoma, CAD in vessels too small to be visualized on coronary arteriography, or coronary arterial thrombosis with subsequent recanalization. You can have seen recanalized vessels presenting with mild stenosis, or a hematological disorder like polycythemia, congenital disease with polycythemia, sickle cell anemia, DIC, thrombocytosis, TTP, etc. So this comes to the domain of the hematologist. Then sometimes there can be augmented oxygen demand as in thyrotoxicosis and amphetamine use, hypotension due to sepsis, blood loss, or medications, or anatomic variants like anomalous origin of a coronary artery which is compressed, or coronary fistula, or myocardial breach. And this is a paper recently published in JACC imaging of OCT and CMR in patients with MINOCA. So they have 40 patients underwent both OCT and MRI, and of them, 9 patients, the specific cause was found because of OCT alone, in 8 patients with MRI alone, and these two combined helped in other 23 patients. So with OCT, you could detect plaque rupture, plaque erosion, lung thrombus, spontaneous coronary dissection, and eruptive calcium. And MRI could detect myocardial infarction, which could not be detected by other methods. So similar findings were echoed by other people like Oplowski and colleagues, who studied 38 patients with OCT and MRI. Then what are the management strategies? Emergency supportive care, a working diagnosis approach for a patient evaluation, exclude disorders mimicking an acute MI like Takotsubo syndrome, and identify underlying cause responsible for MINOCA. Third is cardioprotective therapies irrespective of the cause of MINOCA, and four is cause-targeted therapies. So emergency supportive care might be needed in patients with life-threatening ventricular arrhythmias, cardiogenic shock, and coronary vasculitis may be needed for those with refractory coronary spasm leading to intractable ventricular arrhythmias. Then those with the working diagnosis of MINOCA and clinically overlooked ischemic or non-ischemic presentations. So you can look at the flush occlusion of a branch or severe branch stenosis because of coronary embolism or thrombus or ruptured plaque. It can be detected by angiography or coronary imaging or echo for source of embolism. And the treatment will depend if there is an occlusion, antiplatelet or anticoagulant depending upon the cause, then statin, beta blockers, ACE inhibitors or ARBs. And spontaneous coronary dissection from angiographic reviews and coronary imaging. Then they can have aspirin, beta blockers, plus minus second antiplatelet. Then non-ischemic or MINOCA mimics like Takotsubo, cardiomyopathy, myocarditis can also be detected and appropriate treatment instituted. In ischemic presentation, we can see the specific cause by plaque disruption, then aspirin, high-intensity statin, beta blockers, then ACE inhibitors or ARBs, plus minus second antiplatelet. In coronary spasm, detected by resolution of with vasodilators like intracoronary nitroglycerin, provocative spasm testing with acetylcholine, then ruling out intake of medications like migraine medicated ergotamine and the use of cocaine. Then they can have calcium channel block, very important, have calcium channel block. Beta block can be contraindicated. Other drugs like nicorandil, nitrates, siloxazole may be considered. Statin can be useful. And coronary microvascular dysfunction, then you have used calcium channel blocker, beta blocker. Then drugs like arginine, which improves endothelial function, ranelsin, diprodamol, which improves microvascular vasodilatation, and imipramine, which is visceral analgesic. If there's a coronary embolism or thrombus, anticoagulant therapy, targeted therapy for hypercoagulable states, spontaneous coronary dissection, aspirin, beta blocker, maybe clopidogrel. Supply-demand mismatch, you have to treat the underlying cause. Then myocardial infarction with non-obstructive coronary arteries, the importance of achieving secondary prevention targets. So this is the Sweetheart registry, 5,830 patients with myocardial infarction and non-obstructive coronary arteries, group 1, and 54,000 patients with MI with CAD were studied, and the reduction in the 1-year risk of major adverse events also with pre-specified secondary preventive measures was done. That is, blood pressure, low density lipoprotein lower levels, smoking, and non-smoking and participant exercise training. These are the 4 interventions done. So what is found that in patient group 1, there's a 3 to 20% risk reduction in group 1 with these interventions. And the low achievement of LDL targets and exercise training helped them. So 9 points of the summary of the study was 9.6% of the patients with myocardial infarction non-obstructive disease reduction was there. Low electric levels improved risk and exercise training improved risk. This is seen in this. They achieved all the 4 secondary prevention methods. Hazard ratio was lowest. Then this MINOCA BAT trial, it's going to be initiated, comparing the use of beta blocker, ACE inhibitor in patients with non-obstructive coronary arteries. So this is going to be started. Then in prognosis in MINOCA, in general, patients who have survived STEMI without evidence of significant CAD have a better long-term outlook than those with atherosclerotic. In-hospital mortality is 60% lower, 1-year mortality is 40% lower. Our subsequent risk for patients present with MINOCA is largely based on the underlying etiology and comorbidities. These are a few studies. Action, the WTG study in 19,000 patients, it showed that the mortality, in-hospital mortality was 1.1%, and meta-analysis of Minoka studies showed in hospital mortality of 0.9%, but 12-month mortality of 4.7%. Something similar was in the Sweetheart trial. So all this showed that the prognosis is better than the coronary disease, but worse than a normal person. So it needs to be taken care. Prognosis worse in those people who present with shock and ST elevation MI. So in conclusion, the optimal evaluation for patients with a diagnosis of Minoka after exclusion of other causes for troponin elevation should be aimed at determining the specific cause for each patient so that targeted therapies can be used. Thank you.
Thank you very much to all the speakers. Now the discussion will follow. Over to the chairpersons for the discussion.
Punctually, you have to unmute. You are not audible.
So my question to Dr. Panja, what are the challenges in the vulnerable plaque concept? It's the concept of this visualization and the treatment is mainly focusing on the plaque rupture.
Yes.
And quite good number of the patients with intracoronary thrombosis do not have a clinical events.
No, actually,
and the treatment is mainly focused on the plaque area only, but we have to understand that atherosclerosis is a systemic disorder. And you rightly pointed out in your slide, we have to target at the multiple risk factors which are responsible for the systemic atherosclerosis.
Yes, their question very right. One thing that clinical endpoint of view are aimed to early detection by the IBAS, OCT and needs, but simultaneously you are treating the patients. Why? Because of statin and anti-inflammatory and stent. Our idea to reduce the clinical event, that means MACE, major acute cardio reduce, and unstable engine reduce, acute coronary syndrome reduce. And still, in spite of all the expensive therapy which is available now, 20% cases, again recurrent acute coronary syndrome. That means they are the systemic therapy and stent, at least 20% they are resistant to the treatment. Still yet to explore.
So,
regarding INOCA, there are knowledge gaps also in the INOCA, as there are multiple risk factors which are associated. There are some risk factors which are associated with, which are actually associated with the events, and mainly related to the this coronary, this CMD actually, microvascular dysfunction, and it is not related to all the patients, but in the some of the patients, not all. And any this provocative diagnostic as well as the treatment approach in the INOCA.
Gently, most patients we don't do, but then when you have the facility, if you can do an OCT, if there is some lesion left, an OCT might help find out the cause of the problem. So then we can direct our therapy like that, but we don't do it for every patient. So we can also see whether it's a microvascular dysfunction. We can do the TIMI frame count. We can see if it's taking more time, more than 3 cycles for the blood to reach the end of the cardiac vessels. Then we can think that there is microvascular dysfunction. So even without other tests, even from angiography itself, we can suspect microvascular dysfunction in such patients. And coronary spasm, we might be able to.
Any question from the experts? Any question from the experts?
regarding vulnerable plaque, it's a good talk. As you pointed out, so sometimes you may see asymptomatic plaque ruptures in vulnerable plaque. So patient with a vulnerable plaque, so it's actually overall risk factors. He's a vulnerable patient rather than the plaque. It is only focal disease with a multiple risk factors. We have to comprehensively look at as a vulnerable patient rather than a vulnerable plaque. So there are is no single investigation can find out this vulnerable plaque. It's a multimodality. See, OCT and needs, they come very close to that, but we have to have a CT. So now we have IVAS virtual histology. So what I would like to know, only the now the established treatment is high dose statins. We can make this thin cap fibroatheroma as a thick cap. So other modalities are not much important. So now there was a trial looking at whether we can do the intervention. They recently that prospect absorb study, they put a BVS and studied. It's a randomized studies. Even there they could not able to reduce the acute coronary events by detecting vulnerable plaque. So basically you are telling that patient should have a comprehensive risk management and a medical management rather than the intervention. That is the, because though it is a vulnerable plaque, the prognosis is fairly good. Even in this controlled arm, they had actually less events, only except little angina frequency is little more. Otherwise, mortality and MI was not much.
Thank you, Arvind. Actually, you are rightly point out. See, biochemical marker is very important for index of suspicion. Starting second, rightly I point out the medical treatment, high intensity statin, ezetimibe, anti-inflammatory drug is very useful nowadays. And the regarding the BBS trial, that is the prospective absorb trial is totally failed. And but the current trial, the PECTUS trial, again it is also proved by the BBS PCI. Again the prevent trial also BBS PCI. These cases really is successful and encouraging result. So reduce the cardiovascular mortality, reduce all cause of mortality, reduce the unstable angina, reduce for lead for revasculation. That's supported by the PECTUS and prevent trial only. But this the prospective absorb trial, Greystone is total failure in that case.
Yeah, this large prevent trial, I think we
Yeah, that's right.
get to see the results. I think
Yeah.
prevent trial is examining 1,600 patients. We have
Yes.
to see the results.
Correct.
Regarding Minoka, Dr. Rajiv,
Yeah, yeah.
so, patients we see, what we see, young patients, MI coming with that thrombus, either it is spontaneous resolution or sometimes with fibrinolysis, we see normal coronaries are minimally. But this, do you include these patients also in the Minoka, those who have received thrombolytic therapy and coming to, and when you do angio, the coronaries are maybe minimally affected?
I don't think thrombolysis. There is some disease left, and thrombus done. I think I may not be included.
Yeah, actually they have excluded this, those who have received fibrinolysis.
Yeah.
But when you combine OCT and MRI, so the recent Harpic Minoka in that female patients, when they
Yeah, yeah.
examined, they could able to find out 60-70% of patients having ischemic etiology and another one third
Yeah,
having
yeah.
ischemic etiology as well. So actually, though it is a non-obstructive, their MACE are very high. Even at the end of 4 to 5 years, I think they have significant 10 to 11% mortality and major adverse
Yeah,
cardiovascular events are there. It is only Minoka says that you should be little more find out the ischemic etiology. Probably have to be more aggressive
Yeah, yeah.
in
Yeah,
treatment.
when you once you thrombolize, then you won't know what you started with.
Yeah, but if they
So,
continue to have angina,
yeah,
probably you have to look at the microcirculation and those spasms.
yeah.
Basically, management as a suggestion to platelet with statins and ACE inhibitors. That is
Yeah.
the.
And previously, we used to say everything is recanalized vessel. Whenever you have an MI and you see a coronary which is somewhat normal, if it was not Takotsubo, we will brand it as a recanalized vessel without going to further investigations. But now we know that it's possible, and other investigations like OCT can further help pinpoint the diagnosis.
Regarding calcium, the talk by Dr. Christopher,
Yes, sir.
you see, we do when there is an intermediate risk, as you rightly told, patient is an intermediate risk. So whether to start statins or not, when you are between 7.5, so your ASCVD risk is between 7.5 to 20, 10-year risk. So whether to start statins or not is probably a risk enhancer. If you have a calcium, definitely more than 100, you should start between 1 to 100. So depending upon the, but some patients without calcium also can have an MI. You see,
Very true, sir.
uh,
In fact, that's what I was trying to tell you in the long discussion. There are a couple of groups where you should not rely on the calcium at all. One is the very young group, less than 40. Patients for smokers, patients who come with an acute chest pain. These are patients who have more predominance of non-calcified plaques, which can result in coronary artery disease. So those are the cases in which calcium score will be 0, but you will have a very severe critical non-calcified plaque or a non-obstructive non-calcified plaque which is vulnerable, as was told by the previous speaker. So we have to be very careful in which population we are going to use the calcium scoring and keep these caveats in mind.
The calcium is actually when there is a calcium score, how frequently we have to do, because the as we do calcium score, the risk of radiation is only 1 to 1.5 millisieverts, not very much. Like your mammogram, what we do only to identify the patient who are at risk. Suppose if you find some calcium, maybe if negative predictive value is very good. If it is zero, we can assure the chances of having events at the 10 years is less. Suppose if you find, if you do not find, how frequently you can patient is at a risk. So what is the frequency of getting this calcium score done?
The current recommendation is 5 years. It takes from a score of 0 to be anything near 100, at least 5 years. So that's the current recommendation. Before that, you will not have any value.
So what is your view on statins? When they take statins, it may cause some calcium in the plaque. So what is your view on that?
Yes, so we have to keep in mind the history of statins whenever we do a scan. What is more important is when we do the index scan, as you said, let us say it is about 10. You initiate statins on this patient. At the end of 5 years, when you want to recheck, please remember that the calcium score is going to be unreliable. In fact, it will be more than what you expect because the statin will actually accelerate the calcium deposition. Because as you said rightly, the statin will actually wall off the plaques and actually add to the calcium load. So we have to be very judicious when we're doing the second scan, especially on a patient who is on statin, to interpret it correctly. The second issue is the scan variability. That means if I do a scan today and I do a scan after 3 months, there will be a 15-20% just because of the scan variability, not because the calcium score is increased. These are small things that we need to keep in mind when we are doing it. But for the first calcium score, I think it's not an issue.
Yeah. Though they cause little microcalcification in the plaque, but overall they stabilize the plaque. That is more important. You should not worry about the patient on statins, little increase in the calcium. You should not bother because ultimate is they stabilize the plaque. That is the take home. Okay.
So just one last comment on the Minoka. In our practice, what we are doing in these category of patients, we do the cardiac MRI first. The cardiac MRI is very good to distinguish between ischemic and non-ischemic etiology because of the edema pattern and the scar pattern. Once it is non-ischemic, as Sir has said very rightly, we go in that path, the structural heart disease path, Takotsubo and all those other things. Once we find a scar, subendocardial scar, which is suggestive of an ischemic, then it would be prudent to go into the invasive way, and that will help optimize the cost. So in our center, we're using MRI as a screening tool for Minoka, wherein the ischemic, non-ischemic is very easily partitioned, and we can go into the invasive arm if it is an ischemic etiology. Just a small comment.
I agree totally.
If there is no more questions.
Dr. Saji wants to.
Rajiv, sometimes you have Minoka. Now the people do a lot of OCTs. Then they say, even though it is if there is a plaque rupture versus plaque erosion. So if they say plaque rupture is there, you try to mechanically seal it by putting a stent. And if it is erosion, you can follow. So how does this Minoka patients undergoing OCTs have a therapeutic implication?
The latest HA statement says that both of them should not be treated. It's no advantage of doing it.
Basically, medical management.
Yes, Rabindra perfectly correct. There is some comparative study, deferred study, and proof study prove that the medical therapy versus stent, there is no significant difference. Of course, in the animal experiment, the stent is very, very effective, and still there is some CRT study should be needed.
Dr. Saji, you are not audible. Dr. Saji, not audible.
Please, yes, unmute. Sagi, please unmute.
Yeah. Still muted.
You want to say something, Dr. Sagi?
He's still muted.
I think you are not.
You're not audible.
Sir,
You are not audible.
sir, just unmute yourself, sir, first. Once. No, no, sir,
But
we can't hear.
still there's a problem.
Okay.
Check your
Yeah,
microphone, sir.
yeah. Meanwhile, Dr. Panja, is there any
Yes.
use of evolocumab for if you detect vulnerable plaques?
Yes, I already mentioned that not only aliricumab, evolocumab, and all the three PCSK9 is very, very effective. They reduce the IBAS-derived plaque burden. That is the mechanism action, very, very important issue. Therefore, major cardiac event is drastically reduced and future coronary event also reduced.
It's been shown in the GLAGO trial.
Yeah. There's another important trial, the CANTOS trial. This is also superior than placebo.
Yeah, CANTOS is that monoclonal antibody.
That's
Even
right.
surprisingly,
Canakinumab.
yeah, colchicine. Like they have done a what is called a sub-study of colchicine, evaporate study. Even there is a reduction in the atheroma plaque volume overall. That is another interesting.
Yes. And methotrexate is also very useful nowadays. Prevent the acute coronary syndrome after post-MI. The 3-year study already published.
But that
Great trial.
CIRT did not show much outcomes were not, I think, good with the method.
The
If there are no more questions, so should we? Am I audible now? Go ahead.
Yeah, sir, you're audible. Yeah, you're audible now.
Okay, so now we'll be having.
Thank you very much, all the speakers. It was a very nice discussion. Now we are going to start the debate, which is based on the ischemia trial. Do we need to change our management policy? And the first speaker will be Dr. Debashish Roy, and who is going to speak on yes, I have changed my practice. Sir, continue, please. Sir, you are not audible.
Sir, you're muted, sir. Please unmute yourself, sir.
Am I audible, sir?
Yes, sir. Go ahead.
Okay. So, good morning and thank you to the chairpersons. And for my part, I would like to express quite firmly that after 4 ischemia trial, I do change my practice based on the trial findings. Now, as you all know, the earlier trials like those RCTs done in the BMS era or the recent RCTs like Courage, Mari 2D, the Japanese study, Angina and FAME2, all have failed to show any real benefit of intervention over optimal medical treatment in terms of death or non-fatal AMI. And it is quite understandable that the 2012 ACCAG guideline advocated an initial management strategy of OMD rather than an initial PCI strategy. However, there are several questions that need to be answered. Number one, whether advancement of therapies, especially stents and ischemia-driven PCI, is going to influence the outcome. What about the degree of baseline ischemia? What will happen to those patients who present with moderate to severe ischemia? And what happens to those patients who have a severe disease in the baseline? So, this ischemia trial has been published in November 2019, and has enrolled more than 5,000 patients with moderate to severe ischemia on stress test and were randomized to receive either optimal medical treatment or PCI and are followed up for 3.2 years, has shown that the rates of primary outcome and the secondary outcome, that is cardiovascular death or MI, did not differ significantly between the randomized groups. The all-cause mortality was low in both the groups. The invasive group do have a greater improvement of quality of life, mainly in those with angina at baseline. However, that comes at the cost of greater periprocedural MI. In a parallel trial for patients with advanced kidney disease, an invasive strategy neither reduced cardiovascular mortality or MI nor improved the quality of life as compared to OMT. Now, let us consider this patient, 50-year-old gentleman, hypertensive, diabetic, obese, smoker, presented with class 2 angina and is on nitrate, statin, ACI, and aspirin. So what do we do to this patient? But before proceeding, we should keep in mind two important things, that is the goals. The goal number one is to reduce the risk of death and ischemic events, and number two, we should aim to improve the quality of life. So what we'll do after ischemia? So this is change number one. After ischemia, we'll shift from assessing the ischemic burden of this patient by doing a routine stress test, and we'll put more emphasis on delineating his baseline coronary anatomy by doing a CTCA. As you can see that the amount of ischemia hardly matters in influencing the outcome, whether you are offered an initial invasive strategy or optimal medical treatment. And of course, approximately 15% of ischemia enrollees who have a moderate or severe inducible ischemia were found to have non-obstructive disease on CCTA or on CTCA. So evaluating coronary anatomy is more important than assessing the ischemic burden. And my belief will be further bolstered by the finding from the Courage Nuclear Ancillary Study, which has proved that the ischemia burden in stable coronary artery disease does not effectively identify the revascularization candidates. Now, once we do a CTCA and find a significant proximal LAD stenosis, you know, in ischemia trial, about 87% had LAD stenosis, and of them 47%, the stenosis was located in proximal LAD. So the usual practice is to subject these patients to angiogram followed by revascularization. But after ischemia trial, I will desist from such practice because irrespective of the stenosis from the proximal LAD artery, primary initial invasive strategy has no benefit to offer over optimal medical treatment. In fact, a CTCA strategy doubles the number of angiograms and related exposure to ionizing radiation, and result of ischemia should arrest this trait. So, can we miss out on anything? Of course, we'll miss the opportunity to evaluate microvascular and vasospastic angina, especially in women, which is important because they might result in poor quality of life, and an evidence-based management do exist. You know that only 23% of the ischemia enrollee were women. However, the core CTCA trial is on, which is evaluating the value of initial CTCA followed by invasive angiography in such patients. And till then, if we rely on the core MICA trial result, which has shown a benefit of stratified medical therapy to reduce angina and improve quality of life in such patients, I think the ischemia lesson has told us the same thing. Now, this is change number 3. From initial revascularization strategy, I'll shift to initial OMT strategy. Again, irrespective of significant stenosis, whether it is there in 1 vessel, 2 vessel, or 3 vessels, according to ischemia, there is no benefit of initial invasive strategy over OMT. However, if we have a diabetes patient with triple vessel disease, because of absence of an adequately powered subgroup analysis and in presence of other high quality contemporary data such as those derived from Freedom and Stitch trial will compel me still to consider revascularization in such patients. Now, change number 4. I will shift from biased assurance to shared decision making. I cannot tell my patient blindly that PCI is going to reduce the chance of your sudden coronary cardiac death because it is in ischemia, it has shown an exceedingly low incidence. However, we have always to consider the compliance of the patient to a strict behavioral and physiological risk reduction regime. Still, rather than pursuing upfront coronary revascularization, I'll opt for OMT. And I shall think and act differently if he has renal problem, a recent ACS, unprotected left main, low ejection fraction, NYHA class 3 and 4, and of course unacceptable angina despite the use of GDMT at maximal acceptable doses. So I wish my opponent to speak, to demand, and I will be very happy to answer. Thank you.
Thank you very much, sir. Now the rebuttal second part is going to be by Dr. Viveka Kumar. He is going to speak on, no, I have not altered my management algorithm based on the ischemia trial. Sir, continue please.
Please unmute.
Yes, good morning, friends, ladies and gentlemen. At the outset, I would special thank to Dr. Mohanan and for giving me this opportunity. Coming to this debate, I would say that my learned friend, Dr. Roy, has shown in his last but one slide that in cases where in a routine practice, the intervention is required and where we do our 99% of the cases are the same, where our esteemed friend has shown that he would also agree that he would also intervene in those cases like left main, acute coronary syndrome, the patients who have got LV dysfunction. So he's not saying that his practice is changed. Nonetheless, the debate gets over at this point because he agrees with me that he has not changed his practice. But let's see what the courage had said. If you look at the trial summary, study overview shows that the patient with artery disease were randomly assigned to an initial invasive strategy, an angiography and revascularization if appropriate, or to medical therapy alone. And it also says that the follow-up period you can see is just 3.2 years and there was no significant difference between the group with respect to the estimated rate of ischemic event, and the findings were sensitive to definition of myocardial infarction. But that's not really the true picture. Let's, analyze it thoroughbred and see what it says. So the inclusion in the trial is that at least moderate ischemia on the stress image test with nuclear myocardial perfusion showing more than or equal to 10% myocardium involved, echo or cardiac magnetic resonance, wall motion more than 3/16 segments with stress-induced severe hyperkinesia or akinesia, and cardiac imaging resonance perfusion equal to more than 12% myocardium. But there is, as I said in the beginning, there is inclusion in the trial. Left ventricular ejection fraction less than 30%, history of unprotected left main stenosis more than 50% on prior coronary angiogram or CT coronary angiogram if available. And of course, the acute coronary syndrome patients were excluded. So no debate in this group of patients because practice remains the same because these patients were excluded from the ischemia trial anyway. If you see that initially, if you see the patients who were, supposed to take into this were almost, 8,500 patients, but eventually 2,500 patients were assigned to invasive strategy and 2,591 to, conservative strategy, and almost 1/5, 21% patient also had crossed over to invasive strategy. So I think the data is not correctly presented. If you look at the limitations, again, the reason why I have not changed my practice is that the power were decreased by reducing the sample size from to 5,000, and with a 3.2-year median follow-up, event rate estimates past the median are subject to progressive greater uncertainty. And the primary outcome was expanded as pre-specified owing to slow recruitment, and that also affected the analysis, yet there was no difference between the results of primary and key secondary outcomes data. So completeness of revascularization has not also been well studied in this, and it was non-blinded trial. So there was no sham procedure done to make it more objective and bias free. So what should be the next step in moderate to severe ischemia on a stress test? Do a coronary angiogram or CT angiogram? Does this trial conclude that they should be managed medically without an angiogram? And my opponent, Dr. Debrat Roy, also agrees that in these subsets, we would go and do the invasive strategy, do an angiogram and revascularization. So where the practice have changed, it has not changed. And from initial, as I said, 8,500 patients, 1,218 patients did not had obstructive coronary artery disease, and nearly 500 had unprotected left main disease. So again, such a big, bias was there. So definitely you don't need to change the strategy. And nothing so far has changed in my practice, as these excluded patients were there. LV ejection fraction less than 35%, acute coronary syndrome, which is maximum patients in Indian intervention arm, and left main disease obviously would need, and then heart failure patients, which is again a big chunk in my practice, and advise an angiogram if required after a stress test. So where the practice has changed? None whatsoever. So let's see what it shows and says if the patient is stable coronary artery disease, moderate to severe ischemia, and non-left main coronary artery disease. The primary outcome of death from cardiovascular causes, mitral infarction, or hospitalization for heart failure or resuscitated cardiac arrest. So these were looked at. And secondary outcome, the composite of death from cardiovascular causes or myocardial infarction and angina-related quality of life. So if you see the follow-up of the graph, you can clearly see that the primary composite endpoint, the intervention arm, that is the red bar, becomes better in compared to conservative strategy. Death from cardiovascular causes or myocardial infarction in intervention arm is again lesser. So the graphs do cover, and I think the strategy of continuous assessment and slow recruitment had also affected, but still the patients in invasive arm did do better. So not the separation of the curves, there was statistically significant difference in overall outcomes. The absolute event tended to favor the optimal medical treatment group for the first 2 years, but after 2 years, as you could see, the graphs are changing, they tended to favor the revascularization group. So we need to go for long-term outcomes of no angina at baseline frequency. You can see from their graph that the red bar, which is the invasive arm, did significantly better than the blue bar, which was the conservative arm. So ischemia quality of life, again, this is patients with stable ischemic heart disease and moderate to severe ischemia had significant and durable improvement with intervention. And in patient without angina, the invasive strategy left to minimal symptoms or quality of life benefit compared to conservative strategy. So again, it says that we should do intervention in this. And goal in stable coronary artery disease is to reduce the risk of death and ischemic event, to improve their quality of life. And in this trial, 21% patients in OMT group required revascularization during follow-up. So where the practice is going to change, because 1/5 large chunk of population is going into the invasive arm. So if the trial conclusion was stable coronary artery disease with moderate to severe ischemia and non-left main coronary artery disease, no mortality benefit in selected group of patients, and significant benefit in angina symptoms and invasive strategy was there. So where do we stand in our practice now? My take, chairpersons, ladies and gentlemen, on this trial conclusion would be that if symptoms are suggestive of ischemic heart disease, a stress test is useful to corroborate the likelihood of the diagnosis. After a very positive abnormal stress test, a coronary angiogram or CT coronary angiogram may be useful to rule out the significant coronary artery disease, and further management should be evidence-based and guideline-directed at the very least. And it is imperative that we have late follow-up for the outcomes of ischemia study population, maybe 10 years or so, because we saw that the graph in invasive arm did better after 2 years. So I don't think with this, I would be changing my practice So chairpersons and my friend, my opponent, Dr. Devrata Roy, though he is a friend, but today he is my opponent, that I have not changed my practice based on these factors. Thank you very much for your kind attention. Over to chairpersons.
Dr. Rai, you want to reply?
Yeah, I want to do a rebuttal, sir. Just a short rebuttal. Please allow me. Well, I never considered Dr. Viveka Kumar as my opponent. He is my good friend. I'll just emphasize on 3 points. He raised whether ischemia, is it real? Is it applicable to our real world population? And this is the data of more than 13,000 patients of stable ischemic heart disease from the Japanese Korean registry, which has shown that more than 75% of patients with moderate to severe ischemia were eligible for ischemia trial in that registry. So indeed, in real world, more of the patients, they conform with the ischemia criteria. Next, what about the power of the study? My learned friend raised so many issues about the statistical weakness of ischemia trial, and I would like to present this latest meta-analysis by Sripal Bangalore, published in Circulation in September 2020. It's a meta-analysis which has a firm evidence for which has a power to provide firm evidence for lack of a 10% or greater reduction in mortality with 80% power at a weighted mean follow-up of 4.5 years. And this meta-analysis of more than 40,000 patients were followed up for a weighted mean of 4.5 years with 64,678 patient years of follow-up. Again, emphasized the initial OMT strategy. And I would like to end with this review article by Kit Fox in Nature's Review that progression of disease is in fact dependent on many physiological and methodological factors. And I would like to ask my learned friend, pray tell us which one of these components can be tackled by stenting. Thank you.
Dr. Viveka Kumar?
Yes, so I think the case is already seen that Dr. Roy had to resort to meta-analysis data. All of us know meta-analysis is not the real data. It is, from different subs, so you can't really compare that. Then again, if you see the FAME2 trial data, the invasive arm, so if you are, I'm not saying that you should go and put stents left, right, center. In an era where you have got imaging, you have got functional assessment, you have to, so you can do on-table FFR, and there is long-term data. FAME2 trial has clearly shown that there benefit if you are doing appropriately. So appropriateness of treatment, we totally agree with that. It should be there. Third is that, if we see that the patients who are mainly in our practice come for intervention are the acute coronary syndrome, patients with left main disease, patients with LV dysfunction. So we know historically, right from, body to stitch and all data, that revascularization is beneficial and really indicated of those patients who are at a higher risk or moderate risk. So I think that the case is rested, and whatever we are practicing a very, very genuine cardiovascular intervention, and our practice is not going to change with ischemia trial data. Over to chairpersons.
Yeah.
Thank you very much, Dr. Viveka Kumar. So any comments from the experts?
I like to make a comment. Am I audible
Yes.
now?
Yeah.
Yes, yes.
Yeah. See, the ischemia trial, if you consider the medical treatment arm of the ischemia trial, see, many of these patients develop non-cardiac problems in the future down the line. For example, the patient goes for a non-cardiac major surgery or a cancer surgery. At that time, how do you stratify these patients? These patients who are not revascularized are always at very high risk of taking these patients for these procedures. We always think that the patient only has got coronary artery disease, and that is the only thing which patient is going to have, and the patient will not get any intercurrent illness. Then invasive treatment as well as the conservative treatment may be okay. But if the patient needs a major surgical procedure or major illness in the future, sometime 5 or 10 years down, then these patients become very high risk, very high cardiac risk in these patients, especially with the strongly positive treadmill testing and triple vessel disease. Many times patients may not qualify for major other surgeries like cancer surgery or a neurosurgery or anything. So it may be, I don't know whether it can be applicable in the real world setting if we follow these patients for many years' time. As doctor has shown, Dr. Vivek Kumar has shown that the graph has actually crossed over in favor of invasive treatment after a couple of years' time. I think the graph is going to diverge further down the line. So we really have to see whether it is going to be of use.
Yeah, because here in the ischemia trial, the initial first because they had a peri-procedural elevation of enzymes MIs or 2% in the invasive arm, but after 2 years, actually spontaneous MIs are more common in the conservative arm, that is a medically treated arm. So that neutralized. But if you look at the data in the CARES, we have 12 years follow-up. At that time, we did not have even the drug-relating stents, even our medical management was not that good. Even in this courage trial, that gives really a courage for us. A patient who is stable can be followed up with adequate guideline-directed medical management. Only thing, what I would like to know, if the for all of you, if the patient they have excluded high risk group, LMC has excluded, LV dysfunction has been excluded, ACS has been excluded. So if the patient has a proximal LAD and the patient has moderate to severe ischemia, even there are 47% of the patients in this also had a proximal LAD. What will be our day-to-day practice? Proximal LAD, patient moderate to severe ischemia, and not a, of course, refractory angina has been excluded. Refractory angina is definitely they will go for intervention. Patient doesn't have much angina, he can be controlled with medical management. What is the opinion of our colleagues now, either in the faculty or speakers? So, what would they approach in the real world?
Real world situation, the question will be what will we do if the patient is us or our brother or father? In that situation, what we will do? That is going to be that should be the answer.
True. They are stable. The hard endpoints will not be different. Even then, there is always in the back of our mind some apprehension. So, proximal LAD, large MI. So, always that again, patients here, as the speakers pointed out, there was no sham control in the medical arm. See, that's why probably most of the patient may have, when something is done, they may get relief of angina because you know the probably that orbiter trial we have know there was a sham control. So, I think. Patient, if we had a sham control, that would have probably made little difference in terms of angina frequency.
Yeah, also the crossover was significantly high. Over the period of time, almost 1/5 of them, 22% of them had crossed over to invasive arm. And then as you rightly said, that the proximal LAD is a big predictor. And you see, most get acute coronary syndrome, that is the biggest killer. So, if they get the symptoms, many of them would not be able to reach the hospital right in time. So I would say that, this is not a trial which is addressing the real world issue, and that is why it will not change the practice.
What I believe the most important message from the ischemia trial is that you should shift from uh, your giving any assurance, any blind assurance, and you go for a shared decision. I have already emphasized. Suppose you have a patient with, as Dr. Sagi was telling, suppose you have what you do in a stable CAD with a significant proximal LAD lesion. According to ischemia trial, okay, you subject this patient for initial OMT. But there are certain issues. This is a patient who is following a pretty active lifestyle. What would be your advice? Would you advise him to continue with his active lifestyle? Number two, what will be the compliance of the patient with a strict regimen of drugs and diet and exercise? So there are so many issues on both the sides. And I think ischemia trial is a classical example of the Rosamund effect. I believe you know this. Rosamund is basically a movie which was awarded a prize in Venice Festival. It was from the Japanese filmmaker Akira Kurosawa, and it basically depicts various contradictory statements on a certain issue. So, ischemia trial, I believe, has something for everyone. It has some evidence for both intervention and for initial optimal medical treatment. But what you choose in real world actually depends on your patient, and I think the the final decision should be taken after discussing all the pros and cons with the patient.
Dr. Rai, do you agree with me that during this COVID pandemic, the result of the ischemia trial, timely reassurance to the patients with stable coronary artery disease, differing the intervention, and more focusing on the optimal medical therapy?
Yeah, I do believe.
Yeah, so on the same note, during COVID time, the sudden cardiac deaths were at its highest.
Yeah, but that I believe has a different pathophysiology basis on this.
No, so that's what I'm saying, that,
Yeah.
there is no substitute to, so if you look at the take home message kind of thing, we need to have, rather than biased approach towards intervention or medical management, we have to have a very, very,
But
balanced approach. We should take step by step,
yes,
and
emphasize.
then we should take a good history of the patient, get, investigation of the patient, quantify the ischemia, and obviously the end of the day, the benefit should go to the patient. So we need to do, now we have got access to on table physiological assessment. So it should be, physiology guided, the symptom guided, and the therapy which causes in long term benefit to the patient. So, the stitch trial show that 10 years data was far more impressive than the 5 years data. So, long term, what happens to these patients, that has to be looked over. Then the trials data gets first. Then if you have, significant amount of crossover to the other arm, then again, that's a big problem. It shows that the patients who have covered, crossed over to the other arm, that would obviously mean that, the other arm is doing much better job in relieving the symptoms and the, other outcomes. So that is why most of the patient has shifted there. And, one of the other issue, as rightly said by Dr. Pancholia, that, there is a lot of importance of reassurance and lifestyle modification. So I would say that I would fully agree that in COVID time, in our, chain of Max Healthcare also, and globally also, we saw the data that there was significant drop in acute MI cases. So, in fact, New York Times had an front page article where acute heart attacks have gone. So simply, there is a power of lifestyle modification, and medication should not be underestimated. But everything, if it is done in right place at right time in right patients, I think both the physician and the patients will be the beneficiary.
Recent Jack January this month has come out with an interesting article which supports ischemia trial. It's enrolled about 20,000 patients, and they are followed up with calcium score. And they found out that the total atherosclerotic burden measured by calcium score is what is more important, and the obstructive CAD is not important at all. Actually, we have multiple trials coming in favor, but cardiologists, as like we are trained as stenotic centric, so we find it very difficult to advise not to do revascularization when we find a patient with a tight proximal LA deletion with triple vessel disease. It is very difficult. Maybe time. There's another interesting article which is even bigger than the ischemia trial, which is supported the same concept.
Yeah, so the plaque burden was more
It's more
important than
important
the
than
severity of
stenosis.
stenosis. Yes. So I think, so I mean, the more data, the more different views simply proves that we don't understand the disease yet completely.
What I believe, actually, you cannot do justice to a pan-inflammatory disorder by stenting 5 millimeter of the artery.
So that's true. I think that is why the lifestyle modification and the plaque pacification medications are going to do the trick. So I think that is so. It's like a lot of my patients come and say that, doctor, will I get it again? I said, you cannot get it again if you hold your age. So if you are 50, just be 50 for next 10 years. Nothing will happen. It's part of the aging process, wear and tear and all those things. So there are a lot of other variables in which affects the progression of coronary artery disease. And I think it's more of a aging process, and on top of that you have got multiple other co-variables like diabetes, hypertension, stress, and all those things. So I think this is a complex disease to be addressed with simple algorithm, but definitely the power of medication and lifestyle modification cannot be undermined. At the same time, it is like a fire. Whenever there is a fire, you just douse it with a stent and then let the things work. Rest of the things should work on and continue. So I think that's the way it should go.
Yeah.
So actually, this patient, only 23% of patients were female patients.
Mm-hmm.
Actually, they included treadmill in these
Mm-hmm.
patients. So
Yeah.
that the TMT, how fast the sensitivity and specificity, that too in a female patients.
Yeah, yeah.
So another issue to be discussed. And there is some chat box, somebody is asking whether with this trial, it would be a legal protection. Suppose you do not attempt a PTCA, PCI, just put him on medical treatment. Small percent of patient, again, they can develop MI. Then whether we can ourselves justify, because based on this ischemia trial, the stable patients, there was no need, they can as well be treated OCT. So legally, whether you can have protection. That's one of the question in this, I think, chat box.
Actually, I believe it can go either way, because ischemia trial has clearly shown that if you adopt an initial invasive strategy, it is going to reduce the chance of your subsequent spontaneous MI, though it will come at the cost of an increased periprocedural MI. However, periprocedural MI has little relevance to the long-term outcome. But there are certain gray zones. What happens with to the outcome after a spontaneous MI depends on the definition of MI and the clinical perspective. So I believe these are some gray zones that need to be addressed in future trials. Dr. Pancholia, sir, any comment?
No comments. I had to join another meeting. There's the sub-specialty council meeting immediately. So thank you very much, all the speakers. A wonderful job you have done, and the debate was quite fruitful, and we discussed so many points based on the ischemia trial results. So thank you very much.
Thank you.
Thank you. Thank you,
Thank
sir.
you all. Thank you.
Thank you, Vivek. Thank you.
Thank you, Dr. Roy.
Thank you very much.
Thank you, Dr. Saji and Dr. Ravindran, Dr. Pancholia.
Thank you. It was good talk.
Thank you all very much. Next session will start after 3 minutes, so we'll have a short break, and after that the next session will continue.
हेलो समीर, हाउ आर यू?
How are you? How are you, sir? बहुत अच्छे बात दिखाई दी है.
हाँ जी.
And still we are not able to meet.
हाँ, ये कोविड के चक्कर में बिल्कुल नहीं, पहले ही तो रोज मिलते तो थे।
पहले तो दिन में 10 बार मिलते थे। I think Acha, okay. Otherwise,
When you want to start? Okay. Good morning. This is from the studio of the CSI 2020 Ahmedabad, and we welcome to the CSI 2020 myself, Dr. Jayesh Prajapati, along with my co-host Urmil Shah. Now we are going to start. We are in the studio of Sabarmathi Hall, and we are going to start the second session of today's meeting, and followed by one case discussion, and total 3 talks and 1 discussion. Discussion time will begin after the end of all the 3 talks, and then you can put your question in the box. For the session is the many phases of heart failure, and for that I invite the chairperson, Dr. Rahul Mehrotra, Dr. Manish Bansal, Dr. Amit Vora, along with the expert of this session, Shantanu Sen Gupta, Dr. Ashish Nabar, Dr. Vivek Tandon. So over to you, to chairperson.
Section.
Yeah.
And without wasting any time, we'll straight away go to the first presentation. That is assessment of RV systolic and diastolic function in clinical practice, something which we don't do routinely. And for this, I invite Dr. Sameer Srivastava, who is a very well-known name in the field of cardiology and echocardiography. So over to you, sir.
thank you very much, Manish, and hi, Rahul. So
Good morning.
this morning, this morning I have to justify right heart. Now we know that it is one of the neglected chambers, and possibly because it has a very difficult geometry to understand and to replicate. To justify my talk, let me just give you a case scenario here. 40 years old man, chronic smoker, normotensive, non-diabetic, admitted to a nearby hospital with history of epigastric pain and nausea. ECG showed evolved inferior wall MI or evolving inferior wall MI. Not thrombolized, managed by IV nitroglycerin, antiplatelet, and he developed cardiogenic shock. Once he developed cardiogenic shock, he was referred to EHIRC, and where when we did his right-sided ECG, we found that there was an ST elevation in the V4, V5, V6 too. Now, that was not enough, and we went ahead and did a echo, and this is what his echo showed. This shows that the RV is definitely dilated. There is a RV hypofunction, the contractility is poor, and there is some bit of a right-sided tricuspid regurgitation. Not only that, the mode showed that there is a paradoxical septal motion. And this is what I just wanted to highlight, that if RV is involved, hemodynamically significant, then the mortality is greater than 53%, and around 58% versus 2% for those who have been successfully reperfused. So all of us are very scared when there is an RVMI because it connotes a very poor prognosis. What are the certain signs of RVMI? There are certain primary signs of MI, there are some secondary signs. The moment you start seeing RV dilating, If LV and RV start looking the same size, you are in trouble. Wall motion abnormality of RV free wall is a definite sign that something wrong. Paradoxical septal motion. If your right ventricular end diastolic pressure is greater than 10, or if the RS size increase, or there is a right to left interatrial septal bowing, which means that the right-sided pressures are going up, dilated IVC, decreased collapse with inspiration, and low pressure TR, these are all poor prognostic signs. Here is an example of RV MI, the same patient. If you look at the septum shows a distinct paradoxical motion. I had shown you the M mode. This is the 2D of it. If you start seeing this, this is how it would show in M mode. TR is invariably and always low pressure TR, and this is something which is a matter of concern. Not only that, the RV diastolic dysfunctions can be shown, though not as well validated or prognosticated as it has been done for the LV. The RV diastolic dysfunction can be calculated, and you can calculate the tricuspid regurgitation. Now, when it comes to RVMI, pulmonary regurgitation has a special connotation. If you have a rapid rise of flow velocities to peak levels in pulmonary regurgitation, if there is an abrupt deceleration in mid diastole, the diagnostic accuracy is close to 95% if you have your PhD less than 150 milliseconds. If your lowest mid diastolic velocity versus peak early diastolic velocity is less than 0.5, then the specificity is as high as 89% and the sensitivity is almost 100%. Persistence of PR jet is seen in almost 50% of patients, and there is a diastolic dysfunction which you can calculate by RVDP. So like the left side, there is a myocardial performance index, which is called as TI index. And the standards and the measurements, I'll tell you how to take it. But the normal TI index is 0.2 to roughly around 0.20. And TI index of greater than 0.30 is bad. So you want to have TI index lesser than 0.30 with a specificity of 95% and sensitivity of 82%. Reduction and increased TI index occurs irrespective of thrombolysis and usually settles down in a week's time. This is how you do it. You do your tracings and then you calculate, and you can calculate. This is high RV TI index 0.59, which is not too good. Now, you can use tissue Doppler imaging for assessment of RV functions. It is quicker, easier than biplanar Simpson's rule. Better reproducibility, not dependent on endocardial definitions. And the two ways you can see the tricuspid annular plane systolic exertion is by calculation of TAPSE. And also you can see the tissue velocities at lateral and medial tricuspid valve with RV free wall analysis. TAPSE is easily done, though it has its own limitations. I'm not denying that, but since it is so easily done, as against calculation of ejection fraction. So ejection fraction calculation is something very, very dubious in RV. And that's the reason people have talked about what else to use to evaluate RV dysfunction. So TAPSE signifies shortening of the RV in long axis direction. Lateral and medial tricuspid valve plane displacement is shown. If it is reduced, then it is bad. Roughly around 1.5 to 2 different authors have claimed different things, but less than 1.5 is certainly abnormal. It's a marker of systolic dysfunction, except if there is an apical RV dysfunction. This is a fallacy which happens several times when the RV starts ballooning up. The basis keeps contracting. So because of the tethering, the TAPSE is not hampered. However, there is a LV dysfunction, RV dysfunction which can happen. Not only that, it has an advantage that it doesn't consider the trabeculations or the myocardial dropouts, so it becomes an independent. Now, this is how you do it. At the lateral side, you just put across an M mode and you see what is the topmost to the bottommost. Here, the TAPSE is low, it is 1.29. Not only that, you can start using as annular velocities. If it is less than 10, you are in big time trouble. And it predicts RV dysfunction with specificity of 92%, though sensitivity is poor. But if the systolic annular velocity is less than 10, you are pretty much sure that you are dealing with an RV dysfunction. Decrease maximum early diastolic velocity to less than 8 is also a bad prognostic indicator, and diastolic dysfunctions can be calculated. This is how you do your tricuspid valve lateral annulus TDI. Now, the problem is that it is a kind of a croissant shape structure, and that's the reason why it is so difficult, especially in 2D. Intuitively, it makes sense that 3D would be better, and we are reaching there as far as 3D evaluation of RV is reaching. But if RV could be assessed easily, we have to find out extent to which the compensatory mechanisms utilize to improve cardiac output, therapeutic regimes, predict prognosis, and refine transplant list. So for a transplant list, RV function is absolutely a must. Not only that, you can tailor the therapy for pulmonary artery hypertension, and not only that, you can follow it up too. So these are the guidelines from the Europe, and European guidelines say that there are certain things which you have to do. One is you can't see RV function in isolation, and you have to have evaluation of RA2. Then out of the three, when it comes to RV systolic function, fractional area change, the S prime, which is the tissue Doppler of the systole, and TAPSE. At least one of them has to be done with or without myocardial performance index of the right side, and systolic pulmonary artery pressures with estimate of RA pressure has to be done, and additional pressures of diastolic pressures, RV diastolic dysfunction, these have to be done. So in simplicity, this is sum and substance of what we have to do. When it comes to cardiac dimensions, you have to take it at three levels in the heart, right side. One is at the base. If it is greater than 42, you are in trouble. Mid-level, greater than 35, connotes a bad RV dysfunction. And longitudinally, if it is greater than 86. So roughly it is 42, 35, 86. That's how I have remembered. Not only that, you have to take the RA enlargement also. And this is one parameter which has to be done in end diastole. So end diastole is something which you see, though Q waves are start of systole, but mechanical diastole is at Q waves. So you measure it at end diastole, and if the area is greater than 18 centimeters square, or the major dimension more than 53 and minor more than 44, that is how it is. So this is how you take the major and the minor axis of RA measurements. This is how you take at the base, mid-level, and epic longitudinal measurements of RV. So you have some focused views of RV, which is RV focused view and relative size of RV to LV. Normally, RV is about 2/3 the size of LV, and the moment it starts looking as much as that of LV, though the strict ratio is 0.9. However, visually, if it is almost as big as LV, then you know that there is a RV function which is diminished, or the RV is dilated than LV. Now, not only that, RVOT diameter has to be measured, especially of importance in congenital heart disease and arrhythmias. Amit will bear me out that whenever there is an arrhythmia, you must evaluate your RV for Ruhl's anomaly or arrhythmogenic right ventricular dysplasias. Abnormal is more than 27 at distal edge and more than 33 at proximal edge. Not only that, you have to measure the right ventricular hypertrophy, and greater than 5 is abnormal. Now, this is how you take the RVOT. This is the distal, that's just above the pulmonary annulus, and this is proximal. This is taken in parasternal long axis view. Fractional area change is something which you have to do in end diastole and end systole. And abnormal LV systolic function is if it is less than 35%. This is not the way, because here what you are doing is you are including the tricuspid bulge, which is actually how you differentiate RF from RV is at the annulus plane, and not, it has got nothing to do with tricuspid valve. So if you have to draw a line from here, then it has to include the tricuspid valve, and anything distal to or apical to tricuspid valve is RV, and anything proximal to that is RA. Tissue Doppler imaging, S prime abnormal is less than 10. Pulse tissue Doppler is to be used, and color coded.
Yeah, please. Please, only 30-second left, please. Yeah.
30 seconds? Am I that slow? Okay, TAPSE I have talked about. Myocardial perfusion index is something this is mentioned here. In isolation, we can't talk, so we have to talk about IVC. Just to mention a few things about IVC, it is you have to take it at the subcostal view. Diastolic dysfunction has its own importance, though the numbers vary some bit, but it is exactly done like the way you do it for LV. There are certain gray zones. RV strain is still not recommended, though it is because it is angle dependent, but people are working on it, and 3D volumes may be used for serial volume and evaluation. Here is an example of RV strain, and it can work very well, especially if you have to see in COPD, carpal kind of situation. D-shaped septum means that there is a pressure overload. These are certain things in which you have to take your measurements. This is intraventricular IVC diameter. If it is 5 millimeters with greater than 50% collapse, then the RA pressure is less than 5. If it is large, 25 millimeters or so, if it is the percentage of collapse is less than 25% on inspiration, then the RA pressure is greater than 25. And this is how you take RVH diameter measurements in subcostal view. I'm going to skip through because I think, running out of time. I'll take some questions in the end in case the time permits. There are no geometric assumptions in RV volumes, end diastole, end systole, and I would be happy to just conclude by this statement that RV assessment is a must in cardiac transplant in present circumstances. Left ventricular assist devices, if the RV is bad, you have to put biventricular assist device for whatever work it is. In all cardiomyopathies, arrhythmias, myocardial infarctions, in short, just about in any condition. Thank you very much for your patient listening.
Thank you. Thanks, Samir, for that overview. I know the time is short, but I think there's sufficient time for discussion, so we'll bring up many points during the discussion. Let me now invite Joy, Dr. Joy Thomas, and he's going to allude on what is new in
ERVC.
Hi, Shantanu.
Yeah.
Hi, how are you?
Hi.
Go ahead, Joy.
Good morning. Hello.
Yeah, please go ahead, sir.
Can you see my slides?
We can see your slides and we can hear you well. Go ahead.
Okay. Good morning. At the outset, I would like to thank the scientific committee, especially
Thomas,
Dr.
sir?
Yeah.
Sir, please go to slideshow, sir, please.
So my talk is on what's new in arrhythmogenic right ventricular cardiomyopathy, and coming just after Professor Samir Srivastava's talk on right ventricle makes my job easier. Take this case: 27-year-old housewife who came to me with palpitations and nausea. As you can see in the ECG, the V1 shows a tall R wave after a small Q, and the terminal portion is followed by a sharp deflection, which we all know is the epsilon wave. And this, combined with the T inversion, what you see in the precordial leads, V1, V2, V3, and V4, clearly indicates that this could be a case of arrhythmogenic right ventricular cardiomyopathy. So we do an echo, and in the echo, just to illustrate what Dr. Samir Srivastava has said, you can see the right ventricle is clearly dilated, and the patient had severe LV dysfunction also. Ejection fraction was 35%. She was symptomatic and just having nausea and some breathlessness, but she could carry on with the household work as usual, routinely. We did a cardiac MRI which showed severe biventricular dysfunction, ejection fraction of 30, the left ventricular ejection fraction of 37%, but you can see the right ventricular ejection fraction is only 20%. There was significant dilatation of the right ventricle, and there was significant RV RV outflow tract dyskinesia, scarring and fibrous tissue replacement of the RVUT and some segments of LV lateral wall. What I would like you to notice is that it's not only in systole but also in diastole that the bulging of the right ventricle takes place, as you can see here in the apex, with delayed enhancement also there, and also in the right ventricular outflow tract. So one should, particularly, it is more valuable if you find the outpouchings during diastole rather than in systole. So coming to right ventricular, the microscopic feature of ARVC is a fibrofatty replacement of the myocardium mainly in the right ventricle. But now we know that this can happen either in the left ventricle also, and sometimes in biventricular cases. The ECG hallmark is the sharp epsilon wave, which is seen after the QRS ends, and the dilatation of the right ventricle. There's another ECG finding which is of value, that is the time, the delay in the terminal portion, what is known as the TAD. The normal TAD is less than 55 milliseconds. If it is greater than 55 from this nadir to the termination of the QRS, then it is favoring right ventricular cardiomyopathy. This, along with the epsilon wave, are sure indicators that the patient has got cardiomyopathy. What we commonly see is an arrhythmia, which is of left bundle branch morphology, with an axis to pointing upwards towards the left, as you see in this case, with a white QRS tachycardia. And these patients are at risk of sudden cardiac death if they have got severe ventricular or biventricular dysfunction. Now, this particular slide shows the various parameters on which the diagnosis of ARVC is made. I'm not going to go into all of it, but just some of the salient features have already been illustrated in the case which I have discussed. The echocardiographic features have been very nicely told by Dr. Samir. And what is important is tissue characterization is very important in these cases, and one should go for that, the tissue characterization when one is doing an MRI, and this is very important to characterize. And if your residual myocyte quantity is less than 60% and they are replaced by fibrous tissue, then it is a major point for the diagnosis of ARVC. Family history one always has to go into for at least 3 generations. Now there are this paper which was published in late last year, 2019, discussed some of the issues with the criteria for diagnosis of ARVC. As we know that ARVC need not primarily be limited to the RV, it could also affect the left ventricle and biventricle as well. Pathogenicity of various gene mutations are not clearly defined. Endomyocardial biopsy and endocardial voltage mapping are difficult to interpret, and it is to be used only where diagnosis is elusive. Cardiac MRI must include tissue characterization, as we just saw. Both RV and LV origin indicate different subtypes of the disease. Low QRS voltages in the limb leads indicate that this is an LV origin type of disease. Diagnosis of ARVT in pediatric patients is difficult and should include surveillance of child-related probands, including genetic study. Of course, you should keep in mind the differential diagnosis of RVOTVT, Brugada, RV volume overload conditions, and structural disorders like myocarditis and sarcoidosis. One of the important features of arrhythmogenic right ventricular cardiomyopathy, which makes it a disease which has to be handled with care, is that the patients have got a risk of sudden arrhythmic death. And some of the risk factors which was published in the circulation by Hugh Calkins are that there is a electrical instability, including frequency of premature ventricular contraction and sustained ventricular arrhythmia. The proband status of the patient, the extent of structural disease, cardiac syncope, male, gender, presence of multiple mutations or a mutation in the TMEM43 focus, patient's willingness to restrict exercise and to eliminate participation in competitive or endurance exercise. So these are the risk factors that define this patient. Now, who are the patients who will benefit from ICD? If you look at this pyramid, which goes from the low risk to the high risk, the categories with high risk, which has more than 10% risk of sudden arrhythmic death per year, compared to those with intermediate 1 to 10%. Both these categories will require ICDs. But the class 1 indication are reserved for those who have ventricular fibrillation or sustained ventricular tachycardia. Other features that form a class 2A indication are with an unexplained syncope, NSVT, severe RV or LV dysfunction. And a class 2B indication is those with a Proben status, a male, frequent premature ventricular beats greater than 1,000 per 24 hours, inducibility at EP study, extent of negative T waves, amount of ventricular fibropathy scar, and multiple desmosomal gene mutation. You will not put an ICD in people who are healthy gene carriers and patients with definite ARVC but who do not have risk factors. Now, looking at genetic testing, who are the people who are to be given a genetic testing? It is meant for individuals and descendants with either a clinical or necropsy diagnosis of arrhythmogenic cardiomyopathy. Genetic testing of the established genes is recommended. Now, how do we do it? Genetic testing of established ACM susceptibility genes, I'll come to it in a moment. Comprehensive analysis of all established genes with full coverage is recommended, and interpretation of a cardiac genetic test by a team of providers with expertise in genetics and cardiology can be useful. Now, these are some of the genetic of arrhythmic cardiomyopathy. As you can see here, there is a arrhythmogenic right ventricular cardiomyopathy, left dominant arrhythmogenic cardiomyopathy, then dilated cardiomyopathy, and biventricular. Among all these four, you can see one of the commonest is the PLN gene. But what has been studied extensively is the TMM EM43 gene. As we know, both the left dominant and the right ventricular cardiomyopathy are mainly subepicardial diseases, and this has to be borne in mind when we are going for a radiofrequency ablation treatment. Whereas the classical dilated cardiomyopathy is a mid-myocardial disease. When genetic studies are done, it should be extended to 3 generations of the pedigree, and a genetic counselor and an experienced clinician should conduct this. The first degree relative should undergo clinical evaluation every 1 to 3 years, starting at 10 to 12 years. Cardiovascular evaluation should include 12-lead ECG, ambulatory ECG, cardiac imaging, and exercise testing for arrhythmia provocation is a useful adjunct for cardiac evaluation. What about pharmacotherapy? As we know today in the 2019 consensus statement, if there is RV dysfunction in symptomatic individual, isosorbide dinitrate will help to reduce payload. If the symptoms are primarily due to RV dysfunction, then ACE inhibitors, ARBs, as well as beta blockers, aldosterone antagonists, and diuretics are reasonable. When there is an aneurysm, the antithrombotic therapy is reasonable in these patients. And when there is intracavitary thrombosis with atrial fibrillation or venous or systemic thromboembolism, then anticoagulation therapy should be considered. Now, ICDs are recommended in those with high risk factors, as we saw. If there is inappropriate ICD discharges, beta blocker therapy is recommended in these patients. And if symptomatic patient, despite ICD, amiodarone, sotalol, could be considered. Flecainide in combination with beta blockers can be used. For radiofrequency ablation should be done in those who cannot tolerate amiodarone or continue to have disease. Catheter ablation has been found to be useful, but those who have got more than 3 VTs, their long-term freedom is not very good. For exercise, those who have got genotype positive and at high risk should not take part in competitive sports. Now, all these are taken from the 2019 recommendation. One possible treatment for the future is a transgenic mouse that expresses the mutant video version of the human protein TMM and mimics a human disease, can activate the protein kinase GSK and lead to progressive death of heart cells. This can show as a laboratory model of a condition which
Sir, your time
just
is
10 seconds. There are 2 strategies for inhibiting pharmacological inhibition and overexpression of the calcineurin subunit of C. Take-home message is ARVD, not necessarily right-sided, or can be both left and ECG, MRI with tissue characterization helps in diagnosis. RF ablation are least recurrences when there are less than 2 or less morphologies. Medical therapy, beta blockers, ACE inhibitors or amiodarone useful. ICD in high and intermediate risk cases only. Exercise prescribed in phenotypes and dose with mutation. The future may hold drugs to bring progression of the disease or even to reverse it from the studies of transgenic that express human TMEM43. Thank you very much for your patient listening.
Thanks, Joy. Rahul, are you there? Can you invite Mohan?
I'm already invited.
You are invited, but Rahul may have the privilege of calling you.
Oh, thanks. So, hi.
Please go ahead and deliver a talk on novel device therapy in heart failure.
So I'm sharing my screen. I don't know whether you can see my screen. I don't know. Yeah. So I can see my screen. I hope you are hearing me.
Yeah, we can see your screen and we can hear you well.
Yeah, hi everybody, and big thanks to Dr. Mohanan and his team for inviting me here. So I will talk about device therapy in heart failure, and there's so many things new I'll have to really rush through. So when you talk of heart failure, the number one remains most patients will be at some time or maybe their entire life on pharmacological therapy. The other end is transplantation, but as somebody very rightly said, talking of transplantation as a large scale option for heart failure is like distributing lottery tickets to get rid of poverty. And that is where the filling the gap is CRT and other devices. On one hand, you have devices which look at electrical therapy to change the electrical activation of the heart. The other are mechanical assist devices. So these are the two large classes of devices that can be used in heart failure and increasingly finding their own niche positions. Now, the basis of electrical therapy is that given the same amount of myocardium, you would have a much better ejection if all the myocardial cells were working in synchrony. As compared to dyssynchrony, that is very common and would be clearly seen, best seen, as we have increasingly realized, on the surface ECG by QRS duration prolongation and the QRS abnormalities. So that's the basis of what is called a resynchronization therapy or biventricular pacing. The typical case so far has been the patient, and Samir said rightly that we are all LV preoccupied people. So it has looked at left bundle branch block in trying to resynchronize LV function in patients with reduced LV ejection fraction and heart failure. The way it is done is to somehow pace the left ventricle in synchrony with some part of the right ventricle so that there is synchronous activation of the entire LV in patients with heart failure and intraventricular conduction delay, typically left bundle branch block. And does it work? Yes, of course it does work. A lot of us, including me, we were skeptics how electrical therapy would work in a disease that is purely mechanical. But as you see here, when the ECG goes from a right QRS to a narrow QRS with bi-V pacing, you will start seeing that the same left ventricle cells looking a little more, much better. And with, as with a lot of other diseases, 5% or 6% improvement in ejection fraction is actually converts to huge improvement in outcomes. There's also normalization of the filling patterns. So there's been a long story of biventricular pacing or cardiac resynchronization therapy. The first reports were in the early 1990s, and by the turn of the century, millennium, sorry, it had become a standard of care in a lot of patients with heart failure. It was around this time that I was here in France when Kezou actually, incidentally, is not an electrophysiologist, he's an echocardiographer, very nice guy. He was trying to report the French data from Claude Daubet and across France. And I know the difficulties that they went through. It was around here that we started having bi-V pacing or CRT in India. And at the end of the millennium, it's a standard of care. And as this slide shows, almost all aspects have been studied, beginning with small numbers to as proof of concept to morbidity benefit and also, of course, mortality benefits now. And remember, these benefits are in addition to standard guideline-directed or optimal medical therapy, and that is a big plus. So what has changed? What is new? As operator experience has grown, as the software has become, these devices have become smarter and the hardware has become user-friendly. In the beginning, it was okay to get these patients who were rapidly progressing as downhill to get them back online. But now the expectations have gone up, which is rightly also. We look at responder as at least patients who go back to their baseline state when they contacted medical care, and even super responders. Super responders, again, was something which we thought was a miracle or maybe there was something wrong. But increasingly, I think most of us who do CRT this is the stated goal, to have a responder or a super responder. And clearly now, patients who are class 2 or symptomatic with a low ejection fraction, LBB morphology QRS more than 120 milliseconds is a class 1 indication for this device therapy. So that's standard of care. I didn't know how to put the title to the slide. There are some tricky areas, which some of which Samir alluded to, and some I think all of us see. The tricky areas are patients with atrial fibrillation, because in all biweek pacing, we know that increasingly we need to ensure at least 90% or more of biweek pacing, and how do we ensure that? Patients with right branch block, patients with RV failure, narrow QRS with LV ejection fraction low, patients who are early symptoms. This is something I think most of us have realized. I remember one of the first biweek that I did in Mumbai, the patient was waiting for a heart-lung transplant, was on a ventilator. Those are the kind of patients we were doing at that time, but increasingly we know that if we have to intervene, get that patient from class 3 to class 2 and then put in the device. So are all patients who require bradypacing with some LV dysfunction patients for biweek? That's a question we don't have an answer yet. But it makes sense because there is an element of right ventricular pacing-induced myopathy, which is no longer a hypothesis. We all have seen patients. And if the patient already has a structural heart disease or LV dysfunction, then these patients, you might think that you might need to do a biweek, but can we afford to do that? And what do you do if you don't get the appropriate vein or an epicardial access, or patients who are non-responders? So these are tricky areas, and that's where the new concept of conduction system pacing rather than cavity pacing has come in. And the rationale behind this is that if you see here, this patient has no left bundle branch block, but a right bundle branch block with left axis deviation. And if you're able to pace the His Purkinje system, then you get a narrow QRS, almost like a normal sinus rhythm without conduction delay. The question would be, how do we get a narrow QRS when you are pacing upfront in a right bundle branch block or a left bundle branch block? One of the most plausible mechanisms is that you are actually capturing fibers that are destined to the right bundle or the left bundle in the His Purkinje system itself. So the block is not necessarily here, but the block is up front in the sheets of the His bundle, the fibers of the His bundle, and if you pace distal to the block, you have a normal conduction system or a normal conduction. This is typically how we do it. There's this catheter which tells you where the His bundle is, the diagnostic EP catheter which we use day in and day out for His bundle recording. The lead is a little tricky as of now. It's a 4 French lead with screw-in. It is non-stylus and non-deflectable. So you have to use a preformed sheath which actually directs it to the right ventricular outflow tract. And when you pull back and start seeing the electrogram, His bundle electrograms on this lead, then you find a stable position and screw it in. But already technology is changing, and we have deflectable sheets which should make life much easier. I'm told this is not yet available in India, but it should be available once it's already there in the global market. The other technology for conduction system pacing is that if you don't want to pace here, or you find that and this can all be done while you are doing, these decisions can be done while you're doing the pacing. From the lead, you get to know uh, if the disease is a little more distal, then you can actually go down and trace across the septum and capture the left bundle. This is how it goes, and it captures the left bundle directly, and you have a right bundle branch block and a narrow QRS as you have in biweekly pacing. And going forward, they have even said, and this is brand new in 2020, that if you actually are smart, you could pace with a bipole that captures both the right and the left bundle. Seems very interesting at this point of time, very exotic, but I think that this is possible, at least at this triable. This is again by Xu Zhang, who has actually done a lot of work, and some of us know Xu Zhang for a long time. He's a very, very smart person from China who keeps a little quiet, but he is a very brilliant brain. So I think that's the way to go, and we would soon have bilateral bundle branch pacing as perhaps maybe, if not the standard of care, as an alternative to these so-called traditional biventricular pacing or cardiac resynchronization therapy. Now, we must understand that as we are improving our devices on the that are done in the cath lab, there's also a huge improvement in the ventricular assist devices, whether LVAD or RVAD. And over the years, what was initially brought in as a bridge to transplant is increasingly being destination therapy. And I see that as a great game changer, not only in India, but across the world. Now you see this, I'm just finishing, I'm done. So you see that these devices have become smaller, and as they have become smaller, the outcomes have become better, and you have devices that can soon be put in the cath lab. And once you have devices which are intracardiac and just the cells out, just a matter of time before it becomes a device that is put in the cath lab. And that, like we have seen in TAVR or PTC or whatever, it's a game changer. When people can be treated outside in the cath lab or in the CCU, that's much better than the. So on the whole, I think we've come a long way in terms of device therapy for heart failure. It offers a real great, amazing choice for patients who are in so-called downslope of this heart failure. This will have to always say it's a dynamic subject because there are also game changers in terms of drug therapy available. But I think on the whole, we know that it is not a end of the road if you see any heart failure patient, and you must start talking or thinking in your mind about all the options that are available. Thank you very much.
What is it? 1225. Why is my volume not coming? I can't
Thanks, Mohan. Thank you very much. I think we have sufficient time for discussion, probably 15 minutes or so, and we have our experts also. So, Shantanu and Manish, can you start with the discussion on the first topic by Sameer?
Yeah, sure. So, Dr. Sameer presented a very good overview of the modalities that we use for assessment of RV systolic function. I think the first point to take home is that we should start doing it routinely, something which which many people don't do. And then comes the choice of modality. Due to paucity of time, he could not discuss in detail about RV strain. So I would like to know his views about the current status of RV strain for assessment of RV systolic function, how often one should use it in
So,
practice.
Manish, most of the commercially available machines, it will be difficult to do it because you have to have a dedicated software for RV. LV is captured very easily. RV, you have to switch the sides or do whatever. But it is useful, but not still yet there in the sense that you can use it. It's very easily done. You can do it very comfortably. The only problem is that it is not there for clinical use yet. But let more data build up, and there'll be a space for RV strain to be used in clinical practice and to routine clinical practice. It's something like a LA strain where we know that it exists, but does it have a real utility? We are still debating on that. It will have some utility, but it's still lacking data, and strong data, robust data.
Shantanu, your
Yeah.
opinion about it and choice of the parameter that you use for RV
I
function
think
assessment.
RV strain, TAPSE, and S prime, all three are important. And I agree with Dr. Samir that RV strain, we don't have dedicated software. But what we have been doing is using the LV strain and fooling and using it on the right side. But I think the newer machines are coming up, and I'm sure it is going to have a very nice future, and we need good, robust information and good studies from that. So, Dr. Samir, if I can ask you, between TAPSE and S prime, and if you see that we don't have an RV strain, which one will you pick?
I'll do both. Reason being that TAPSE has its own limitation, because several times you'll find that because of the tethering, you'll have TAPSE which is normal, but towards the apex or towards the RV free wall, there'll be hypokinesia, which is so evident, but TAPSE will be fallaciously normal. So that is the time when tissue doctor will come to some certain help, though it can also have its own fallacies. So if you want to look at the sensitivities and the specificity, one is more sensitive, another is more specific. So either which ways, you combine both, because most of the commercially available machines, they will have both the modalities these days. So you should use both. Though they say that out of the three, fractional area change, S prime, and TAPSE, one of the three should be used, other than the TAR, other than the diastolic parameters. So that is my take. We do it routinely for S prime and TAPSE.
So we have a very good, important question from one of the audiences. For every patient with RV dysfunction, do we do RV strain?
You cannot, because actually I'm not too sure what machine this gentleman is having or lady is having. But if you don't have an RV dedicated strain software, it is not fully justified to use it. You can use it, but that is a makeshifter anyway.
Samir, as a non-echocardiographer expert, let me ask you this question: that often we see reported RV ejection fraction is reported, and you brought out the difficulty in assessing the RV systolic function by conventional volumes. So, is that ejection fraction of any role, value, or eyeballing is as good as with LV ejection fraction?
So the most fallacious aspect is to calculate ejection fraction in RV. Most fallacious.
Yeah. See, RV ejection fraction cannot be calculated by 2D. You need 3D, and very few machines have that option. So if someone is reporting RVEF, then it is, I would say, an incorrect estimation reporting.
Yeah, so I agree with what Manish and Dr. Samir said, that so if you ask me to get an ejection fraction of RV, the best is a 3D RV volume by echo or an MR. So this will give you a better thing. But 2D derived RV ejection fraction should be a no-no.
So I agree with Shantanu. The gold standard for RV volumes and ejection fraction is probably MR.
Joy, can we let me ask you this question, Joy? That in terms of ARVC, uh, now often we are referred with patients who have right ventral output act PVCs, non-sustained VT, and the question comes up of taking up them for EP study and ablation. Do you recommend doing a cardiac MR in all patients to rule out an ARVC before taking up so-called clinically diagnosed as idiopathic RVOT-VT? Joy, are you there?
He is muted.
Joy is muted. Joy, can you unmute yourself?
Okay, I'm sorry, I had muted my thing. Yeah,
Okay.
Amit, I think we have to do an MRI scan because we are going for an invasive procedure. We also have to tell the patient about the chances of a recurrence and to make sure that you don't get into trouble later on because of a cardiomyopathy. It's best to rule out structural heart disease to the best possible. We all know the limitations of conventional ECG and echocardiogram in diagnosing ARVC. And cardiac MRI is very, very helpful in this particular diagnosis, being able to distinguish whether there is a cardiomyopathy. So I do MRI for all my patients whom I take them for RVOT VT ablation, or even for while I'm evaluating them.
Dr. Vora, can I ask a question?
Sure, please.
Yeah, so this is for Dr. Vora, Dr. Nair, and all the EP guys over here. So now we have been seeing a lot of HFpEF, heart failure with preserved ejection fraction, and one of the entities we have started defining is an isolated atrial cardiomyopathy or an isolated atrial problem. So how often do you see patients coming to you who have been ablated, has got some ablation done to the left atrium, come presenting with HFpEF? I mean, do you see this entity now?
Well, can I answer that, Amit?
Yeah, please go ahead. Please go ahead.
Yeah, I think that atrial myopathy is increasingly recognized, and we know that what was known now, in fact, decades ago, that, for example, atrial fibrillation begets atrial fibrillation. You have atrial fibrillation or an atrial arrhythmia giving rise to myopathy, which that makes it more uh, uh, they get to more atrial fibrillation, and so paroxysmal goes into persistent and chronic. But ablation is actually supposed to reverse myopathy. In fact, we follow up patients who have atrial fibrillation ablation, and one of the things we like to see is a change in the or reversal in LA myopathy before we reverse or start thinking of stopping antiarrhythmics and anticoagulants. So I don't think ablation itself could be causing unless you ablated a large part, which we don't do. But surely atrial arrhythmias can cause atrial myopathy just as ventricular arrhythmias can cause ventricular tachycardia. Surely.
Yeah, so I think it's a important.
Peter, is Peter Anand there? There's a lot of echo coming.
Yes, sir.
There's a lot of echo coming. Please ask anybody with a laptop on to switch it off.
Sure, sir. Sure, sir. Sure.
So the reason I was asking is this comes from a case report from Dr. Sanjeev Shah's. He presented, I think it's come in Jack recently, uh, to define whether atrial myopathy causing atrial fibrillation comes first, or post ablation there is more atrial myopathy. I mean, it's a very difficult entity to understand which is coming first. But I think what Dr. Nair you are selling makes sense. But I think in any modality where you can identify it is reversing it. I mean, do you think an MR will help or
Yeah, so
anybody?
I think this is an important clinical problem, and the way I look at it is I look at the atrial size. So often you have large atria. When you have a large atria, it is very likely that it could be a primary myopathy and the arrhythmias are secondary to the myopathy. And then, yes, now cardiac MR definitely helps to look at atrial fibrosis also. So often it would happen that if you only target these arrhythmias, you may not be successful, and eventually, especially with invasive therapy and drug therapy. So various forms of atrial myopathy, not only left atrium, but predominantly right atrial myopathies are known. We have sometimes silent atrium. There is absolutely no electrical signals in the atrium, and the ventricles are completely normal. Sometimes we have to use pacemakers. Sometimes we consider doing ablation, but there is a recurrence. So I think that's a great question. Coming back to Joy, Joy, I would like to ask you again this question that uh, echocardiography diagnosis or even a MRI diagnosis of arrhythmogenic RV cardiomyopathy, uh, it needs expertise. It definitely needs expertise. Now, sometimes we come up with patients who have vague symptoms or few PVCs, and incidentally, when echo or an MR gets done, they get reported as having RV dilatations and some trabeculation or saculations. The patient is not really symptomatic. The ECG is not supportive of ARVC. So he is in that asymptomatic category. But the investigation, echo or MR, has suggested presence of a RV cardiomyopathy. How would you approach this patient?
Uh, well, when there is a doubt about this thing, the diagnosis, and if you have a good genetic lab, you can send for genetic studies. They can add to the thing. The other thing is, of course, by going in for tissue characterization by echo. Like you said, of course, for that you need a very good radiologist. Fortunately, in Chennai, we have got a couple of MRI radiologists who are very good at this. So we tend to send it to that particular person for whenever we have a problem. But looking at the history, looking at 3 generations of the patient, if they do not have such family history and genetic studies, all these things can add to the information. Biopsy and endocardial studies, these are not very helpful, but they also can be the last resort when you are come to a situation where you do not know what else, whether this is cardiomyopathy or this is just ventricular outflow VPDs of a structurally normal heart.
Thanks, Joy. Mohan, now, obviously with the shortage of time, one could cover the entire spectrum. But tell me, what is your take on devices in heart failure in terms of diagnostic devices? Do you think that, the purely the pulmonary artery pressure sensors and stuff like that, it's been going on for quite some time. Do you think they will ever come into clinical practice, or only devices only diagnostic modalities which are incorporated within a therapeutic device will be used?
Yeah, I think that's a very good question, and we've all been attending these seminars on devices where not only the device electrophysiologists but the heart failure specialists are there. It's just a matter of time before we get the right sensors. It's just like the activity sensor, and also we need to have a balance between an oversensing parameter where the beep goes off and the patient is unnecessarily in anxiety, versus a device with a sensor that gives you an alert where you can intervene and stop a hospitalization or an adverse event. So I think it's just a matter of time before we get into the right sensor. It's the way to go.
And your quick comment, you talked about conduction system pacing, and that seems to be probably the future as well. But what is your take? Is left bundle pacing going to be an important tool in device therapy for heart failure?
Yeah, I think increasingly, yes. Left bundle pacing seems to be the way to go. It's a question of your comfort level. So, what we are doing is optimize CRT or hot CRT, where you have the LV pacing lead there. But if it's not a CRT D, you could have the RV pacing lead screwing into the left bundle, and that might be a good starting point. But going forward, a lot of these patients, I think it's just a question of the same way as the CRT. We remember how much, everybody was struggling with the CS lead, and we couldn't get the right leads. And then your own experience increases, and the leads become better. As I said, the reflectable leads have come in. We are just going to do a LB pacing case now. So I think, increasingly we'll look at these things. And I said these are decisions which can now be made in the implanting lab. You go around the his bundle, see if you can get a his bundle pacing and an RF. You probe the left bundle and see if you can get that place. And if not, you go with a conventional CRT. So that's the way I look at it.
Thanks, Mohan. And I think Narsimhan is all set, and we are on time. So, Narsimhan, can you share your screen and start the presentation? It's going to be really interesting in terms of case-based discussion on ICD therapies. Over to you, Narsimhan.
Sir, Narasimhan sir, please unmute yourself, sir.
Okay. Can you hear me?
Yes, we can hear you and we can see your screen. Go ahead, Narasimhan.
Okay. Thank you so much for the kind invitation. Thank you, Amit, Mohan. The topic that was assigned to me is on ICD therapies before, during, and after. Um, this is from American Heart Association. Large population studies have indicated once a patient has a cardiac arrest, even if you do an aggressive resuscitation, the chance of survival comes down and it's practically 0% after 8 or 9 months. I would like to emphasize that the best way to treat sudden cardiac death is to prevent it. Why is this important? Because even if you have a lot of AEDs and very aggressive resuscitation teams, after the first 5 or 6 minutes, you can get the rhythm back, but a lot of them will be on a ventilator with lifelong cognitive dysfunction, especially if the resuscitation after 6, 7 minutes happens. So resuscitation is extremely important. I'm not belittling it, but please understand there is a price to pay for delayed resuscitation. The whole family will be managing a person who's brain dead. All of us agree that when a person dies, the death may be because of a rapid VT progressing to VF, primary ventricular fibrillation. But increasingly in heart failure population, you have sudden deaths because of electromechanical dissociation or asystole. So there are clinical characteristics now for you to understand whether the patient is at a risk of developing VT-VF versus pulseless electrical activity. Let's start with a case. This was an army officer, 68-year-old diabetic, hypertensive, CAD, severe LV dysfunction. And he had an ejection fraction of 25%. And this person had a non-sustained VT on Holter, hence we recommended an ICD. However, because it has to go through several layers and they felt it was not required because the patient didn't have any VT. However, they went out of pocket expenditure and ICD was implanted. And after 4 years, patient had VF, was successfully resuscitated. He has had the second episode after 6 years and he is doing well, almost class 2 functional class. So there are certain phenotypes of heart failure where LV dysfunction, you're able to arrest the remodeling with contemporary therapy, but an unexpected sudden cardiac event can be precipitated and nowadays can be prevented by an ICD. So it's important as a clinician to understand this subset of patients. Now, I'm going to dwell a little on these slides. All of us know ICDs have been shown to reduce mortality, but the magnitude of benefit compared to the secondary prevention trials, if you identify a person who's at high risk of sudden cardiac death and appropriately prevent sudden death with an ICD, over and above the best medical therapy, the reduction in mortality is close to 50% in primary prevention trials. So it's far more, again, important to prevent sudden death in an appropriate chosen patient. Now, the conundrum of giving an ICD for a person with severe LV dysfunction is because of this paradigm. As the functional class increases, suppose you have a person with EF of 30%. As the functional class increases, the risk of sudden cardiac death increases several fold, from two-fold increase in sudden death to threefold, sevenfold, up to class 4. So yes, there is a higher incidence of sudden cardiac death. However, as the functional class increases, there is a much higher increase in pump failure death. And that is why the benefit of ICD is offset because several patients die because of pump failure. So it's far more important to identify severe LV dysfunction and patients with preserved functional class who are likely to benefit from the device. And this was recently looked at by looking at an additional indicator like non-sustained VT, frequent PVC, and syncope or pre-syncope as a marker for sudden death. One thing we forget is the wealth of information about risk of sudden death from a simple ECG. Despite optimal medical therapy, if the resting heart rate is very high, there is early repolarization pattern, especially in the ischemic subset or in HCM, prolonged QRS or intra-QRS notching like fractionation. pathological Q waves or LVH on ECG suggests that the risk of sudden death is quite high. If you start seeing ST segment shifts, non-specific STT changes, prolonged QTC or dispersion T peak to T end are all additional markers for a clinician to fine-tune the decision whether to offer an ICD for a person with sudden cardiac, at a risk of sudden cardiac, low EF. And then the QRST angle. So whenever you have a patient, young individual, especially functional classes 1 and 2, but he needs an ICD, you look at other ECG characteristics, non-sustained VT. In addition, once you've decided that this person will benefit from an ICD, you look at the Holter, look at the sinus rate on optimal beta blockade. If you see an existing sinus rate already at 45, 50 at nights, later on over progression over time, he will require atrial pacing. Unopposed ventricular pacing should be avoided in every person with LV dysfunction. So choose preferably a dual chamber ICD if the sinus rates are very low at nights in a person where ICD is contemplated. If the patient doesn't, even if he doesn't have heart failure, but you are contemplating on an ICD, and the patient happens to have a left bundle branch block, please consider CRT. This is from MADIT CRT. We can see clearly CRT-D improves survival as well as heart failure hospitalizations, even in functional class 1 and 2. When an ICD is contemplated, please give a CRT-D to these patients. This is a patient referred for ICD. When you have this kind of recurrent VT, VF storms and PVCs, this is not when you consider an ICD. So please make sure that this patient is adequately treated. You have taken care of the arrhythmic substrate, either by pharmacological therapy or catheter ablation. And the ECG should not be having frequent arrhythmias before you start contemplating on ICD on this patient. Let us see what happens if you put an ICD in that kind of a patient. This 50-year-old lady, anterior MI, had a PTCA about 2 weeks ago, then presents with VT. She had VT on the 3rd and 4th day, so a pre-discharge ICD was implanted. And so this patient presented with a VT storm, and ICD kept on shocking after shocking, intubated, ventilated, VT continues, IABP, VT continues, and then you do an overdrive pacing, VT continues. Please understand there is a price to pay when the VT continues like this. It has a significant impact in the hemodynamics. Patient develops hypotension, fall in urine output, and lactic acidosis, and what to do next. So this is the stage when most of us would be called in. You need to ideal therapy, which has been proven to be of use, is a combination of amiodarone and of course IV procainamide, which we don't have access to. In our context, we use a combination of IV amiodarone and lidocaine to suppress the VT, in addition to sedation and ventilation. One word, the single most drug which shows an improvement in survival is beta blocker. And among the beta blocker, there is a clear evidence that the good old non-specific beta blocker like propranolol is superior to other drugs like metoprolol in reducing the VT storm and improving survival in these patients. As a clinician, when you're treating this person, if suppose I give 150 milligram of amiodarone, patient doesn't respond, you make it 300 and then give another antiarrhythmic. There is a finite limit to which there is a difference between ED50 and toxic dose, and efficacy versus toxicity. There will be a trade-off as you increase the dosage. You will convert the death from a VT death to a pulseless electrical activity with very high doses of antiarrhythmic. In these situations, you need to use an intra-aortic balloon pump, overdrive, preferably atrial pacing because it won't alter the hemodynamics. But if the AV conduction is poor, you may have to do ventricular pacing, sympathectomy if required, and as a last resort, substrate ablation or trigger ablation or radiofrequency ablation. Please make sure when you discharge the patient, even if you have given a dual chamber ICD, the patient's V ventricle should not be paced. You need to prolong the AV delay, and this is appropriate programming where there is an unnecessary ventricular pacing, this patient will come back to you with heart failure after 2 or 3 months. So please avoid minimize the ventricular pacing. At discharge, optimize all medications. Please consider the substrate resolve continues to evolve in these patients, hypertension, diabetes, use of SGL2 or statins and antiplatelets, all are important when addressing a patient with an ICD. Avoiding inappropriate shocks, because inappropriate shocks has a significant impact both in terms of psychological well-being and worsening heart failure hospitalization. And the data suggests that prolonged detection periods, especially in patients with primary prevention devices, in fact, improves the survival and decreases mortality. This is a patient, a young gentleman with an inferior wall MI, severe LV dysfunction, and recurrent VT, given a device. Unfortunately, he was programmed inappropriately and came with multiple episodes of VT therapy for a sinus tachycardia, which was inappropriate. And this patient is a classic example of inappropriate programming. So how does the device work? It VT from looking at the RV lead. So make sure that the RV sensing is extremely important. Unlike the pacing threshold you check, you need adequate sensing in an ICD, and prolong the duration of detection in primary prevention ICDs. Once the tachycardia is detected, you need to put the enhancements. There are several discriminators which can discriminate and tell you whether it's a sinus tachycardia in the VT zone or in atrial fibrillation. If it's AT, AF, or patient with sinus tachycardia, you should not initiate VT therapy in terms of shocks, and you should be able to suppress the therapy. So, for example, if you have a young individual with heart failure during walking, it is very easy for these patients to go to a rate of about 150, 160 on walking. But the devices can calculate the previous RR intervals to the next 4 RR interval, and the onset criteria helps to withhold therapy and decide when the therapy is abrupt or when it is gradual, and then you can withhold therapy for inappropriate sinus tachycardia. Similarly, devices nowadays are very good algorithms to match between the sinus and the VT. And if it matches more than 95%, it's more likely to be a sinus tachycardia, but VTs will not have any match. But having said that, you need to individualize this. Whenever you program a device, your aim should be to prevent inappropriate shocks and try to terminate the VT by anti-tachycardia pacing, because anti-tachycardia pacing is very effective in almost 70 to 80% of VT termination, avoids inappropriate shocks, improves quality of life, and lengthens the battery life of the individual. And there are specific algorithms, several publications. I'm not going into the details. Roughly about 8 stimuli per train, and cycle length of anywhere from 84 to 88% as the coupling interval for the tachycardia cycle length. So appropriate programming is not theoretical. It significantly, for example, inappropriate programming, and you have persons with frequent ICD shocks have a higher mortality compared to high rate therapy when the device is appropriately programmed and withholds inappropriate shocks in a given patient. So improved ICD programming to high rate more than 200 beats per minute for a shock and a long detection interval of 60-second duration is associated with significant reduction in inappropriate therapy and a significant 50% reduction in all-cause mortality from this MADIT trial. So, Chairman, ladies and gentlemen, it is extremely important to optimize medications depending on the substrate before and after the ICD therapy, and because they continue to evolve in a given individual. So choice of device is crucial, whether it's a dual chamber ICD. If it's dual chamber ICD, minimize the ventricular pacing. If a person has a left bundle branch block with ICD, give a CRT in addition. It's important to discuss these options with the family. Programming the ICD therapy should be individualized. Please use delayed detection and high rate programming for primary prevention, and bring in all the discriminators on to prevent an inappropriate therapy for a given individual. Thank you very much for the patient listening. Thank you so much for the kind invitation.
Thanks, Narsimhan. As always, it was a very informative session. Narsimhan, let me ask you this question. We have a couple minutes. What is your take on indication for ICD implantation as a primary prophylaxis in the non-ischemic cardiomyopathy group? How do you approach such a patient?
Okay. There are broadly non-ischemic cardiomyopathy stems from two broad categories of devices. I mean, etiologies. One is channelopathies or genetic mutation. The other one is inflammatory cardiomyopathy. Inflammatory cardiomyopathy, when they have this, we have a lower tendency to give a device, irrespective of whether there's an MRI scar or no scar, because you know that the patient's sarcoid, there'll be a reactivation of sarcoid several years later. Similarly, when you look at the ECG and the patient's family history, if there is a family history, there are certain markers. For example, lamin AC mutation, even if it doesn't have a MRI showing a scar, it has a very high arrhythmic potential. We tend to give a ICD at our threshold is very low. Similarly, certain mutations like dystrophin mutation, the arrhythmic risk is very low, and the patient doesn't have a scar on MRI. I would prefer not to give an ICD and manage on medical therapy. So gone are the days when genetic testing or just theoretical basis, they have a significant impact on patient management. Certain genotypes are associated with a higher arrhythmogenic risk. Combined with an MRI showing a scar, I would have a lower threshold for giving devices for those patients.
So, would you say that you would like to do a cardiac MR in most patients with non-ischemic cardiomyopathy to look
Yes,
at
all the
myocardial scarring?
patients, all the patients with non-ischemic.
So this has not come up in guidelines as yet, but you think this is strong enough for us to use it in clinical practice?
I think so. So if a person doesn't have access to MRI or the patient cannot afford, you can look at the ECG markers of scarring. For example, if you have a very low amplitude of QRS, you have a notching and fractionation of the QRS, those are indicators that the patient is developing an evolving substrate. B1 to B2, loss of R wave, TV1 more than TV6. These are all indicators that you are having substrate which may warrant an ICD at a lower threshold.
Joy or Mohan, you had any comments to make?
I really agree with Narasimhan and the point raised by you regarding non-ischemic cardiomyopathy and primary prevention. There seems to be, it's not something which is we are so confident doing. So I think that the MRI magic number seems to be 50% more or more of fibrosis. And more importantly, there again, as you said, it's not hard and black and white. But I think that what Narasimhan brought out is extremely important. I look at the QRS. A QRS that is not normal, a QRS that is wide, the QRS that is notched. You look at the QRSs which are notched, these patients don't do well. So there, I think they're very simple, I mean, you look at these, and increasingly we see, patients who have QRS which was notched, same QRS width, they don't do as well with anything. So that's QRS notching and QRS width have been not given the same importance. Actually, just look at the ECG and you can do everything. You don't need to have an MRI. I'm not saying that we don't do MRI. We go by the protocol, but that's where it is.
Absolutely. I think the good old ECG. I think it's an appropriate way to end the session. We had a great session, but ECG remains one of the most important tool in arrhythmia management. I think wonderful session. Great job done by all speakers and my co-chairs and experts. Thank you very much. We are on time. Let's wind up. Thank you.
Thank you so much.
Thank you.
Bye, Narasimhan.
Thank you.
Bye.
Bye, everybody else.
Speakers, now we end up session here. Now we move on to the next session, lunch on session. We start at within 1 minute's time.
Yeah, Dr. Soumitra Roy and Dr. Dhiman Kahali are there, and we are all here. 3 of us are here. I suppose there are only 3 of us.
Yeah. Afternoon.
Yeah, I
Good
think
afternoon,
we should
Tiny,
start now.
Shomitra.
Good afternoon,
Yeah,
Tiny and
yeah.
Yeah, we can start.
Just three of us, I suppose. Yeah, yeah. So, this is a luncheon session, and I think this is a very important session. And being a Zoom session, nobody can run for lunch and skip this session. Now, this is on hypertension, and basically, we are talking about hypertension therapy. To talk about that, we have two eminent experts here. We have Dr. Dhiman Kahali, Professor Dhiman Kahali, who heads the Department of Interventional Cardiology at BM Birla Heart Center, and Dr. Soumitra Ray, my close friend. He is from Vivekananda Institute of Medical Sciences, Kolkata. Now, both of them are, as we know, not just experts, they are closely linked to all CSI activities. And they have contributed, both of them, in a big way in understanding and development of the science of hypertension in India. So I think you can't get a better faculty than this talking about hypertension. I am Dr. Tiny Nair. I head the Department of Cardiology at PRS Hospital, Trivandrum. So uh, we all know that hypertension is very important. And in India, perhaps about 30% of the population has hypertension. And hypertension is the leading cause for cardiovascular death, right? But that is not important. What is more important is that apart from death, hypertension accounts for a lot of debility. And that debility, if we see whether it is stroke, whether it's TIA, or maybe a disabling angina, or maybe heart failure, or claudication, CKD, or whatever, it damages a person significantly. And that is why when we look at DALI, for example, DALI, death plus disability adjusted life years, we see that India is on the top of the list as far as hypertension is concerned. Now, the other side of it is hypertension is so easy to diagnose. You just need a BP apparatus and a trained person to diagnose hypertension. And we have extremely good drugs which are safe to use. But despite all this, we are very poor in both diagnosis and control. We know about 8.5%, 8.9% of people who are at goal in hypertension management in India. So with that, the first question, Dr. Dhiman Kahali, the first question would be that we know that there is a lot of problems in India in tackling the problem of hypertension in diagnosis. We have problem in treating, problem in persistence, in everything. In that background, where do you put compliance? It's very vital we understand, but tell us as to where it stands and how best we can tackle the problem of compliance of therapy in hypertension.
Yeah, Tiny, you have raised a very important question because we find a lot of patients, as you have mentioned, that in India, almost 85 to 90% of the patients are not well controlled, even if they are diagnosed. So it's very important to find a non-compliant patient. And in cases of resistant hypertension also, we find non-compliance is a big problem. Now, the major reasons for non-compliance, number one, it is the pill burden. If we give too many pills, the patient doesn't take the pills. And then prescription drug costs. If the cost of the drugs is too high, because we know there are certain drugs which are costlier unnecessarily than the other drugs. So prescription drug cost, if it is very high, then of course they won't take it and the patient becomes unnecessarily hypertensive. Besides that, the side effects of the drugs are also very important. Just to tell a few, like atenolol or chlorthalidone. Chlorthalidone is a very valuable adjunct in ABC treatment, and we know about it. But we also know that it produces so many side effects: hyponatremia, hypokalemia, and sometimes we do not take into account if we give to a young individual, the patient sometimes becomes impotent. I have a patient who tells very vividly. I was surprised. I was looking at his face. He came and told Dr. Kahali, you have been giving the other medicines. Those are very good. But after you have changed to this clothalidine moiety, I have become impotent. I am a young person and married for last several years. So you should do something. And as I stop the drug, I again gain back the potency. So such a vivid description. So I immediately stopped it and gave another cocktail or combination of therapies. So we must have into account that the patient, how well he is doing, and whether he has got any side effects of the drugs, like insufficient time to the patient. We doctors are all very, very busy in our clinics, in our hospitals, and we can't give adequate time to the patients. That's very important. If we are so busy that we cannot give adequate time, we should ask our assistants, the sisters, the paramedical staff, our secretaries, or we can have a chart where the lifestyle modification measures are mentioned, how to take the drugs, when to take the drugs, because there is dilemma. Like in Eugene Bronwell's book, it's still written that it should be given in empty stomach in the morning, but now majority of us are switching to give it in the evening time. And there are some other, points that is, I should pay non-compliance on our part, that is under treatment of the patient. So sometimes we do not give adequate dosage or optimal dosage as we should tell of the drugs or properly or a drug combination. And as a result, the patient has got some reduction in the blood pressure, but not to the desired level. So it's very important that we should give optimal dosage and optimal medications. And sometimes some other factors we should give notice, like if a patient has a normal high blood pressure and the patient is a boozer, he drinks heavily. I have to give few minutes time to the patient that please don't drink too much. You become a moderate drinker, you find your blood pressure will come down. Second, obesity. If a patient is severely obese and we are giving, adding one after another drugs and the patient is not getting a blood pressure at our desired level, we should have to ask the patient that please reduce your weight. I have a patient whose blood, young patient, very, affluent, globetrotter, has his own plane, but he had a blood pressure of 170 by 110 and I was giving AC inhibitors, ARB, and a small dose of diuretics to control his blood pressure, and all in a high dosage. But the patient weight was 85 kg. So I asked him to reduce weight and to go for gym and all these things. So he became 60, 61 kg and he practices lifestyle. You won't believe that his blood pressure is at present 110 by 70 millimeter of mercury. So what is in the written in the book that you go for DASH diet, your systolic pressure will be lowered by 3-4 millimeter, diastolic by 1-2 millimeter. Again, you go for physical exercise, it will be reduced by 3-4 again and 1 or 2 millimeter. It's not the end of the story. If somebody practices lifestyle measures very well, he can get his blood pressure down from 170 by 110 to 110 by 70 millimeter of mercury, because we should not forget that after 115 by 75 millimeter of mercury, each 20 millimeter mercury increase in systolic and 10 millimeter mercury increase in diastolic, though both are normal blood pressure, increases the mortality by 200%. Then exercise, excess of salt, that's a major reason, in our society. In US also, the average consumption of salt, though by ACCHA, all are telling that you shouldn't take more than 5.7 grams of salt, which contains 2.3 grams of sodium. But we don't adhere to it. In US, the average consumption in males is 10.7 grams per day, and in ladies is 7.3. So we should have to give some notice that whether he is taking proper restriction of salt. And everything has been done. At last, we find the pressure is not coming down. The patient has got obstructive sleep apnea. If we don't give notice to that, the patient won't. So these are non-compliance on our part, that is physician part, and we have to give proper notice to all these factors, because controlling blood pressure, as you have been telling at the very onset of your lecture, that it's very important to look at the global risk factor, the global factors which are predisposing to hypertension. And unless we take care of everything, only giving drugs can't bring down the blood pressure, and that may be told as non-compliance of the patient. But not only non-compliance on the part of the patient, but also on the part of the physicians, like not giving adequate time, giving a cocktail of drugs which can produce side effects, a very costly drug prescription, too many of pills. So we want to give 3 pills in a single drug. We often do it: calcium blocker, ARBs, and small dose of diuretics. So I think that will solve the issue. So we have to look at each and every point in detail, like heart failure patient, so that we can prevent the disease, because we should not forget the fact that in India, the burden is very high, as you told rightly. 30 to 35% of the urban population are suffering from hypertension, and many of them are very young. And the huge burden of it in US, 80 million patients are suffering, that is 8 crore, and globally 1 billion, that means 100 crore population is suffering from hypertension. And in 2030, it will increase to 150 billion. So having such a huge burden, and which is easily preventable, which is easily treatable and curable, if we take care of all the factors, we should be very, very cautious as physicians in educating the patient, I think.
Absolutely, I fully agree, Dr. Kahali, on what you said, and it is a big problem. Compliance is a big problem. So from there, let us come to something else. We know that one side we are talking about lack of compliance, and we are talking about more pills patient may not take it. On the other side, we are talking about blood pressure goals. Let's say it has been coming down, right, from 140 over 90 to 135 over 85 to 130 80, and now we are talking about 120 70. Okay, right. So every day we are seeing different lower and lower goals. So, Dr. Soumitra, let me come to you. Uh, uh, do you see that with this compliance problem and the goal coming down and down, every single patient, apart from maybe those like ESC says, very frail or very elderly or borderline, everybody going for a combination therapy? What would be your take on that, Dr. Soumitra?
Yes, Tiny. Thank you, Dr. Kahali, first to give a very nice sum up of the preventive aspect and the lifestyle management of hypertension. That remains the rock solid basis. On that, I can start my talk about pharmacotherapy. Now, as you were saying, that the goal and the threshold for diagnosis is coming down, though there is some controversy about the threshold, whether 140/90 or whether 130/70, but across the Atlantic, the goals remain the same. That is 130 by 80 millimeter of mercury, that should be the goal. And that is fortunate because we are less confused. Once we decide that our patient needs blood pressure pharmacotherapy, we know that we need to achieve a figure below 130/80. Now, as you say, this very nice meta-analysis review came about 10 years ago of all the big blood pressure trials available at that time in 2012 or something. 7 big trials were taken, the most big trials like ALLHAT trial, like HOT trial, like ACCOMPLISH trial, ABCD trial, which showed the average number of medicines required to bring the target is 2.5 to 3. Now, as you cannot break the number, you have to give 2 or 3. And as the number is more than 2.5, so by mathematics, it means that you require 3 medicines to achieve a target. And out of those 7 trials, 3 trials showed that you required 3 to 4 medicines to require your target. What was that target? The systolic was between 135 to 145 they achieved, because their goal was 140. And some achieved it, some did not achieve it. But 135 to 145. Now, if we say your goal is 130 and below, you can easily understand that even 2 is insufficient. You require 3 medicines to start with. So, but still, I would say at least to start with, as you mentioned, excepting in very few young and newly diagnosed mild hypertensive with the 10 years cardiovascular risk of less than 10%, there you might start with monotherapy. But even with that, monotherapy achieves your target in around 40% of patients. In the Kaiser Permanente, there is a very big community-based meta-analysis going on in north of California. Kaiser Permanente, it is funded by an NGO, a very big NGO. It showed that if you start with 2 drugs at least, then more than 85% of your patients achieve the target within 3 to 6 months. And it was a huge community-based study. So you see, you might say, okay, there is always time, I can step up my medicine. But then you are losing 3 months to 6 months. You are already diagnosing the hypertension, you know when. As you said, that 80% of hypertension is not diagnosed. So when you are getting a chance to diagnose hypertension, target organ damage is already there. And you are still delaying for another 3 months, 6 months, 1 year by what Dr. Dhiman Kali said, clinical inertia. Clinical inertia. So if you start with a combination therapy, particularly fixed dose combination, your inertia part is taken care of, patient's compliance part is taken care of, and you are sure that at least in majority of patients, you are achieving the target within 3 months without further end organ damage. So I am a strong believer and proponent of the European guideline, which says except in a few specific condition, you start with two drug therapy, particularly in a fixed dose combination. Now that is another issue, whether you will give a fixed dose combination or separate or giving split dose morning and night. Perhaps we will come back to that in the later part of our discussion.
Yeah, but hold on for a moment. See, okay, just for argument's sake, this concept of single pill, multiple drugs, all of us now follow that, right? But that is how many years? Maybe about 3, 4 years. Now we see so many of our old patients who come for follow-up. I'm sure you have, I have, all of us. They come back with maybe taking very small dose of a single drug for years together, and they are fine. Doctor, how are you? They will ask. We will say, oh, blood pressure is normal. What are you taking? They might be taking one very small dose of telmisartan, 40 milligrams, or somebody said I'm taking amlodipine of 5 milligrams, or somebody is taking something maybe indapamide of 1.5 milligrams. For how many years? Years long, and they're controlled. So don't you think that if we give combination to everyone, these patients will be overdrugged? Just thinking about it.
I have got an answer for that. If you stick to European guideline, that is beautiful. There is a huge scope of de-escalation. So as soon as your pressure is going below 120 to 170 by 70, you are allowed, not only allowed, you are advised to reduce the medicine. So what is important, as we are doing in sugar with cholesterol, same as blood pressure, we hit it hard at the beginning. Then you sit back and you see if the blood pressure is falling. At least you know that blood pressure is falling, you have got below 120/70, then you take off the second drug. You keep one drug. What is the harm in that? Except in
Exactly.
a few cases of
Correct.
postural hypotension, maybe
Correct.
that you
Correct.
can always monitor.
This is what I wanted to come out, that people are bothered about getting too many drugs. You can always de-escalate. I mean, that is the thing that we should, and as you heard from the experts, that is what is important. But how many of us do that? I think we should follow that. When a patient's blood pressure is controlled, we should try to de-escalate. Now,
De-escalate,
moving,
yes.
yeah, de-escalate. Now, moving to the next point, Dr. Kahali, if we are talking about combination, let's say in one single pill, we are talking about combination, and now we have got ASARB, we have beta blockades, we have calcium antagonists, diuretics, we have a host of drugs. Now, from the pharmacological point of view, what would you recommend as the ideal combinations that we can think of?
See, Tiny, you are posing very good questions which are very practical and pertinent. So, I just quote Eugene Braunwald's words in his latest textbook that we should go for we usually go for the combination of AC inhibitors oblique ARB plus calcium channel blocker. And he has also mentioned about the molecules. For ARB, he goes for telmisartan or irbesartan because both are proved in major trials that they are efficacious and their action is quite acceptable. And regarding the calcium blocker, it is nothing else other than amlodipine, which is time proven and which hasn't got any metabolic monitoring is required because in a country like India, that's very important. And he mentions about a dose 40 to 80 milligrams for telmisartan and 150 to 300 milligrams for irbesartan and 5 to 10 milligrams initially for amlodipine. As both of you and Dr. Roy has mentioned, that over the time we find that in combination therapy also the usage of the drug or the need of the drug combination comes down. Sometimes we can make instead of 10 amlodipine 5 or telmisartan instead of 80 or in some cases even 120 we can come down to 80 or 40 milligrams of telmisartan. And usually we prefer it as combination because of the uh, reasons we have told that the patient becomes non-compliant. So that being a problem, we want to give it together. Usually in the evening, I used to give in the morning because as Soumitra was telling, in Brownwell's book, still written that the blood pressure 140/90 or above is hypertension, the latest textbook. But we know it has been changed to 130/80 globally. So like that, he tells that you should take it in the early morning. Even if you go for urination, you take it in the very early morning. But some of the recent data have taught us that we should take this combination in the evening or at bedtime. I give it preferably before the dinner because the absorption will be complete except for carvedilol. And so we prefer a combination of sartans mainly because cough is a problem, and 25 to 30% of the patient in my practice I find I give good AC inhibitors and they come with some sort of cough. And also from our experience in India, we have found that its sartans are better than the AC inhibitors in controlling the blood pressure. They're little better, and we can go for a better dose of them. And regarding the third drug, which is required sometimes, we give chlorthalidone or indapamide. Indapamide is a very good drug. We can start with half a tablet of 1.25 milligram. If we give chlorthalidone, 12.5 milligram is better. And both the drugs are much better than the time-tested hydrochlorothiazide because unfortunately chlorthalidone was not available in our country for long, and now it is available. Half-life is more, and so the problem with hydrochlorothiazide that you give it in the morning and after afternoon the effects are gone. So the patient's blood pressure again shoots up. So that's not a problem with chlorthalidone, but being a stronger diuretic with a longer half-life, there are some problems with chlorthalidone too. So the best practice is to try the lowest possible dose of chlorthalidone. So I would go for tiny for sartans as predicted by the authorities like Eugene Grunwald that you give a dose of 80 milligrams and 5 milligrams of amlodipine. Amlodipine is time tested. Only problem with amlodipine is that if you give a dose of 10 milligram, there is pedal edema in 20 to 30% of the patient. But along with telmisartan, the incidence of pedal edema is also less with amlodipine. And if we give a dose of 5 milligram, the incidence is further lower, the incidence of pedal edema. Another problem with amlodipine, if we give on a long term, even on a dose of 5 milligrams, we have a patient who is a doctor here registered and her mother. So she has gingival hyperplasia. That is a problem sometimes we find, but the remedy is very simple. You stop amlodipine and it reverses. It goes down unless it is, for long period it has been present, and that causes some dental problem. So we should look at it once they come, once in a while, at least in a year or 6 months. We should look at the gums, whether they're in a gingival hyperplasia. So it's good to have a combination of drugs, and I think telmisartan, because if we give telmisartan alone, as you have been talking, that what is the problem? Because if you give a small dose, no problem. But if we give in a middle-aged person, sometimes we don't calculate the EGFR, and the EGFR being borderline, that can cause AKI, especially if the patient is hypovolemic, a dose of 80 milligrams, or sometimes we go even for higher dose of telmisartan to reduce the blood pressure, or RV-sartan, suppose at 300 milligrams, that can cause unabated hyperkalemia or some deterioration of renal function, precipitating in acute kidney injury. So these being the possibilities, I think a combination, we can reduce the side effects. They have synergistic effect, as it is called, like low salt diet has a synergistic effect on all the molecules of hypertension, antihypertensive drugs. Like that, if we give a small dose of telmisartan, or irbesartan, small dose of calcium channel blocker like amlodipine, we can have a synergistic effect. And the side effects, as all of us have been discussing, comes down a lot. And that synergistic effect and the virtue of each drug with minimal of side effects makes it an ideal combination. And therefore, European Society, American College, everybody is telling that go for a combination of drugs at the earliest of blood pressure detection so that the blood pressure can be cured or can be brought into under control very effectively, and the compliance also is much more, as it is happening in the Western countries. Because of their systematic approach, they are controlling, not only controlling the blood pressure, but the patients are also compliant.
I fully agree. But so we see that Dr. Kahali clearly prefers a combination of RAS inhibitors with a CCB to start with. And then only second option would be maybe a diuretic and a RAS inhibitor coming in. And obviously, three would come in if two are not controlling it. Now, Dr. Samutra, let me come back to you asking something. See, here are two things. For example, ESC very clearly said that you can add up RAS inhibition with CCB or a diuretic. Okay, in the first. But the recent ISH guideline said that they're not looking at diuretic, exactly like Dr. Kahali said. They're looking at RAS inhibition plus CCB and then the acid version of CCB full dose, and then only adding up diuretics. Now, two things
No,
come
I
into my
told
mind.
Tiny that
Yeah,
RAS inhibition and CCB is the first choice. I
yeah,
told
that's yes.
about
RAS inhibition CCB is
diuretics the
first,
third choice.
diuretic
Third
is the
choice.
third choice.
Third
Now,
Yes,
choice.
the
that's what
point
I
is,
said.
Third choice.
yeah, there are just two things here. One is that we saw in the India heart study that patients had in India had significantly elevated heart rate, right? Which we had discussed in our forum so many times. So, but then in all these 1, 2, 3 beta blockade doesn't come in the standard guidelines, right? Number one. Second thing is we know today that around 50%, whatever little data we have, data from Chennai, we have data from Goa coming in, whereby 50% of Indian patients are salt sensitive, salt sensitive. So, in that background, Dr. Samitra, what would be your take on the combination therapy for India? I mean, are you going the same line as Dr. Kahali, or are you also adding up, thinking of beta blockade earlier, or adding up a diuretic earlier? What would be your take on that?
I'll give you a few points and it's an individual decision. You see, India is the seat of metabolic syndrome. And what does a diuretic does? It causes dysglycemia, dyslipidemia, hyperuricemia. None of this is caused by a calcium channel blocker, number one. Number two, dyselectrolytemia. Hypokalemia may be taken care of as blockade, but hyponatremia, in all hypertensives are educated to take low salt diet. And in India, the temperature fluctuation is so much. Say, as for example, New Delhi, it varies from 0 degrees Celsius to 50 degrees Celsius. So your body, your sweat glands are not adapted to excrete low sodium in your sweat because it varies from winter to summer. So in summer months, when an Indian sweat, they lose a lot of salt, sodium. They do not preserve the sodium. So there every often we see hyponatremic admission in ICU because of diuretic use with the low sodium intake in the diet. Third, you see that RAS blockade causes cough, ACE inhibitor causes cough, amlodipine counters that cough. Amlodipine causes some proteinuria and pedal edema. RAS blockade counters that pedal edema and proteinuria. They are so complementary. You see, calcium channel blocker, as you said, may stimulate the sympathetic. Indians are adrenaline prone. RAS blockade stops that adrenaline secretion. So they are so nicely complementary to each other that I think I fully agree with Dr. Kahali. Only point in favor of diuretic is that it is cheaper, it is cheap compared to a calcium channel blocker. And secondly, as I would say, some people are hypervolemic or heart failure prone. They will perhaps, particularly diabetic patients who are prone to heart failure, systolic or diastolic, they perhaps will get some benefit with the early introduction of diuretic. Now the beta blocker. I am a strong proponent of beta blocker in Indian subcontinent because India is the seat of coronary artery disease along with metabolic syndrome. Some people say, like Neil Poulter told me, you are talking about diuretic and India is the seat of metabolic syndrome. What is your beta blocker doing to metabolic syndrome? I say, okay, sir, but metabolic syndrome will kill later, but coronary artery disease will kill directly. And beta blocker is preventing that direct sudden cardiac death or arrhythmic death associated with coronary disease or ischemic heart disease. And most Indians are youngish Indian, young hypertensive population. They are sympathetically overactive. So we need a beta blocker perhaps much earlier than other countries. And as you say, as Dr. Kali also said, importance is an important thing, particularly in younger people. So we have to choose a beta blocker carefully, maybe a very selective beta blocker or vasodilating beta blocker, not the age-old atenolol, maybe nebivolol or maybe carvedilol or maybe super selective like bisoprolol. So beta blocker comes very early in my treatment algorithm. Calcium blocker always precedes diuretic in my treatment algorithm. But of course, if you need a third drug, diuretic is there.
Yeah, so I think we have finished our time allotted to us and we have been want to stop. But then, we would have wanted to talk, the talk to go on and on because of the wisdom of these two experts here. But we have to stop here. So what did we learn? Just in 4 bullet points, we have learned that number one, compliance is important in India. And we have to make sure that we can counter compliance by whatever method. And like Dr. Kahali very clearly says, spend more time with the patient. Convince him that there's an asymptomatic disease, but unless you take your drug, you will end up in a lot of problems of multiple target organ damage. Do take the drug. That is point number one. Second thing is, both of our experts has taught us and reiterated that most patients would need a combination therapy. Most patients. And they should be, to start with, a RAS inhibitor on one hand, along with that, calcium antagonist. And if that combination fails, we go in for a diuretic at stage 3. And both the experts have very clearly said the importance of hitting it hard right at the beginning and controlling blood pressure. And if we get a good control, you can always think about de-escalating it. So thank you, ladies and gentlemen, for joining us. Thanks to the panelists for being so nice, and the clarity of your thoughts is excellent.
Thank you,
Thank you
Dr.
very much.
Tiny
Thank you.
Nayak, my longtime friend, for such a wonderful moderation, and also thank the organizers and
You are
thank Dr.
wonderful.
Soumitra
Yes.
Rai.
Thank you, Dhimala.
Thank you, Soumitra.
Thank you. Thank you.
Bye.
Thank you, everybody, for finishing on time.
Thank you, everyone. Thank you for finishing on time. Good afternoon from the studio of CSI Ahmedabad 2020. Welcome to CSI. I'm Dr. Kamal Sharma, interventional cardiologist. Along with me, my co-host, Dr. Harshad Patel. We have another session in the Sabarmathi Hall. Our first session today is going to be on interesting imaging sessions. I invite our chairpersons, Dr. Mona Bhatia, Dr. Mahapatra GN, and Dr. Rajesh. We have 8 talks, and we have Dr. Purvi Parwani from USA talking the first case. Over to the chair.
Good afternoon. This is Dr. Mahapatra. I myself, with Dr. Mona Bhatia and Dr. Rajesh, welcome all of you to this afternoon interesting session on interesting imaging session. And in this case, now I would request Dr. Mona Bhatia to invite Dr. Purvi Parwani. Dr. Mona Bhatia, can you unmute? Dr. Mona Bhatia.
Thank you, Dr. Mahapatra. Yes, we invite Dr. Purvi Parwani. She's speaking to us from the west coast of the US, so she's up in the middle of the night to give us this amazing talk on Minoka, which she has been talking about, and I've heard her in various other sessions. So we know that 10% of acute MIs can be because of Minoka, and it's no longer as benign as we always thought. So over to you, Purvi, to go on with Minoka and going beyond coronaries with CMR.
Thank you so much. I thank the Cardiology Society of India and Dr. Bhatia for this kind invitation. I did my med school in Ahmedabad, and this is really a full circle coming. So I'm really honored. I have no disclosures pertaining to this talk. So let's start with a case. So we have a 52-year-old female with history of asthma and sinusitis who came with NSTEMI, had a borderline troponin with EKG, as you can see here, pretty unremarkable. This is the echocardiogram, and on echocardiogram, you can see that there is some wall motion abnormality in the septum, both the entro as well as the infroseptum. Going further, given her presentation, she got cardiac catheterization done, and you can see that her coronaries are widely patent. So because she basically fit the diagnosis of Minoka, we exposed her to cardiac MRI, and on cardiac MRI, you can see again that she has some wall motion abnormalities in her septum, both the entro as well as the infroseptum. And she had some delayed enhancement that was very focal and involving the septal arteries of LAD, both in the distal infroseptum as well as the proximal enteroseptum. So given this patient had sinusitis, asthma, also had presented with acute vision loss along with chest pain and STEMI and rash, we had biopsied her rash, and she basically had eosinophilic granulomatosis with polyangiitis, and this case is a demonstration of how the coronaries were involved. And this is her MRI 2 years later. You can see that that delayed enhancement, the subendocardial delayed enhancement that we saw in the septum, the distal infroseptum as well as the prox enteroseptum now has small little aneurysms. So this was a case of Minoka where we were able to see the eosinophilic granulomatosis with polyangiitis involving the coronaries. Now, in cardiology, we are very good good with taking care of STEMIs when there is 100% occlusion of coronaries, but when there is no coronary artery disease found, or when there is a non-obstructive coronary artery disease, the question always is what to do about these patients. And we need to diagnose Minoka because it's represented in almost 6% of acute MI. It's overrepresented in women and young, and the prognosis is guarded, almost similar to 1 to 2 vessel coronary artery disease. And by diagnosing, you can target the management. So if we look at the ESC guidelines of NSTEMI that included Minoka, and the class 1 indication was to utilize the Minoka algorithm, it includes the definition of acute MI and a non-obstructive coronary artery disease and the angiogram, and no particular alternative diagnosis for the clinical presentation that is present for this NSTEMI. So when they took all these patients, and this is the biggest meta-analysis systemic review available on these patients, they found that patients fall into many different categories, and they had diagnoses that varied from ischemia, but also acute injury, like in cases of myocarditis and stress-induced cardiomyopathy. So how is the CMR useful? Because on delayed enhancement, given the particular pattern on the MRI, you can actually diagnose whether the reason for the NSTEMI is ischemic versus non-ischemic. So in ischemic reasons, etiology, it would be subendocardial. In non-ischemic etiologies, depending on what etiology we are dealing with, the delayed enhancement would have different patterns as they are shown here on this graph. So this is the diagnostic algorithm that was suggested by the AHA, and you can see that it's kind of like a traffic light approach, and I invite you to review this in detail. But cardiac MRI sits right in the middle because it is the diagnostic modality which is going to differentiate ischemic causes from the non-ischemic. So let's review some quick cases. This is a case of a 20-year-old gentleman that came to our institute with sudden cardiac death history in the family. He was a smoker, but you can see that he has a pretty unremarkable EKG and cardiac catheterization. On the MRI, you can see some subtle wall motion abnormalities in the lateral wall. Corresponding to that, you have an epicardial delayed enhancement, which is classic for myocarditis. However, given the imaging findings as well as his family history, we decided to subject the patient for genetic testing. And actually, this was a case of left-sided arrhythmogenic cardiomyopathy with first manifestation presenting as myocarditis. One more case real quick. So this was a 42-year-old lady that had come with elevated troponin. You can see the wall motion on this MRI is absolutely normal, but there is extensive subendocardial delayed enhancement in the circumflex territory, almost going transmural. And this patient was actually discharged thinking that her cath was negative, but on further review after the MRI was done, you can see that there is some haziness in the proximal circumflex along with 100% cutoff of one of the branches. So this was a case of myocardial infarction with silent, which remained silent initially, thought to be silent initially on the cath. And this last case I want to show, this patient was forever called hypertrophic cardiomyopathy based on echo at an outside institute, had presented with a borderline NSTEMI. The cardiac catheterization was negative. We did an MRI, and on MRI you can see the hypertrophy, but rather than having delayed enhancement in the mid-myocardial region in the septum, delayed enhancement was all distributed in the infralateral and lateral region. So this is classic for Fabry's disease, with this kind of hypertrophic pattern. And again, we checked the patient for Anderson-Fabry's disease, and they were indeed positive for it. So my take-home points for all of you is the diagnostic criteria for Minoka. So it's the acute myocardial infarction with non-obstructive coronary disease, and CMR being one of the main diagnostic modalities to further differentiate these patients. Thank you so much.
Thank you, Purvi, for an excellent talk. I think we'll take questions at the end so that just so that we keep everything to time. And so I'm going to now invite Anirudh Kohli, who is the head at Breach Candy Hospital, and he's going to tell us whether FFR today is the crowning glory to CT. So over to you, Anirudh, with your topic on CT FFR, cath or no caths.
Dr. Anirudh, sir.
Is Dr. Anirudh Kohli here?
He is not logged in actually.
Okay, so then I'm just going to go quickly to Dr. Tarun Mittal, who's with us from UK, and he's going to be speaking to us on plaque imaging, the new goalpost. We'll come back to Dr. Anirudh at the end.
I'm just going to share my screen. Okay, can you see my presentation?
Yes, we can. Thank you.
Okay, well, thank you, Dr. Mona Bhatia, and thanks to the CSI Scientific Committee for inviting me to this meeting. So I would like to start with presenting a case of a 55-year-old man who is obese and presented with atypical chest pain. He was hypertensive and had a family history of premature coronary artery disease. He was now non-diabetic and his lipid profile was normal. So based on the latest ESC guidelines on chronic coronary syndrome, as per his age, his sex, and atypical chest pain, his pre-test probability of having significant coronary artery disease was 17%. So as per the guidance, this patient then was recommended for a cardiac CT scan. And first we did a CT coronary artery calcification scan, which showed that he had a calcified plaque in the proximal left antidescending artery, and his total Agatston calcium score was 125. And we know that when we see calcified plaque in the coronary artery, it's a very specific marker for atherosclerosis. And we also know the more the calcified plaques in the coronary artery, the higher the calcium score, the more is the atherosclerotic burden in the coronary arteries. And this also relates to risk. So the more the atherosclerotic burden, the more is one's risk for having acute coronary events or dying of cardiovascular death. What is also important, if the calcium score is absent, then the chances of having significant coronary artery disease in a stable patient is less than 2%. And we also note that these patients with zero calcium score have a very low annual event rate of less than 0.3%. Now, as this patient has calcified plaque, he underwent a CT cardiac angiogram. And here we can see that he has a mixed plaque comprising of both calcified as well as soft components. And on the short axis images, we can see that the stenosis is less than 50% luminal diameter stenosis. On close inspection, he also had high-risk features in the form of external remodeling at the site of the plaque. He had low density in the plaque of less than 40 HU, and he also had something called napkin ring sign, in which the low attenuation plaque is surrounded by a higher density area. So overall, the diagnosis on the CT cardiac angiogram was that this patient has a high atheroma burden with the plaque showing high-risk features, but the degree of stenosis was less than 50%, and thus not explaining his chest pain. So we know that from several studies like this one, that high-risk features on CT cardiac angiogram, like napkin ring sign and low attenuation plaque, they are associated with worse outcomes. Now, Professor Fuster, in his editorial in JACC in 2015, he warned us that for managing patients at risk of acute coronary syndrome, the focus should be on the overall plaque burden rather than on the identifying thin cap fibroathromas or vulnerable plaques. And that's because most of the vulnerable plaques, they will change to more mature thick cap fibroathromas. And also we know that the larger number of acute coronary syndromes are caused by non-obstructive plaques rather than obstructive plaques. Now, in this study that was published this year from Confirm Registry, it shows very elegantly that in patients with non-obstructive disease on CT cardiac angiogram, it is the extent of plaque burden on CTCA that represents increased or higher risk compared to even the traditional risk factors like hypertension and diabetes. And this Scott Hart study that I'm sure most of you are familiar with, which randomized patients with stable symptoms to CTCA and standard care, it showed at 5 years that patients who were in CTCA arm, they had almost 40% reduction in MACE events, and this has been ascribed to the greater use of statins and aspirin in the CTCA arm of patients. So to conclude, a CT coronary artery calcification is the simplest way to assess the overall plaque burden and to quantify it. In patients with stable chest pain or stable symptoms, CT cardiac angiogram is the non-invasive technique of choice to demonstrate plaque morphology, high-risk features, and degree of stenosis. And it is the overall atheroma burden that represents increased risk requiring preventive treatments and lifestyle modification. Thus, I would say, and the current evidence points out to that the new goalpost is the overall atheroma burden that we should be identifying on our non-invasive imaging and trying to target for preventive therapies. And with this, I would like to thank everyone for your attention and would be happy to take any questions later on.
Thank you so much, Tarun. Yes, that was a great talk. And we have been following plaque more than stenosis. It's plaque that we're now interested in, between the necrotic plaque, the vulnerable plaque, plaque regression. It's really the topic today. And we've really gone to plaque being the guide to whether it is going to be significant coronary artery disease or not. But we'll take the questions at the end. So I'm now going to go ahead to Dr. Uday Jadhav. Is he here?
Yes, Dr. Mona, yes, thank you very
Great.
much. Yeah, I'm
Dr.
here.
Uday Jadhav, over to you for post-intervention recurrent chest pain. Dr. Uday is very actively involved in CT imaging, and it's great to see a cardiologist with so much intervention experience with us for CT and imaging.
Thank you very much, Dr. Mona. Thank you for the opportunity in the first place. And uh, I'm just going to ask whether my slides are seen
Yes, they
before
are.
I start.
Thank you.
Okay, thank you. Okay, so very quickly and briefly. We know that for post-stent imaging, you can have excellent imaging pictures like this. And I'm not going to present a case like that of normal, a classical case of neointimal hyperplasia, occluded stents, very beautifully seen here. These are not many images that we will see in real practice because post-intervention for diagnosis of acute chest pain and acute thrombosis, I don't think we should pass on this message to clinicians. It's not recommended. CTA should not be done for acute chest pain post thrombosis at least in the first 7 weeks because the chances of a thrombus being high, you need to intervene in those cases. So you can have images like this. These are some of our images, beautifully seen, a very nice LED stand, which we don't always see. We have problems about metal artifacts, we have problems about the struts, uh, but then it's good to evaluate over a period of time patients who have atypical chest pains or sometimes difficult. So the message is clear, not for acute thrombosis, please, we still have that as a gold standard. Here is a quick clinical summary. He's an elderly male, type 2 diabetics and hypertension, non-smoker, obese. He came with an anterior wall ischemia. ST segments were also down in 2-3 AVF. Normal echo. We did his angiogram in August 2020 and we did his CTCA in November 2020. And I'll explain why it was done. So here was his angio. And in the cath, we can see a very severe stenosis in the proximal circumflex territory, right? Followed by what we called as a plaque at that time. And there was, of course, a significant disease in the LAD. So significant disease in the LAD, a very tight lesion in the proximal circ and the OM branch and a plaque thereafter. So we just look at the diameter in general on QC and thought that it's about 30-40% plaque. We need not go and stent it beyond just to reduce the metal burden. So in the cath lab, we put a proximal stent for the lesion and a 3.5 16 millimeter stent, reducing the length was put. And that did pretty well. There was a good T3 flow. You still see a plaque, and we called it insignificant. That's not a good word to use. We should start just labeling it as probably non-obstructive. And that should be what is the FFR talk, which follows my talk today. So we call this as a sort of, non-obstructive or insignificant disease. Leave it at that. Patient was okay. After 2 months, he came back with a chest discomfort, which is not typical. It's not typical of angina. The STs did not go up. The troponins were 9.7 at a cutoff of 19. Now we know that for absolute rule out at 99 percentile, it should be less than 1.5. So this is little elevated. Maybe it's still the lingering effect of the prior PTCA, but it's 2 months already gone. We explained the patient that a cath may be a good thing to do. He said, no. Can we do a CTCA and have a look? So we did not encourage straight for CTCA. We did a conventional CTCA, and there was a stent in LAD which was doing well, and the left main was good. There was a calcified plaque. The stent was doing one. There was a calcified plaque and a small plaque which I had noticed in the LAD on the cath also, but that did not look significant. And in general, on various views, the LED did not look too tight. And though there is a little lucent area where the calcified plaque is, this was not on various, sequences looking tight. So we said, okay, this doesn't seem to be the cause. The LED stent was, in general, fine. The flow was good, it looks like, and the images were good. And even the circumflex stent was good. So good LED stent, good circumflex stent, a plaque just prior to the LED, but did not look at all very significant, looked more like a calcified plaque. And we said, okay, so both stents are doing okay. And here is that particular lesion, which is distal. And it looks somewhere around 40 to 50% if we measure it also. Close to 50, lesser, anywhere between 40 to 50, that's what it looked like, this particular lesion. And you can see it on the various images, that particular plaque beyond this stent. These are his lipid levels. He has achieved very, very good. There is nothing more I can do, right? His LDL is 53. There is a belief you can get it down to 30 in such patients where you see a plaque. Why I brought out this case just to save all this time is that though we always talk about 70%, stenosis of 70% is a great predictor of positive CT-derived FFR at a cutoff of zero point 0.8. If you get a stenosis of 30 to 50%, then by and large, you might be happy and say this is a negative CT-derived FFR, and these patients will not have significant lesions. But the advanced registry have already shown this. One third of those patients whom you think with a stenosis more than 70% are significant, and we stand them are actually not significant. And less than 50%, we think that these are not, important plaques, so-called non-obstructive, are actually functionally significant and not insignificant, and that's 20%. So does this patient with this sort of lesion belong to a significant lesion? We may have to look at the plaque morphology. I mean, these are the four great images that ESC has put in one particular picture, right? The plaque remodeling, the positive remodeling, the hypolucent plaque, the spotty calcification, and the napkin ring sign. So this is classical. Maybe this is a hypolucent plaque just beyond the stent, and this has started creating a trouble. So the point is, what do we do now? Should we do a CT-FFR and check it out, which I don't do? Should this patient undergo further testing? He did undergo a exercise testing limited, and it showed a little ST depressions, but they were there before. So I do not see why one should go on doing stress tests and look at ST segments and correlate it all the time, because you find the ST segment still down post interventions also. That's not a great gold standard. Should we cath him again? Now, that's a question left to discussion. Should we ask him to undergo one more cath and be sure what we are dealing with? Should we leave it where he is? Does he require a evolocumab to get his LDLs down to 20, and will that plaque stabilize? Thank you very much for the attention.
I can't hear.
Ma'am, could you please unmute yourself, ma'am, please? Because you are muted.
Unmute. Dr. Mona, unmute. Again.
Ma'am.
Unmute.
Okay, am I
Yes. Yes, yes, yes.
Thank you so much, Dr. Jadhav. That was a great talk. And yes, I think this is the most appropriate time to bring in Dr. Anirudh Kohli to tell us whether his CTFFR would have helped the situation and whether we can avoid unnecessary cats and, just let the patient know how it goes. So over to you, Anirudh, for telling us about when and what to do if you need the CTFFR and whether it's the most appropriate test today at the end of the CT for an intermediate lesion.
Yeah. Hi. Sorry, I'm at work and I've never tried to do a Zoom from work, so I'm having a little issues out here. Just getting on and sharing the screen. So just you'll have to bear with me
Do you
on
want
this.
us to come back?
Okay. Okay, but I don't know whether my screen will open. Okay, come back to me.
Okay. So let's just continue then to our next talk, and that is going to be Dr. Suman Singhal. Dr. Suman Singhal is going to tell us about hypertrophic cardiomyopathy and how CMR can help us now with all the traditional risk factors in place, whether we can actually change and think about CMR guiding us to who is at risk of sudden cardiac death.
Thank you so much, Mona. Thank you, CSI, Dr. Mahapatra, and Dr. Rajesh, for this opportunity today. I'm just sharing my screen. I guess you people can just see it. Can you see my screen? Hello, can all of you see my screen, please?
Yes, ma'am.
Thank you so much. So coming to assessing risk in hypertrophic cardiomyopathy, which we all know is very important to assess the risk factors for sudden cardiac death for the primary prevention ICD therapy, which is to be given to the patients. So I start with the case, a 35-year-old male presented with hypertension and breathlessness on exertion for last 2 years. The ECG showed LVH with Q waves in the lateral leads. On echo, there was hypertrophy of the LV myocardium involving the anterior and the septal wall. There was no SAM, normal LV function was there, no significant LVOT, trace MR and TR. So cardiac MR was done for further evaluation. As we all know, by cardiac MR, we can actually assess whether which are the areas which are hypertrophied in HCM, where few areas like apex are sometimes not well seen on echo. We can look at the other causes for HCM to look for the causes like amyloidosis, other infiltrative disorders, and finally to look for the risk factors for HCM. So in our case, on the Cine 4-chamber as well as the short axis view, we were seeing that there was hypertrophy of the LV myocardium involving from basal to distal anterior as well as the septal wall. The LV function was absolutely normal. On the late gadolinium enhancement, there was this patchy enhancement seen in the hypertrophied myocardium, which was mid-wall as well as epicardial wall. The LVEF was normal 50%. The end diastolic wall mass index was more. And on the looking at the risk factors which we see on in HCM on CMR, since there was no amyloidosis and all, the maximum wall thickness in the septum was 25 millimeter. The LGE was more than 15%. And this is, we can see on CMR the qualitative as well as the quantitative assessment of the late gadolinium enhancement by different softwares. Which is like, the sequence can be seen like this. We can get the quantitative assessment of the enhancement also by the software, and qualitatively we can see by the eyeballing. On T1 mapping, the T values were increased to 1556 millisecond in this patient. So coming to summary, in this patient, we had asymmetric hypertrophic cardiomyopathy with maximum wall thickness of 25 millimeter. There was late gadolinium enhancement in the hypertrophic myocardium involving the anterior as well as the anteroseptal wall, which was more than 15%. T1 values were increased. There was no SAM, no apical aneurysm, no LVOT obstruction, and ejection fraction was 50%. So LGE just more than 15% was the only high risk factor present in our patient. Now coming to the 2020 guidelines, which have recently come up, and which is actually the article is still in the press for the guidelines for risk assessment for hypertrophic cardiomyopathy, according to which the current any one of these risk factors, if it's they are present, one has to consider the primary prevention ICD therapy. If there is any family history of sudden cardiac death from HCM involving the primary, first degree relative or the second degree relative, if there is massive LVH more than 30 mm in any segment of LV, if there is unexplained syncope, which is there, if the ejection fraction is reduced less than 50% evaluated by echo or CMR, if there is any LV apical aneurysm, independent of the size of the aneurysm, if it's there in the LV apex, then it's a risk factor. If there is extensive late gadolinium enhancement on CMR, which is more than 15%, then it itself is an independent risk factor for ICD therapy, even if the other risk factors are not present. If there is non-sustained VT, which is there on ambulatory monitor, it is again a risk factor to be considered. So the present guidelines say that this is a flow chart which is to be followed for any ICD therapy. If there is a prior event which is there, then ICD is recommended. If there is any one of these risk factors which I just mentioned, then ICD is to be considered. If there is NSVT or extensive LG on CMR itself, an ICD has to be considered for the primary prevention therapy in HCM. So the major risk factors which we see on cardiac imaging are the increased wall thickness more than 30 mm in any segment, if there is a presence of LV apical aneurysm, if there is late gadolinium enhancement more than 15%, like this we are seeing in this case of asymmetric HCM, where there is patchy enhancement, the mid wall enhancement or the epicardium which is there in the hypertrophied cardio, LV myocardium, then and a reduced ejection fraction. All these are the risk factors which are to be evaluated on CMR in patients of HCM. So even in this recent article in 2019 in JCMR, they said that the amount of late gadolinium enhancement outperforms the current guidelines criteria which are present in HCM for sudden cardiac death. So earlier we had this 2014 European Society of Cardiology criteria and the 2011 American Heart Association criteria which were there. But now we will follow the 2020 guidelines according to which these are the LGE more than 15%, which is very important risk factors along with the reduced ejection fraction, LV apical aneurysm or the LV hypertrophy more than 30 mm. What they consider in LGE is that basically these are the areas of increased arrhythmogenic substrata which are there, and if the patient has more than 4 segment involvement of LGE, then there will be reduced ejection fraction in these patients, as well as these patients are more prone for ventricular tachycardia than the patients who have less than 3 segment involvement by the late gadolinium enhancement on CMR. So again, the same thing is repeated, and thank you so much for the kind attention.
Ma'am, you are muted again, ma'am. Please unmute, ma'am, please.
Okay. So thank you, Dr. Suman. That was a great way to approach the hypertrophic cardiomyopathy, and that's really a very relevant topic today because hypertrophic cardiomyopathy is almost like a lifelong disease, and we not only now have to think of what's happening to the people who come to us with the symptoms, but also the children and at much younger age groups where hypertrophy might be within the families, and we need to evaluate family histories, any presence of genotypically positive, phenotypically negative hypertrophic cardiomyopathy. The other place where I think the hypertrophy is becoming more important is its differential, because between the amyloid cases or even the cases of athlete heart, that's becoming so relevant today because there's so many people running marathons and training at very high levels. So the whole differential of hypertrophy, true hypertrophy to the athlete heart becomes more relevant. So we'll go on to our next talk, and this time we're going to be talking viability. So I'll let Dr. Mahapatra introduce Dr. Ashwini.
Yeah, thank you, Dr. Mona. After hearing the plaque imaging, then the post-interval recurrent chest pain, hypertrophic cardiomyopathy, we'll move to the ischemic heart disease, particularly of viability, and PET is the last word. In this connection, I would like to invite Dr. Ashwin Sood, who is the current professor of nuclear medicine at Postgraduate Institute of Chandigarh. Dr. Sood.
Muted myself.
Can you hear me?
Dr. Sood? Yeah.
Yeah, can you hear me?
Yes.
Okay. Thank you very much. And good afternoon, everybody. And I would like to thank Dr. Mahapatra, Dr. Mona, and Dr. Rajesh for giving me the chance to speak on this platform. So I'll be talking about pet viability. The pet is the last word. I have restricted my slides to the a case report, thinking that there is a time limit of 4 minutes, and I have not put any literature in that. So please excuse me, and if you want any questions, I can answer those afterward. So this is a when I'll be talking about viability pet is the last word. I'll be presenting a case, a 60-year-old male patient who was smoker with a history of exertional angina grade 2, 3 for 6 months, but without any other symptoms, without any comorbidities. His echo showed concentric LVH with a mild global hypokinesia, and his LV ejection fraction was around 45 to 50%. His coronary angiogram showed diffuse triple vessel disease. All the vessels were involved, and we can see LAD was having a proximal to distal diffuse plaque with a maximum stenosis of 95%. And his D1 was a large vessel with a diffuse disease. LCX was having a proximal 99% tubular stenosis, and there was a plaque in the OM1. RCA was also involved with the proximal to distal diffuse plaque with a maximum 99% stenosis with a retrograde flow by grade 1 collateral. So in view of triple vessel disease, patient was planned for CABG, and before CABG, patient was evaluated with the PET, and normally we do a PET with the perfusion imaging agent as well as a FDG imaging agent. So in a cardiac PET, we do a first with the ammonia, and it is available in our institute. So it is a perfusion agent, and we can see in the sectional images there is a reduced perfusion in the infralateral as well as the inferior wall of this patient. And whereas while the patient was subjected to cardiac PET with the FDG, it shows the preserved metabolism in those areas where there was a decreased perfusion. And we can very well appreciate on the polar plot also in the infralateral and the inferior wall, there was a decreased perfusion. And in the corresponding segments, there was a preserved metabolism. So the patient had a hibernating myocardium in those areas. In view of this thing, and the hibernating myocardium was around 28 to 30%. In view of a hibernating myocardium, patient underwent a CABG procedures. 3 grafts were placed, Lima to LAD, and RSVG to OM1 and D1. His per-operative and post-operative period were uneventful, and in the follow-up there was no history of a major adverse cardiac event following the procedures. And as a research protocol, patient underwent again a cardiac PET with the ammonia after 5 months of a CABG, and patient is on a follow for last 6 years post CABG, and patient is asymptomatic. So we can see that the upper panel is showing a pre-CABG ammonia, and we can see there is a reduced perfusion in the inferior and the infralateral part of the myocardium, and which is showing a preserved FDG or metabolism in the corresponding area. After getting the CABG, after 5 months, the post-CABG ammonia PET again show the restoration of the blood supply to that area, establishing that the uh, reperfusion is there. And these are the gated images, and we can see upper panel is showing the pre-CABG ammonia PET, and we can see there is a reduced perfusion in the infralateral and the inferior wall, and the pre-CABG ejection fraction is 37%. However, after CABG and repeats ammonia PET showed restoration of the perfusion along with the improvement of ejection fraction to 49 from the 37. So I will say the PET has a role in establishing the hibernating myocardium, and can document the restoration of the perfusion if it is done after the CABG. Normally, it is not prescribed, but it is research protocol. We do it in our patients over here. And I would like to show another case where there were two discordant findings in the different imaging modalities. And here is a 57-year-old male patient, known case of a coronary artery disease with triple vessel disease. His echo showed ejection fraction of 20%, regional wall motion abnormality in the anteroseptal wall. Patient was on medical management for heart failure, and patient was asymptomatic. Patient was evaluated for the viability assessment before CABG, and we can see his cardiac MR showed mid and anterior interseptal wall segment showing a end diastolic wall thickness of 4.5 millimeter with the regional wall motion abnormalities, and the LG images showing the involvement of a 50% of a myocardium thickness, which was suggestive of a non-viable myocardium. However, when this patient was subjected to cardiac PET with the ammonia and FDG, we can see that the ammonia, there was a reduced perfusion in the anterior and the interseptal segments, which showed up preserved metabolism of on FDG imaging, and the these defects are known as a perfusion metabolism mismatched defect, and they are usually suggestive of a viable myocardium. So we can say on this case, just it's only one case, but we can say FDG PET has a last word in a myocardial viability. With that, I'll conclude my talk. Thank you.
Thank you, Dr. Sood. We'll have question answers at the end of the session. And the next is our friend Dr. Johan, a role of CMR in new onset of heart failure, the CMR guidelines management. Dr. Johan.
Thank you, Dr. Mahapatra, Dr. Mona, and chairs. I'll be talking about CMR and new onset heart failure. We know that heart failure is complex. What is more complex is the etiology, and in the management rests on a couple of principles. Now, why would I choose cardiac MR? Because I feel it's a one-stop shop for cardiac imaging. It has morphology, it looks at function, tissue characterization, and metabolism compared to the other competitive technologies. It also is able to image a vast array of cardiac pathologies, right from congenital to non-ischemic cardiomyopathies. So the first step in the evaluation of heart failure is to assess morphology and function. And heart failure really depends on the ejection fraction, because we know that if your EF is less than 45 or more than 45, the prognosis is completely different. And MR has come to be known as the gold standard for ejection fraction because it does not depend on window issues, and also it is inter-operator independent. The second issue in heart failure is whether the patient has coronary artery disease or not, and this has been shown by Felker's elegant work that in an ischemic pathology, the mortality is much higher. We have traditionally relied on angiograms. You can see the one on the left is normal, the one on the right has an LAD occlusion. But however, MR does the job in a very non-invasive fashion and clearly shows by the wavefront hypothesis that subendocardial scars are ischemic and the rest are non-ischemic. The notable exception obviously is amyloidosis, which has a global subendocardial pattern. This all has led from 2009 to cardiac MRI given the 2B for imaging patients with heart failure with an underlying ischemic etiology. We know that viability is important, and we know that when you revascularize viable myocardium, the mortality comes down to 6 to 8% compared to 14% for patients who are left on medical management. And what better tool to do than a cardiac MR? And the first step obviously is to look at the regional wall motion, as you can see here, and also to gauge the ejection fraction. The second step is to look at the perfusion. This is perfusion at rest. You can see the LAD territory is poorly perfused. The third step is to look at the delayed enhancement here. And all these three are put together very elegantly. So you have the wall motion, you have the delayed enhancement, and then you can assess the viability for that particular lesion. What is also good is that it can assess the complications of myocardial infarction. You can see this patient has a rupture in the infralateral wall and was subsequently fixed on surgery. This is another patient with an LAD scar, but the patient also had an aneurysm and a thrombus, and this was fixed by the surgeon after putting in the grafts. Shifting gears, we can see that in valvular etiologies, especially aortic regurgitation, the pathology of the valve, the degree of regurgitation, and also the degree of ventricular dilatation can be very well assessed by cardiac MR, irrespective of the obliquity of the jets, and you get a very reasonable regurgitant fraction, which is as good as 3D echo or even better. Mitral regurgitation obviously is the bane for coronary artery disease, and especially when it's an oblique jet like this, it's very difficult for the Doppler to align, and cardiac MRI does this very well. It also sees the pathology behind the MR and assesses the severity very well using the LV stroke volume and the aortic stroke volume. The second major step that we look at is characterizing the cardiomyopathy. And here we look at the huge spectrum of non-ischemic cardiomyopathy here. And it is important to differentiate all of them because they all have varying survival curves. So we have three major cardiomyopathies: the dilated cardiomyopathy, the restrictive cardiomyopathy is represented by amyloidosis, and the T1 and the ECV images also help you make that diagnosis. And lastly, as was discussed by Suman, hypertrophic cardiomyopathy. So these three are very elegantly evaluated by MR, but there are other etiologies that are there, and just like each pathology requires a different strain, we have come up with the T1 mapping, which is a single stain for a huge multitude of pathologies you can see here, which can be differentiated very well, provided you have the know-how of doing it. The ECV is done post-gadolinium, and both are put together, and they give us a very kaleidoscope of cine images, T1 maps, scar images, ECV maps, and perfusion maps, and thereby the whole characterization of cardiomyopathies can happen. The third major issue where we want to go into is risk stratification and therapeutic management of these patients. You can clearly see here that if you have gadolinium of any kind, of any magnitude, the all-cause mortality, the heart failure, hospitalization, and sudden cardiac death really go up. In hypertrophic cardiomyopathy, which is a prototype of such a disorder, you can see the scar burden here. And when you go beyond 15%, as the guideline showed us today, you are eligible for an ICD as a primary prevention. Dilated cardiomyopathy again lends itself to this scar pattern very well. And if you again have a scar, these patients have a poorer course in terms of mortality and obviously sudden cardiac death. So a prophylactic ICD again can be considered. Myocarditis is another patient which can present like a Minoka, as was discussed, and the TROP-Ts are positive. And if you have a scar here and a lot of edema, these patients are in the ICU for a longer time. They require more supports than patients who do not have this. In sarcoidosis, again, the presence of a midline scar, especially in the septum, and also the presence of nodes which are metabolically active, make these patients at higher risk depending on the quantum of gadolinium. Also here we rope in the help of PET scans, and you can see here the presence of metabolic activity nodes and myocardium lend these patients to immunosuppressive therapy, and 3 years of immunosuppressive therapy later, you can see the nodes are gone and the myocardium is metabolically inactive, which also led to the resolution of the ventricular tachycardia which this patient came in. In amyloidosis, which was previously an irreversible disease, is shown here by the onset of bortezomib, which was a very good modulator, immunomodulator, which has come into the market. We have started using that, and you can see a significant reduction of the amyloid fibrils in the heart, and MR is very well poised in repeated examinations. So the higher the T1 you have, the higher the ECV you have in amyloid, the poorer the prognosis, and also puts these patients on the transplant list. Iron is again a favorite of MR, and there's a different prognosis when you have iron in the liver, and there's a completely different prognosis when you have iron in the heart. And patients with iron in the heart lend themselves to more of IV therapy, dihydroxyapatite therapy, and they do very well compared to those in the liver. ARVD is again one such disease where the volumes are very important, and that lends itself to the diagnosis based on the modified guidelines. The presence of scar obviously puts them at a higher risk, and they are also patients for a prophylactic ICD. In patients with EMF, the presence of thrombus and scar again lend themselves to very specific surgical therapies in very specific centers. Constrictive pericarditis again is very well diagnosed by echo, but the presence of enhancement of the pericardium puts these patients at better to be done on medical therapy like steroids for 4 to 6 weeks before the surgeon sees them, and this decreases the morbidity and mortality of the surgery. Cardiac masses especially are characterized very well by MR, and the presence of LV thrombus here before the patient went in for a cabbage helped the surgeon plan the surgery better and caused a very good outcome. So, ladies and gentlemen, in conclusion, the evaluation and management of patients with heart failure is clinically very challenging. Cardiac MRA is a great technique which encompasses a whole range of cardiac pathologies, and it specifically looks at morphology and function and the identification of pathologic and modifiable substrates to ensure good end therapies. Thank you very much for your patient listening.
Thank you. I'll hand over to Dr. Rajesh, the chairperson, to
Second
invite.
last talk of this seminar is about Are We the No Longer Forgotten Ventricle by Dr. Manpul Singhal. Are you there, Dr. Manpul?
Yes, he's there. He should unmute.
Sir, can you unmute yourself, sir?
Yeah. Dr. Manpul?
Unmute.
Okay,
Yes,
that's
yes,
fine.
yes. Go ahead.
Should I start? Okay, the topic, in the interest of time, I'm just going the topic. Otherwise, it's a great platform to share on this important topic. Are we the no longer forgotten ventricle? So, as we have been hearing, let me put in a sentence what has been talked till yet. The CMR always scores over echo as because it's a multiplanar. It gives
Sir,
not only.
sir, can you share your screen, sir? We
Yeah, I
didn't
have
see your
already. I have,
presentation.
I have done that. Is it okay?
No, sir.
I've already done that.
No. Can you reshare again, sir?
There is option in the below. Just hit that share screen.
Yes.
Yeah, I have done that.
Yes, sir.
Now it's
Yes.
visible?
Just
No.
again, sir. Yes, sir.
Now it's coming. Go to the slideshow.
Yeah.
Yes.
Okay, so CMR we has been talked by very nicely by my previous speakers. It's a multi-planar examination. Not only it gives the information about structure, but it gives definitely about function, which is coming as a gold standard, and more importantly, it gives about the tissue characterization. So as this is being a topic, so I will be presenting three important cases in which RV was involved. To begin with, this was an 45 years old female who had a graduate distension of abdomen, lipidedema, and difficult breathing. Ultrasound showed some fluid in the abdomen. ECG was confirmatory of paroxysmal atrial fibrillation. Echo showed massively dilated RV with normal systolic pressure. So definitely the clinical question was RV cardiomyopathy, and the distinction was the idiopathic ventricular cardiomyopathy versus ischemic. Another subset was ARV versus EMF. So that's how the MR came into the rescue. If we see these images, this is not working. If we see these images, this RV is massively dilated over here. The RV is dilated, and we are seeing that there's a global hypokinesis. And more importantly, we see the apex is massively or is obliterated and impinging on the LV, which is compressed and displaced more posteriorly. And if we see the LG, we can see there's a pan LV enhancement. We can see over here. However, there was no thrombus seen in the apex. With this typical characterization, we could reach a diagnosis of EMF, and appropriate therapy was initiated. Now, coming to the next case, this is a 36 years old man who had complaints of recurrent palpitations associated with dizziness. An ECG and the echo was almost confirmatory of ARVC and planned for RF ablations following an EP study, and ICD was implantation was planned. But however, MR came into picture for confirmation of ARVC. Now to see this case, this is very interesting one. If we see the two chamber and the four chamber views, we can see the large systolic function is preserved, and we see there's a good exertion of the mitral wall over here, and so is the RV function is largely preserved. There is no outpouching to suggest an ARVC. And if we go to the short axis views, we can see they are nicely contracting. There is no hypertrophy, and the RV also appears normal. Now we are dealing with them. So the function is normal, and so is the structure. Now let's see about the tissue that we typically see on LG or in the mapping if you have. So we see the tissue characterization. We see the classical septal LG, what has John Christopher has shown one case of sarcoid, which we can see there's an anteroseptal LG, so is the inferior wall. This is mostly epicardial and the mid myocardial. And to our surprise, we can see there's an enhancement along the LV wall. And when we went back and saw our bright blood imaging, we could find a large paratracheal lymph node which was biopsied, and the diagnosis was confirmed as sarcoidosis. The workup for tuberculosis was negative. So, in spite of going for the invasive treatment, patient was started on medical therapy, and after some time, this inflammation and the clinical improvement was noted, and patient did not require AICD implantation. That's how we changed the clinical management. Had it gone directly based on the other without MR, probably this patient would have worsened, and we could have done more harm than doing good. This patient was is a classical case of sarcoid, which was simulating as ARVC. Now coming to the third case, this was 34 years old female who complains of palpitations. Echo showed of global hypokinesis in the LV, and or is a biventricular systolic dysfunction. Electrophysiology was quite concerned and was quite confirmatory of ARVD. Then why the MR has to come in picture? MR is to confirm in picture to prove the diagnosis and to see the other abnormalities. So if we see this four chamber view, we can see there is there's a global hypokinesis, and we can see there is TR MR. But if we see this classical images which are going through the free fall of RV, we can see some outpouchings. You can we see this outpouching which is persisting both in systole and diastole, and there is some dyskinesis and dyschrony along the LV RV apex. Now, as when we did the tissue characterization, we can see there is an global enhancement along the free wall of RV, and we can see there was some enhancement along the lateral wall. As we came to apex, it was showing some transmurality as well. So these are the four chamber views to show the pan RV enhancement, and the enhancement was seen on the RV side of septum as well. So this showed, and as far as the task force criteria, the new criteria, the end systolic diastolic volume index was more than 146, and the ejection fraction was around 30% of RV. If we have to see the criteria, it was filling all the criteria of 2010 CMR task force. The index volume was more than 36, ejection path, thereby confirming the diagnosis of ARVD. So these were the three cases in which RV was definitely involved, and CMR came to and rescue and provided the diagnosis. In one case, if we see the second case, is clearly showed that it was not ARVD, it was classical a case of sarcoid which was simulating ARVC. If we see the third case, is proved to case to be an ARVC and showed the non-ischemic burden. And if we see the case one, it was a classical case of EMF, which is very rare to see involving a single ventricle, especially the RV. So with this, I could share these three important cases in which RV was involved and MRI came to and rescue. With this, I complete my this presentation, and questions, if any, I think we can take in the end. And thanks to the chairpersons.
Thank you so much. I do believe that the RV, which was not the so forgotten ventricle anymore, we're all back to it. And with CMR, it's definitely given a very comprehensive assessment of the RV. Not only that, I think there's also pulmonary hypertension where RV is playing an important role. You can hear me, right? So the RV is now playing a very important role because the ejection fraction and function of the RV is becoming more important than just assessing doing the cath and checking for the vasculature in patients of pulmonary artery hypertension. So that's another place where RV is becoming very important today. So now we're going to go on to the last talk. And this is going to be Anirudh back again. And I hope you are ready to join now, Anirudh.
I'm ready to join, but I'm trying to share the screen, but I'm not getting I think they need to allow me to share my screen.
Is someone
Sir,
helping?
no, sir. It's already allowed, sir. You can share your screen, sir.
Well, I'm not getting my screen.
No, sir. At the bottom, yes, sir.
Okay, sorry. Okay, so are we getting? My screen is on.
Yes.
Oh, great.
Yes, you are there in the screen.
So my talk is going to be very quick, simple, and I've just got with cases because I think this is something which is very important, and it's more important to see visuals than facts. So basically, CT-FFR, as you know, is a computational fluid dynamic technique to assess the FFR values. It's non-invasive, no adenosine is required, and
We
it
are unable
basically
to see your
drives.
slides. We are unable to see your slides.
No,
Yeah, we are seeing the list of patients.
no. 1 second. Uh, I'm trying to do. One
You
sec.
need to open the CTFFR CSI, the top one.
Yeah. Okay, now
I'm in the
are
window.
you able to see?
No.
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 Oh.
Okay, so while Anirudh is trying to do this, let's just go on with any questions that we may have. So my first question is to Purvi. I mean, Anirudh, you can continue to try sharing your screen whenever you
Right,
get
I'll
to
do
it.
that.
We'll go on. So Purvi, I want to understand that when do you do the cardiac MR in the case of Minoka?
That's a great question. Thank you for asking. So basically, depending on the studies that we have available, we know that the earlier from the the index event of N-STEMI or troponin elevation, the earlier we do the CMR, the better it is. So the best 90%, 90% diagnostic value of CMR is within 1 week of the index event. But the latest studies, some of them are published in JACC Imaging, also show that up to 3 months, you have diagnostic capability up to 75 to 80%. So even after in follow-up, if you can do an outpatient CMR, that would be useful to the patients.
Great, thanks. Okay, so Anirudh, we had your screen. Can we go on?
Yeah. Okay, can you see my screen now?
Yes.
Oh, wonderful. So, as I said, I think what we did, I'm basically going to just show you cases at that where CT-FFR is useful. So this is just a straightforward case where we can see a focal narrowing in the vessel. I can't get my pointer up. Where's the pointer here?
We don't have much time, so just get on.
Yeah, just okay. So focal lesion, as you can see, narrowing in the proximal portion of the vessel, and the FFR along with it. As you can see, a marked narrowing, a drop in the FFR, and you can see color coding is very useful. So you can see it red color means reduced flow. And this is another example where we have that you can see that there is a questionable with the red arrow on the VRT image, questionable narrowing in the vessel, but you can see the FFR on this side is not red, and the FFR values we can measure along the vessel. And we have corresponding images of the cath angio and the FFR values down below, which you can see very clearly that the FFR is not reduced. So here, there was really no actual need to do a cath angio. And this is something commonly is a problem that we have where you have calcified lesions and which obscure the lumen of the vessel, and we aren't able to read this section. And this has been one of the main banes of CT angio. And this is where CT-FFR really helps us, because you can see the CT-FFR in the image below, that below the calcific plaque, it's all red. That means that there's a fractional flow reserve limitation, and you can measure the values there, and you have the cath angios alongside, which shows you the narrowing and of course postplasty, the lesion having been opened up. Here's another example when we see extensive small calcified lesions, slightly poor quality CT angio, we get stuck there. And again, the CT-FFR bails us out. As you can see the image below, that there is a significant narrowing, and with the considerable drop, it's all red below, and corresponding cath angio images, and of course postplasty. Again, another example to show you here, where you have a long segment lesion in the LAD, where calcific and soft plaques and the narrowing and the angio, and of course the FFR image. And here's an example where, again, this would be a non-readable CT angio, one due to the quality, secondly due to the mixed calcific and soft plaques, and an inability to tell us about the extent of stenosis. And there the CT-FFR is showing you that the FFR is good, and that's further confirmed with the cath angio and the invasive FFR. Again, here, similar examples to show which are lesions where we would definitely ask for cath angio in the past because of our inability to read these segments of mixed plaque and questionable luminal narrowing, but the FFR shows you everything is good in the angio. So again, another example, sometimes we do see plaques which are eccentric and we have difficulty to identify. There's some amount of remodeling going on out there. So what is the extent of the narrowing? And again, you have the FFR, CT FFR, which shows things are good and confirmed with the image below of the invasive FFR that it's all good. Here again, as I said, calcific plaques are really a bane in the past, but FFR really bails us out. Here again, showing us that the FFR is good on CT and confirmed on the cath FFR, invasive FFR, that everything is good. Another example to further show you exactly the same thing that I've been trying to show you all along. And there's an excellent correlation that we get. So these are the ones where we used to send them on to cath and they really didn't need to go to cath. And that's really, I think, what I wanted to try and show you, that I think FFR is really making a difference today. And especially for us as radiologists, it's a problem solving technique. When we had inadequate studies, when we had calcific plaques causing difficulty in the CT angio interpretation, an adjunct of CT FFR, which is non-invasive, nothing extra you need to do. It's all from the data which you have already acquired for the CT angio, and it helps us to decide whether a cath is required or no cath is needed. One caveat to be extremely safe is that it has an excellent positive predictive value below 0.7 and an excellent negative predictive value above 0.8. But between 0.7 and 0.8, we still with veer towards caution and would probably ask for a cath angio to be done. But of course, looking at other factors in it. So this is just a quick intro to CTFFR. Over to you, Mona.
Thank you so much. That was great. I think it's a great tool, and it's wonderful to see such lovely images. So, Dr. Rajesh, do you have any questions
Yeah,
before,
I have a
because we are imaging
question
people?
for Dr. Purvi Parwani. The last case you showed about circumflex lesion, thrombus, and the circumflex infarct, would invasive imaging like OCT would have made a difference in diagnosing that particular Minoka?
No,
And the second
yeah, no.
question is about high resolution CMR versus conventional CMR in picking up more yield in, as far as Minoka is concerned.
Yeah, I wanted to, I think this is not the study I wanted to share. Let me just, I wanted to share that, I wanted to share the AHA traffic light signal. And that clearly shows, as you clearly pointed out, that once there is myocardial infarction, we should go for OCT or IVUS imaging to see what exactly is the plaque characteristic and to see if there is plaque rupture, embolization, something that we have seen quite commonly with Indian population, and there have been some studies looking into it. Not all the centers in United States have those capabilities. So typically OCT would have been the course of action, but because that case, it was completely missed on the cath, the patient actually was discharged home and she came back with chest pain. Wasn't much on medical therapy. So she came back with chest pain, and on retrospective analysis of those cath images, it was found. So it was truly a missed case, but you bring up a great point that, the real workup for myocardial infarction actually starts after MI is picked up on the CMR, and it just doesn't stop with OCT or IVUS, but rather goes into more details of, discovering if there is coronary vasospasm with acetylcholine provocative test, or CMD, with coronary functional testing with adenosine and stuff. But only 7 centers in United States do the acetylcholine provocative test. So the entire workup for myocardial infarction, that's another level of talk by itself. But in that patient, it was not done.
Thank you, Dr. Purvi. I just want to ask one question to Dr. Anirudh Kohli. I do not know. Usually, the cath FFR they do, and if suppose there is a borderline lesion, they don't do the stenting or the dilatation, or if they find that the lesion is less than 0.7, 0.8, they go for the angioplasty. So why 2 FFR to be done? Why you say that they cannot do it? Because angiography, that they are doing the FFR in borderline lesions, whether they want to intervene or they do not want to intervene. So in that case, they will do that. So again, after doing a FFR, if suppose they would take up the case, then they will do the same thing. So what is the additional advantages?
I think the answer is in the title of the talk, to do a catheter or not to do a catheter. And I think what our role, we are basically gatekeepers. And let's accept it now. We are becoming gatekeepers to the cath angio using CT angio and CT FFR. So it's really been at the past is that CT angio was basically used to, determine a low probability or medium probability of disease and who should go for a catheter angio. But in that, there were a lot of caveats in the sense that when there were calcified lesions, like many cases that I showed you, those are unreadable. And for those, the radiologist had to veer towards saying a cath angio should be done. And many times the cath angio would come negative. And that's well documented in literature. Anywhere from 30% you will have a negative cath angio. So the whole idea being is to reduce the numbers of negative or towards unnecessary cath angios that need to be performed. So that's where CT-FFR is playing a significant role. Of course, if a lesion is critical on the CT angio, you don't need to do a CT-FFR because it's obvious that the patient needs to go. This is the twilight zone where to decide whether to cath or not cath on inadequate studies or where there are calcified lesions which are impeding your ability to make the diagnosis, whether they should go for cath or not.
Is there a time? Can I have a quick question, please?
Yes, please, go ahead.
My question is to Dr. Tarun Mittal and Dr. Uday because I have been working on this fascinating topic of plaque imaging. So one we did on a CT-based study, another was a mixed study of CTCA versus nuclear medicine. In which Dr. Ashwini Sood was our, we worked together. So my question is one and straight simple. If you find an plaque, a patient coming with an acute myocardial event, and you go ahead with CT coronary angiogram and you find a ruptured plaque or you find a vulnerable plaque, what to do? Patient should go for catheterization or you should be subjecting that patient for an medical therapy. Vis-a-vis, a patient coming for an CTCA and you find a vulnerable plaque. Vulnerable plaque to us is a positive non-calcified plaque, which may or may not show you calcium, which can either be picked by an or PET scan also. So what's the take on that?
So if I may, Dr. Mona, may I comment?
Yes, sure, sure.
Yeah, thank you. So if it's a AMI in the first place, I wouldn't do a CTC at all. I think that patient goes to the cath and whatever the findings come out, then we can have a look at maybe the plaques which we are not addressing then can be classified and looked at vulnerable. The point is both in the vulnerable category where you are working as well as the previous discussion, I'll tell you what is the real world difficulty when we sit actually and see patients. If you find a vulnerable plaque or the other way fine, if there is a diffuse bad atherosclerotic disease, the one which Professor Dr. Anirudh showed, why do we need a CT-FFR? Is it not a better idea to get a perfusion physiological information in this patient? Know how the myocardium is doing rather than going by the FFR, both in terms of vulnerable plaque, because you're not going to cath all those plaques. And why do FFR? Why not get a perfusion imaging done? Whichever be the modality. You can use a CMR, you can use a pattern. Why not have that information? Because that can translate into how we are actually going to manage patients. Thank you.
See, there is no doubt that finally we are going to need both anatomical and functional testing. So, the anatomical testing at the CT level is one, you have the very high negative predictive value, you have the very high positivity in the sense that if you have more than 80%, 90% stenosis, that is easily detected. The problem comes when you have an intermediate lesion. That's where all the questions of whether it is relevant to do stress testing, whether it is nuclear medicine, echo, ECG, ETT, or whether we're going to CT perfusion. It could be stress on CT perfusion, it could be stress, and it could be FFR. So I think that's where it helps. And plaque only helps further in increasing your risk stratification. Because if you have a vulnerable plaque, and now when we're talking about plaques, we're also doing, plaque progressions. We're looking at regression of plaque. If we're talking about LDLs below 50 and how we can actually take to regression of plaques. So I think plaque is becoming very important in terms of what is the final risk and which direction are we going.
Dr. Mona, this suppose there is a borderline lesion on any of the catheter angiography and other things. So why the patient should be subjected for a CT angio or a CT-FFR? What? Listen. Suppose if we do a myocardial perfusion scan, stress perfusion scan, there is no stress-induced perfusion defect, which cardiologists they send us to find out whether they want to intervene the lesion. So why you want to reduplicate the things with FFR?
We never want to do a CT post cath because the whole
Excuse
point
me.
is to do it before cath. You said
Before
if a
cath.
patient has a borderline lesion in cath, the point is that 86% of these patients in the Promise and the Scott Hart did not need to go to cath. The whole point is to avoid the cath. The point is to to
Excuse me,
improve the
sorry for
accuracy
interrupting.
and to make it a non-invasive testing.
Sorry
So
for
between the
interrupting
standard
because
of care
we
and
are
the CT,
we are close
Listen,
to the
Dr.
next session.
Mona.
Can we
But
close
again,
now?
but again, it is an anatomical lesion. But you need a physiological, how much myocardium is in geoparody and all. So that you're talking about
Thank
before
you very
that.
much because we have to go to the next session.
okay.
We have
So
finished
we
your
have to
time.
close the
Thank you
session
very
and
much.
we will take all this over tea with Dr. Mahapatra in Bombay next time.
Thank you very much.
Thank you,
Thank you
ma'am.
so much. Thank you, Dr.
Thank you,
Rajesh. Thank you,
everybody.
Dr.
Thank you.
Mahapatra.
Thank you.
Thanks to all the speakers. Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you everyone for completing the session on time. Now we are starting a new session. A session is a way of life. I invite all chairperson and experts to be on screen.
I'll tell you.
The,
Good afternoon. I'm Dr. Sibu from here. The third talk is the speaker is not there.
Sessions chaired by Dr. Pratap, Dr. Abdul, and Dr. George. Experts are Dr. Vitul, Dr. Pankaj, and Dr. Manikandan. May I request Chair to start the session?
Good afternoon. I think we will start this session with the alcohol paradox. I think this is something which we have discussed many times, but worth discussing again. Alcohol, the paradox revisited. And this will be delivered by Dr. Shanmuga Sundaram, Chennai. Dr. Shanmuga Sundaram, please.
Thank you, Dr. Koshi. I hope you are able to see my presentation.
Yes, please go ahead.
I think the venue of the conference has made Dr. Mohanan to choose a topic like this for me. Not one paradox, there are a few paradoxes with which alcohol is associated. Desire to consume alcohol dates back to millions of years. Even our primate ancestors tasted fermented fruit to get the desire of alcohol intake. Equally so, for many years, right from our Vedic period, we are aware of the harmful effects of alcohol. For the year after year, alcohol continues to be one among the 10 top 10 causes of global burden of diseases. Consuming higher amounts of alcohol is, but what we need to know is whether lower consumption offers protection. If there is protection, is there any paradox in dose response? A standard drink is defined in different ways in different countries, but moderate alcohol consumption is generally considered as 1 drink per day for women and 2 drinks for men. Anything which exceeds this limit is called as heavy drinking. The first paradox with which alcohol is associated with is French paradox, which all of us know about. In spite of consuming very high cholesterol, unsaturated fat, coronary artery incidence or occurrence is quite low in France, which is attributed to intake of wine. For many years, of this J-curve dose rate between alcohol and CHT, and this is a meta-analysis which reconfirms that when compared to a non-alcoholic, a person who consumes small amount of alcohol, seems to be protected against coronary artery disease. But on the right side of this presentation, you could see the J curve does not manifest very well with fatal events, does not manifest very well with women, and does not manifest very well with non-Mediterranean countries. Similar fact was obtained by a larger study, 83 studies, data put together, followed up for 7 years. The so-called J curve existed when all the cardiovascular outcomes were put together. But look at individual outcomes, all-cause mortality. There was positive and curvilinear association. All strokes, positive and roughly linear association. Same thing, whole good with heart failure and non-cardiovascular deaths. Even for myocardial infarction, the protection seems to be for non-fatal MI rather than for fatal infarction. Look at what happened with atrial fibrillation. Even one drink a day seems to be increasing the occurrence of atrial fibrillation. So the alcohol paradox one is moderate drinking may protect against MI, that too non-fatal MI, but not against other cardiovascular events. We know very well alcohol is carcinogenic. Even light drinkers are not protected. We know very well even a small amount of alcohol consumption shortens lifespan by 1 year. Alcohol consumption is an important reason for disability-adjusted life years. So alcohol consumption is linearly associated with cancers, decreased longevity, and decreased DALY. This particular study looked at the confounding variables which can influence the J-shaped curve. When they looked at different confounding variables, they derived the conclusion that the J-shaped curve was existing for men, not for women. Even among men, if there are 3 or more comorbid conditions, the J curve does not exist. And the J curve was confined only to people beyond 40 years, not younger than 40 years. Interheart study, the results are well known to us. The so-called alcohol protection does not exist with South Asians. And worst thing is when the data were dissected, Indians are prone to get higher occurrence of CAD-related events or myocardial infarction, even with a smaller amount of consumption of alcohol. Same fact was brought out by Ambuj Roy's paper on 4,000 people, industry employees and relatives, consuming as little as 14 grams per week would increase the CAD-related events. The supposedly cardioprotective effect of moderate intake of alcohol does not, however, occur with female gender, youngsters, and people with multiple CVD risk factors, and does not seem to be true for all ethnic groups. The worst paradox is with the lower socioeconomic strata. In spite of consuming similar or lower amounts of alcohol, people who belong to lower socioeconomic strata are exposed to higher mortality, as much as 1.5 to 2-fold higher mortality with alcohol consumption. The postulated reasons are many: deprived or less protected, clustering of unhealthy behaviors, different patterns of drinking. Lower socioeconomic strata people try to consume, though rarely. When they consume large amounts of alcohol. It may be inappropriate or inaccurate reporting. Genetic susceptibility may also play a role. This paper looked at what could be the reason for the alcohol harm paradox. Among the various factors which were looked at, average quantity per occasion, it was heavy episodic drinking that was associated with heightened risk with lower socioeconomic strata. Yet another paper, similar conclusion: whenever they exceeded thresholds, people who belong to lower socioeconomic strata were exposed to higher risk of CAD and events. And this is a telephone survey in England. Look at the clustering of smoking, overweight, unhealthy eating, and unhealthy lifestyle occurred 10 times more likely in deprived people than in non-deprived people. So it is very obvious that cardio protection offered with moderate drinking may occur with higher socioeconomic strata, but not with lower socioeconomic strata. Social inequalities do exist and are likely to persist throughout our mankind, and so as the health inequalities. What is our duty? Educate the vulnerable, try to influence the government policies, try to impress upon the government to regulate the availability, marketing, pricing, etc., so that the harmful effects experienced by the vulnerable people are no longer there. The data from our population makes me to consider that the healthiest drink is, of course, water, and we have it in attractive bottles in different brands. Thank you very much.
Thank you, Dr. Shanmuga Sundaram. We will have the questions at the end. Next, we will go to the talk on psychosocial stress and cardiovascular disease, presented by Dr. Sajan Ahmed, my dear friend, my student, and the young quiz master. Dr. Sajan, please. And a very interesting topic.
Good afternoon, sir. Good afternoon, respected chairpersons and dear friends. I hope I'm audible and visible.
Very well visible and audible.
Sir William Osler had said that the main cause of myocardial infarction is the wear and tear of life. I'm sorry, I'm having a bit of wear and tear with the system, I think. So beyond stress cardiomyopathy, what is the relationship between psychosocial stress and cardiovascular disease? That is what we would like to look at here.
There is some background noise.
Yeah, is it okay now, sir?
Okay.
So, as in the case of cardiologists, unfortunately, stress in cardiology is also omnipresent. We read about it and we think about it in wall stress, shear stress, exercise stress test, stress echo, and diastolic stress test. But the thing with the Google literature search is that you can link stress to anything under the sun if you type in the right questions. So, what we will try to answer is what is really psychosocial stress? Does it really matter in cardiology? If so, how does it lead to cardiovascular disease and can we do something about it? The accepted definition of stress is that it is a process in which the environmental demands exceed the adaptive capacity of an organism, resulting in psychological and biological changes that place the person at risk for disease. There is something called eustress or the good stress, which is essential for optimal performance. Homeostasis is a state of equilibrium in a system, and allostasis is a term used to describe a state of dynamic balance which we attain by adapting and coping with stimuli. The wear and tear on the organism that is forced to use these allostatic mechanisms again and again is called the allostatic load. Life stress is an upset that is caused by external influences such as the work environment or home situation. And psychosocial factor is any measurement that potentially relates psychosocial phenomena to the pathophysiological changes. And our subject of interest, psychosocial stress, is in fact the negative response to an emotional or social stimulus. For ease of understanding, we could divide stress, the time frame, into acute within 7 days or chronic of more than 7 days. But it is variable. What is the relevance of stress? Is it this simple? Does the presence of psychosocial stress, with or without conventional risk factors, lead directly to CVD? Or is it something that increases the susceptibility of the individual, or triggers an event, or causes an event, in fact, or aggravate or help in the progression and affect the outcome of the disease? The landmark Interheart study, if you look at all the three major risk factors which had the highest population attributable risk, psychosocial stress was one of them, next only to lipids and smoking. And in 2003, even before the Interheart, the National Heart Foundation of Australia had noted that there is a strong independent causal association between depression, social isolation, and lack of quality social support. And again, in 2008, there was a classic state-of-the-art paper describing the mechanisms. In 2012 itself, there was a call from India for a biopsychosocial model of cardiovascular health. And more recently, stress has been described as a pervasive component of the human experience, and we have to look at the biology of stress. So, how does it create cardiovascular trouble? One way is by pathophysiological mechanisms. Second, indirectly by affecting health-related behavior. And finally, by reducing access to health care. Anything in science, we have to explain the mechanism. So there should be a biological plausibility. And the four major axes are the hypothalamo-pituitary adrenal axis, neural axis, inflammation, and immune system. Now, if you consider the neurology of stress, the major areas involved are amygdala, hippocampus, anterior cingulate cortex, and the prefrontal cortex. And with this activation of these neural centers, there can be cardiometabolic changes, increased sympathetic nervous system activation, reduced parasympathetic system, heightened leukopoiesis, increased inflammation, in addition to behavioral changes. In fact, on functional MRI and PET imaging, there is more atherosclerotic inflammation, greater coronary plaque burden, and increased leukocyte release from the bone marrow in patients who are under high stress. And stress management training has been shown to improve outcomes in cardiovascular disease. Stress naturally leads to hypertension with increased norepinephrine levels and reduced nitric oxide synthesis in hypertensive patients. And it has been shown in systematic reviews and in ABPM studies that systolic blood pressure is overall higher in patients with stress. The major problem with diabetes is related to inflammation, while in obesity there is a positive feedback with increased weight gain, increased depression, high energy food selection, and leptin resistance, in addition to the role of interleukin 6 and the overlap of the inflammatory macrophage and the metabolic adipocyte in obesity. So overall, all these pathways will lead to a road to perdition for this patient. There is, in addition, a role for coagulation system and platelet activation too. And arrhythmias and sudden cardiac deaths have been described in higher frequency in patients at high risk of psychiatric illnesses and chronic psychosocial stress. So what are the kinds of stress? The four major psychosocial stress features are type A personality, and recently there is some stress on type D also, depression and anxiety, work characteristics, and lack of social support. Type A behavior pattern is marked by stressed out, always on the run, hostility, anger, and there is increased catecholamine and sympathetic nervous system activation. Depression and anxiety are both well-defined psychiatric disorders and can occur as a result of CVD. And we know that post-MI depression is a significant predictor of 18-month post-MI mortality. SAD Heart study was one of the earliest studies to look at the effectiveness of antidepressive medications in post-MI patients. Along with depression, anxiety has also been linked to increased incidence of cardiovascular diseases. The earlier Da Costa or soldier's heart has its modern avatar, probably in the form of the post-traumatic stress disorder, which is following combat or intimate partner violence or natural disasters, and has been extensively studied in American soldiers involved in the Iraqi war. And they have found increased cardiovascular risk factors, endothelial dysfunction, and inflammation in these subjects. Three patterns of work characteristics are described to be high risk. One is job strain, second is the controlled demand support model in workplace, and also an effort reward imbalance and overcommitment. Long working hours, more than 55 hours per week, has been linked to increased cardiovascular disease, especially stroke. So how does it do it? There could be direct mechanisms as already described, or it could be behavior related and diet related mechanisms on top of work stress. Social support depends upon the social network, and not only the number but also the quality of support and also the marital status. Women are especially prone to risk due to adverse marital stress. Death of spouse or a significant person also increases the risk of cardiovascular disease in the partner. Following natural disasters like earthquakes, people have noted increased Holter abnormalities, non-dipping of BP, increased blood viscosity, and higher frequency of pulmonary embolism. Unfortunately, we make disasters too. So man-made disasters like terrorist attacks also have shown to increase the incidence of arrhythmias and ICD shocks in patients who are residing near areas. Then race and discrimination, as shown in this Jackson Heart study among African Americans in the US, discrimination could be one reason for increased hypertension. Gender equality or gender discrimination against women is also proposed as one of the factors for increased incidence of cardiovascular disease. Now coming to economics, very, very important area, not just in India but across the world. Economic stress has also been strongly linked, and as shown in the PURE study, education rather than wealth was the factor most strongly associated with the primary outcomes of the study. COVID quarantine blues we are seeing more now, and this could be one stressful factor that we are likely to encounter more. And unfortunately, politics and polarization, as shown in this 2016 paper after the presidential election. And also, two new things we are likely to face is the adverse psychosocial impact with the use of social media, And also the caregiver burden in cardiovascular disease, especially with the increasing longevity. More and more middle-aged people are have to take care of elderly family members. So to conclude, we must remember psychosocial stress as one of the links in the chain that connects the conventional risk factors, genetics, environment, and behavior towards cardiovascular disease. The solutions, unfortunately, are not just medical alone. Definitely, we have to recognize and offer professional help and continued support. In addition, there should be societal changes, educational changes, economic changes, so that the benefit is given to the individual. Finally, be kind to each other and try to reduce stress, and very, very importantly, and be kind to yourself also. Thank you so much.
Thank you, Dr. Sarjan. Do we have the third speaker? Do we have the third speaker?
Sir, no, sir, because he can't attend the meeting, sir, because he is having some network issues. He
So can
can't, we
discussion,
can't reach.
can we have the discussion now?
Yes.
Okay. See, Dr. Shanmugas, listening to your talk, one gets a feeling that there's no controversy regarding alcohol because you have shown such a lot of data telling that there's no benefit by taking alcohol even in small quantities. You are telling in Asia, especially in India, there's no reduction in CVD. If at all there is a benefit, there's no reduction in fatal MI. Even one drink of alcohol increases the prevalence of atrial fibrillation. So there's nothing to look forward to for people who want to drink. Is it the way? You started with paradox and finally there's no paradox.
Thing is like, that inverse association doesn't seem to exist with everyone in the world. The thing is like, people who live in lower socioeconomic status, the pattern of drinking is different. Like, in contrast to Westerners, people around us, you can, look at it, with your own experience. People there abroad, they drink small amounts every day. In contrast to most of us here in India and probably other Asian countries, who would like to drink in the weekends, who consume larger quantity each occasion, and invariably things that go with your alcohol, like, the so-called, accompaniments, probably are responsible for the adverse effects of even smaller amounts of alcohol in our population. I think the pattern of drinking is more important than the amount of drinking.
Okay, thank you. But I think you have the point.
But still, the people who drink, they find excuse in this that it is protective to heart. So you will come across so many people that I drink only one drink or two drinks and it is protective to heart. And it is real very difficult to make them understand that even a smaller amount is dangerous.
The data looks like that. Another phenomenon which is being often said is people in the West, they take alcohol along with their meals, in contrast to what we do here. Like, we consume enough alcohol and then go for food.
Yes.
That is not appropriate combination.
Dr. Manikandan, please.
Actually, I am a bit depressed about this talk. and for so many years, it has been told that about a light drinker or a small, medium or maybe one or two drinks per day has been shown benefit above 45 years, especially in persons with severe risk factors, as well as postmenopausal women. A drink a day can reduce. A lot of reports are there. Okay, I have to revisit it again.
Dr. Pankaj Manohia,
Yeah.
please.
Yeah, I have a question to Dr. Shamacundaram. So, what is the effect on? Does it varies whether you are drinking beer or wine or red wine is more protective? Is any data for that?
I mean,
compared to the Scotch, and you can say
the earlier data, like, it looked like, wine offered protection, but the data which came in afterwards, there seems to be no difference between the different drinks. It is the amount of alcohol and the pattern of drinking that I bought.
Okay.
I think people are all interested in alcohol. What about social stress, psychosocial stress? Dr. Sarjan, I think one important issue is quantifying psychosocial stress is very, very difficult. Always we discuss many of these points. That is number one. Quantifying that is difficult. And second point, though we all tell about that, I don't think we take it very seriously. Though we tell about anxiety, depression, we are all familiar with the trial, the sertraline trial in which they found significant benefit by giving antidepressant. Do you think a routine counseling of these post-MI patients and people with CVD could be beneficial in reducing this burden?
To assess the psychosocial status. But honestly, it keeps changing. The one day you administer the same scale to one patient, after 1 week you administer the same scale to that person in another mood or another setting. The results are likely to be different. So that is an issue inherently. Second thing, the point that you raised, sir, is also important. I think we are yet to catch up, but many centers across the world are incorporating assessment and evaluation of the psychosocial stress as part of cardiac rehabilitation itself in post-MI patients and especially in heart failure patients. So it is an interesting proposition. In fact, even if you look at the Takotsubo syndrome, patients who are prone for the stress cardiomyopathy, where the sympathetic drive is more, almost 30% of patients had some underlying neuropsychiatric disorder, the largest in the TAC registry. So which means to show that these patients may be prone. So, but because not everyone exposed to the same stimulus develops a cardiovascular manifestation.
Controlling stress, I think it is better said than it is very difficult to do it, in fact. So you can preach a lot that you don't, stress is so much around us that even if you are driving safely, you are always stressful that somebody else is going to hit you. So,
yeah, in fact, we stress more on the chronic stress, especially.
Yes, yes.
And there's a thin line between a positive stress and a negative stress.
Definitely.
Positive, we need to have some stress to perform.
Yeah,
I'm sitting here in front of you as an expert and a chair. I have some stress. That is good for performance. But when this positive transforms into negative stress, what is the line? It is difficult to mark that line.
Different people, because the point that you raised is the use stress. That is the optimal amount of stress that is required for optimal performance.
You are right, because if there's no stress, then you'll be very comfortable and there won't be any work output. That is true. You require a comfortable stress, which you call use stress. Dr. Sarjan mentioned about that, which is different for different people. That is, I think, that is something very important. Any other comments?
Sajan, what do you think about this working hours and CAD even? Like, suppose I work for 18 hours a day. I love my work. Am I vulnerable to develop sudden stress or arrhythmias or CAD? How about the data? That are available. Is it work for longer hours or work with stress? What is important?
Very extremely valid point that you raised. Actually, we have data for longer work hours producing more atherosclerotic disease, but that data was stronger for stroke rather than coronary artery disease. But then, of course, when you search literature, whichever way you want it, you can present it. For example, if you have a debate, you can have either literature. But like you said,
and the other way around also. If you are working, you are under stress for 18 hours. Supposing you take a holiday, you may be under more stress that I am not working. So what to do?
Yeah.
So that may again harm you. So what you love, like Dr. Pankaj has said, so it is negative and positive stress. When you love working, you don't have any stress, but it may be long working hours. But if that work is taken away from you, you may be more stressed even if you are sitting idle.
Yeah.
Quality is more for the senior doctors. who do not want to retire, because many feel that if you do not work, it will be very stressful. And
Yes.
that's what which keeps them working for hours together. But if you look at these studies, generally people tell that you don't work for more than, say, 55 hours in a week, 50 or 55 hours in a week. Ideal maybe something like 45. But people who enjoy the work, that rule may not be applicable. If you do not enjoy, even lesser hours of work may be stressful. So I think you have to individualize.
Effort, reward imbalance, and overcommitment. These are two factors that they have mentioned in the literature.
Even overcommitment is also bad. That is what people tell. So I think you have to draw a balance and then go move accordingly.
Like you always used to teach us, sir, the middle path.
Okay. Anything else? I think very interesting two topics, alcohol and psychosocial stress. Do we have any questions in the chat box?
Well, Dr. Sailava, it is easier said than done, but how to control the stress for the cardiologist? Because we are under so much stress, we are doing primaries, angioplasty, daily patients are coming, attendance are demanding, and everything. We are under so much pressure.
Yeah, I think
Pressure of attendance are very much.
Yeah, the
Yeah,
performance,
more
everything.
more than more than the work, it is the other thing,
Yeah,
which has
yeah,
come up in
yeah,
last 10 years, I think,
yeah. Medicine is more of managing attendance than the patients
than
now.
the patient. Definitely.
Now,
I would love to say that things will change in future, but I'm not confident enough.
No, it is going back to worse. In fact, attendance are demanding and uncertainties are so much that you fear that if something is going to happen and attendants are after your neck.
exactly. And Dr. Sajan, we have seen various harmful effects of stress, but there is one advantage of stress also. Mental stress is the best exercise to lose weight. Once you are in a stress, weight reduce dramatically, as I've seen.
But yeah,
But we are not too sure whether weight loss by stress really helps
But
off.
but
That's the point.
some people eat more when under stress, so they can increase their weight also.
It's a both ways.
The
It's
other way
both ways.
around also.
We do not recommend that as a means of losing weight.
Yes.
We should tell people
is to
eat
lose weight.
diet and all those things rather than leading a stressful life. Thank you, Dr. Sajan. Thank you, Dr. Shanmugha Sundaram. I think we had a very, very interesting post-lunch session. I think Dr. Mohan was very good enough to choose very nice topics for the post-lunch session.
Nice to see all the chairpersons and the discussants. Thank you.
Thank you.
Thank you.
Bye-bye. Thank you.
I think you should start the next session also.
Yeah, next is a very interesting session on salt controversies.
Yes.
Still, nothing is clear whether restriction of salt is important. What is the limit? They say Indians consume 3 times the upper limit of
there is lot of
consumption. Indians, but there's a J curve for salt also. I've heard, as with the hypertension. I think in the coming 2 lectures will be very interesting.
We invite Dr. Bansal to start his lecture.
Yeah, thank you very much, Dr. Vittal. And see, this is going to be a debate, and I don't see Dr. Satish as yet. I only hope and pray that he'll join. And now, my job over next 10 minutes or so is to say that, okay, a moderate amount of restriction of sodium is good for heart failure. Now, actually, there is a fairly important article on this topic Uh, that was called the Heart Trial. And subsequent to that, added to it were two editorials. And I picked up this clinical vignette from that, which basically says that if a young woman who has dilated cardiomyopathy presents to you with acute worsening of heart failure, she's controlled and now she's getting discharged.
Rajesh Verma.
Rajan Verma, you advise her to
अटेंडेंस नहीं बताएंगे आधे
you
घंटे का
advise
मतलब
her
मीटिंग
to
करनी
have
पड़ेगी
guideline
आपको
directed
बुला लेंगे आधे
medical
घंटे बाद
therapy. And what do you do about sodium? Do you advise her to follow a diet which is less than 1500 milligrams of sodium per day? You say, okay, you can be more liberal, you can consume say less than 3000 milligrams a day, or you say, okay, go ahead, doesn't matter, whatever diet you take, you continue with that. Now, when we delve a little into this particular topic of sodium, we find that for so many years, heart failure research has primarily focused on drugs and devices. In the same breath, we also understand that the sodium restriction is the most widely recommended self care measure. Our patients are more bothered, particularly in our country. They keep on asking you, kya khaye, and how much of sodium to eat, how much of salt to take, and things like that. There is also clear evidence, relatively more clear evidence, that high sodium intake worsens outcomes. As Pankaj already said, we have parts in our country wherein areas in northeast, where in the tea garden areas where people consume up to 60 to 80 grams of salt a day. So huge variations. It is also known that we do not know the optimum level of sodium to be consumed in heart failure. The recommendations that are there, they range between 2000 to 3000 milligrams of sodium per day. This is in paradox to the fact that the American preventive guidelines recommend less than 1500 milligrams of salt of sodium per day to anybody who is more than 50 years of age. So if you are normal, you can take a lower amount of salt, and if you have heart failure, the prescribed limit is 2000 to 3000 milligrams of sodium. Now that's a paradox in itself. Let us see how a low sodium can affect in a beneficial way and also in a deleterious way. Now, if we go on this left side, there is this talk of positive side effects. So if you have low sodium intake, you decrease the dose of diuretics, you decrease the congestion, all because sodium holds water. You decrease the pulmonary capillary wedge pressure, and you decrease the stress in functional MR, and you lead to a better compensated heart failure. On the other hand, imagine a patient who's on concomitant diuretics. He has an more than required contraction of intravascular volume that leads to decreased baroreceptor firing and leads to aldosterone secretion, leads to decreased renal perfusion, leads to decreased cardiac output, activation of renin-angiotensin system, and also the sympathetic activity, the very systems that we are targeting in our treatment protocols. Now, again, there are points for and against the restriction of sodium in heart failure, and these are highlighted here because it may improve the symptoms, blood pressure, and NYHA class. But as I said, it may activate the very systems that we are looking for to inactivate in patients with heart failure. As we discussed, the guidelines are very broad in this, they are very non-specific. These are the three major guidelines from US, Canada, and Europe, which again say prescribe you a range between 2000 to 3000 milligrams of sodium intake per day. When we go further, there are many other guidelines. Majority of them, if you see 2 to 3, and the level of evidence is by and large not stated, and that actually tells us volumes about the fact that although we have these vague guidelines, there is no very clear or solid evidence for that. And let us see that there are very few articles actually going into this, and there are more reviews and meta-analyses that I could come across, and a number of editorials. And one of the important ones is this, which is from 2018. And as we can see here, this is a meta-analysis from or a review from the JAMA in 2018. Importance is the fact that of over 2,650 studies that were referenced, only 9 actually had patients who could be, analyzed for sodium intake, and there were less than 500 patients in these trials, and none of the studies had more than 1,100 patients. So what was concluded was that for outpatients, there is very limited evidence, and for inpatients, there is absolutely inconclusive evidence. And so overall, there is a paucity of good quality data to say whether you should restrict sodium or you should not. When you go through the details of these studies, you find that majority of the studies showed that restricting sodium did not make any difference, although there were 2 small studies, one from Mexico and Sweden, which said that there was a benefit if you reduced the sodium intake. There are studies which showed worsening, and there are studies which showed equivalent or equivocal results. It has been seen in another review that the mortality rate was lower in the moderate to high intensity group as compared to the low sodium group. So if you really take these people and divide them into those who have a normal sodium, i.e., means ad libitum sodium that is more than 3,000 milligrams per day, milligrams per day, and those who take 1,800 milligrams a day, then what we find is that in those patients in whom there is a moderate restriction, the mortality is lower as compared to those who high consumption or those who take lower consumption. It has also been seen that those who are in a higher NYHA class, sodium restriction does better. If you are less sick, then sodium restriction is more counterproductive. In fact, there are many reviews also speaks volumes about the controversy of this topic. Now, talking of positive studies, this is a fairly positive study which showed that lesser or moderate restriction of sodium to these patients, then the risk of decompensation of heart failure is significantly reduced over a 3-year period. Likewise, there is a moderate reduction in mortality also, although what others have claimed, all-cause hospitalization in this particular study was not reduced, whereas others, as we shall see, have actually hospitalization. Now, the most important study, and I thought my colleague Dr. Satish do is, and this is actually touted as one study which is really negative study by Duki et al. And this came in Jack Heart Failure 2016. And what this has done is it has analyzed data from a trial called the Heart trial. And what they have gone on to see is review a set of about 833 patients. And further, they have done a propensity matched analysis to show that there is a reduction in the heart failure death and heart failure hospitalization composite, which is predominantly driven by heart failure hospitalization in those patients in whom it is a negative study in the form that it says that if you reduce sodium intake, there is a higher uh, rate of hospitalization. Now, this was something surprising, but this is not the only thing. There are several other studies which have made that kind of observation. So it really is an area of confusion. What they've done is actually they've done propensity matched analysis. These clear circles show pre-match comparisons or differences, and the red ones show post matching differences. And as we see, there is a wide scatter. There's a wide scatter in these 36 variables that were used. So this speaks volumes of the nature of analysis that has been done and the reliability of which would be limited. As I said, the first slide that I showed was from an editorial by a gentleman called Clyde Yancey. He's a renowned heart failure guy. And there was another editorial by Scott Hummel, which is highlighted here, and he brought out that there are several limitations analysis because sodium restriction is hard to assess. There are ways, there are repeated questionnaires that you have. These questionnaires need to be repeated twice every 1 week, twice every week, and you are required to make 12-RD analysis of the amount of sodium consumed. But in actual practice, what has been noted is that sodium, whatever you may prescribe, people consume more sodium. And the best way to assess it is actually assessing the urinary sodium, but that is not really done. Then there is a concept of reverse causality, which basically means that those who are sicker patients, they were more likely to be given, or they were more often given sodium restriction than those people who did not need it, and those who were less sicker. And these particularly included people with chronic kidney disease or CVAs. Then another important thing is that those people who have acute decompensated heart failure hospital admission, they are more likely to have readmissions. And the only positive benefit that was found was a reduction in heart failure hospitalization. So if you have patients who've had heart failure hospitalizations, they were the ones who were more likely to be having lesser sodium intake. So they were already more likely to be having greater hospitalizations for heart failure. And then there were some other issues. So there is really a kind of controversy that exists. Now, closer home, this is from American Journal of Medicine 2020 by Javed Butler. And what this says is that there is no doubt, data on both the sides. The data is not so well organized. It is not so well clear. Nonetheless, he says the sodium restriction is routinely recommended and remains a cornerstone for management of heart failure. We already know that there is a more clear relation with hypertension, but even with heart failure, a moderate amount of restriction is advised. Now, what do we fall back to ultimately is, we fall back to currently to things like UpToDate.com and Medscape. So what is the current situation on these two? This is a article on this particular topic, which is about a couple of months old. It is reasonable to moderately restrict the sodium intake of heart failure patients, particularly those who are symptomatic, to 2 to 3 grams per day of sodium. There are trials which are ongoing and which are likely to provide us with more clear answers. And when we go to uptodate.com, again it says that it has been commonly recommended, though the optimum cutoff is not available, but based on expert opinion and limited evidence, it is good to restrict sodium intake to less than 3 grams per day. So, by and large, the best bet in this scenario that we have, as I have tried to show you from the available evidence, is to have a diet that contains 2 to 3 grams of sodium per day. And I thank you for your kind attention. Thank you very much.
Thank you. Do we have the next speaker?
No, sir. Unfortunately, the next speaker has not joined.
Okay. It's not a debate actually because there is no one to oppose.
So we can ask Dr. Bansal to present the other, basis of the sodium restriction also.
I think
yeah, I can actually broadly tell you the fact of the matter is that it is absolutely an unclear area. If you talk in terms of clear evidence, unfortunately there are no clear trials which have prospectively looked at this particular thing. All these that I have shown you are actually retrospective data. They are based out of at best propensity matching, and so it is an area. It is a recommendation which is based on you can say expert opinions with a very poor level of evidence. Nonetheless, it makes reasonable sense that if you're consuming ad libitum salt, that doesn't help much. So there is some amount of it is saying that doctor, I'm taking a statin, so can I consume ad libitum fats? This was the best analogy that I could find out from the scenario, that if you have heart failure, higher sodium is going to be bad. So do I say, can I take it ad libitum? No. The other extreme is also bad, that if you consume too less a salt, you actually cause a reactivation of renin, angiotensin, aldosterone, and sympathetic nervous systems, and that is again counterproductive because those are the very systems that are harming your HFrEF.
I think the relation between sodium and sodium chloride, the salt we are taking, is also important.
This is talking about sodium, 2000 to 3000 milligrams or 2 to 3 grams of sodium, which is approximately 40% of the total sodium chloride. So that goes in conjunction with the standard WHO recommendation to consume less than 5 grams of salt, actually. So 2 grams of sodium is equal to 5 grams of salt approximately.
And the Indians consume almost 3 times the upper limit. They say 5 grams. Asian Indians. So for Indians, restriction should be a must, I think so. Because how much restrict we ask them to do, ultimately they land up in taking more salts.
Yes, I agree, and I did try to touch on that. I was surprised when some of your colleagues and who come from the Northeast. We have a lot of friends from the Northeast. They'll tell you that people in tea gardens consume 60 to 70 grams. There, every 2 in 3 people have hypertension.
So basically in tea gardens, they must be losing the same amount of salt and sweat also.
They must be, but remember the fact that the epidemiological studies from those areas show that 2 out of 3 people, 60% incidence of hypertension in that population.
Because
So,
I find blanket sodium restriction without knowing the occupation of the person again can land the person into hyponatremia sometimes.
sure. See, body has given us sensors. If we are hypovolemic, if we have absolutely low sodium, we will consume more. It is
Two or three other important things to be see how much of heart failure the patient
yes,
whether with mind or second, how much of diuretic he is taking,
yes,
other drugs he is taking, and third very important thing, how much of sodium is excreted in the urine.
yes.
If you ask the nephrologist, they will tell it's a very important thing.
Yes, I actually touched on all these 3 points in different parts of my talk. It is absolutely seen that if your NYHA class is higher, then then a moderate restriction is more beneficial because you're already in a fluid overloaded state. If you have milder heart failure, class 1 or 2, then perhaps a lot of restriction is counterproductive. Secondly, as you rightly said, the best way to assess the sodium intake is to measure the urinary sodium. And indeed, those patients who have associated diuretics going on, there the chances of having a more having a greater volume reduction is higher. And the
Dr. Bansal, one last question before we sum up. You have not touched upon the salt sensitivity and hypertension. Salt sensitivity and hypertension.
I get your point. See, salt sensitivity in hypertension was not exactly the area to be covered in this talk, and so I did not touch upon it. In a way, if you really go by the American College of Cardiology definition of heart failure, so if you talk of effective management of hypertension as taking care of stage A of heart failure, then yes, salt is important, and I should have discussed salt sensitivity also. But I did not discuss because that was not a part of my debate.
So, so what is the final takeoff? So should we take the recommendation of reduced salt intake with a pinch of salt? What do you say?
Reduce salt intake. Oh, these are
A pinch of salt.
beautifully.
We should take this.
If I mean, back in Chandigarh, they used to say you should always read the editorials. And if you go through the editorials on this topic, they are very wonderfully worded, just as you said. Take it with a pinch of salt. Is it worth its salt? There are
2 to 3 grams per day will be reasonable for most of the patients.
Yes, for most of the patients.
I think we have to conclude. The time is up. So thank you. I think Dr. Bansal discussed the topic for both the speakers in detail, so that you have included everything. So thank you, Dr. Bansal. It was a very excellent talk, and we had a very good job. So can we conclude this session, Dr. Gupta and Dr. Manohia?
Yeah, I think we are on time. It was a wonderful session, and we have learned a lot. It's really, I'm thankful to all the speakers and all my co-chairpersons and the expert panel. Thank you very much, everybody.
Thank you.
Silacar, India's #1 CCB in management of hypertension. Myotan CM. Bisotab.
The telescope guide extension catheter pushes past the ordinary, delivering the performance you want for your complex clinical practice. With a thoughtful, deliberate design, Telescope GEC features a coil-reinforced, hydrophilic-coated distal segment contributing to superior deliverability, and a solid round push wire that maximizes force transmitted along the catheter for superior pushability. Our soft TrueFlex tip is made of a soft polymer melted and shaped to precise dimensions, responsively deflecting and providing flexibility. Smooth Pass technology includes 3 components that work together to smoothly channel stents, balloons, and other devices. A tapered distal push wire section, transitioning from a solid round proximal push wire for flexibility. A polymer on-ramp that maintains superior deliverability and channels devices. And the entry port, contributing to smooth device entry and delivery. As PCI evolves, we're delivering the GEC performance you want for your complex clinical practice. Telescope GEC, an extension of you.